Good evening, sir. Just, I'm not able to hear you. I think you are muted, sir. Kindly unmute.
Okay, that should work. Can you hear me now?
Yes, sir. Thank you so much. Once again, it's a honor. We are only feeling bad that you are not here physically with us.
Yeah.
But it's so nice. So nice of you to join today. Today is the final day of our 4-day Congress. We had a lot of sessions, a lot of the dignitaries. Now we are again blessed to have you also. So nice of you.
Well, thank you.
So time now here is people are joining only 8:22, 8:30 is the time we set. So another 7-8 minutes we'll go live, sir, if that is okay.
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 So I have a half hour.
Yes, sir. Half an hour for the lecture, and then another 15 minutes for discussion. So
okay.
Professor Binu Nainan, another neonatologist from India, from southern India, Chennai, will be the moderator for the session. You will see him when he joins. And then
okay.
Dr. Minu, you want to come? I'll just, he is here, but we are not gone live. Live, the stage is.
Sure.
I think
sure.
people are joining.
Good morning.
Good morning. Oh, good evening. Good morning.
Yeah, it is evening there.
Yeah.
Rather, we should say night, isn't it, sir?
Yes.
Good evening.
Yeah.
What time is it there, sir?
It's almost 11 o'clock.
Oh my God. I'm so sorry. I've sincere apologies to keep you.
No problem. No problem.
Like, because if you keep it at other times, no, like people will not join. No? We want,
yeah.
This is a time in India. Like.
Sure. Sure.
Also, Peter Davis is here, and he was like he's in person here actually. So see,
oh wow.
Probably if he joins, then in between after the session, I will turn the camera to him. I don't know. There is another session. That's a record. The Professor Alan Job's talk is there at 9 o'clock after this. Immediately after this. So I don't know where he'll be listening at that time actually. So.
Yeah.
We are having.
Is there a way? Is there a way I can test the screen to make sure that my PowerPoint?
Yes, I will tell. I will hand over to my technical team, and then we will start testing right away, sir.
Okay.
Thank you. Thank you so much once again. I'll write you, sir, after this.
Very welcome. Okay.
Thank you, sir. Just we'll put it live and see. Yeah. No, he wants to share it and see. Yeah. So you want to share the screen, sir? Please.
Yeah, I just want to make sure that it works.
Yeah. Please go ahead, sir. Perfect. Perfect, sir. It's working perfectly.
Good. Good. Okay. Very good.
Yes, sir. So if you want to stop sharing so that when you introduce you can be seen for the, yes. We'll go live in another 5 minutes. We'll go live. Sir.
Okay.
Thank you. Sir.
pandemic, IAP NeoCon 2022, the 13th National Conference of Neonatology Chapter of Indian Academy of Pediatrics, hosted jointly by National Neonatology Forum Kerala, IAP Thrissur and NNF Thrissur. We begin with today's programs with a talk on controversies in nutrition of ELBW infants by Professor Joseph New. Dr. New is a professor, Department of Pediatrics, Division of Neonatology, University of Florida, USA. He will be joining us online. And we are extremely privileged to have with us Dr. Binu Nayanan as the moderator for the first session.
Dr. Binu Nayanan is a current HOD of Pediatrics and Neonatology at MGM Healthcare, Chennai. He is a past HOD at Sri Ramachandra University, Chennai for the 18 years. And he is an MCI recognized teacher for Pediatrics and Neonatology. He is a teacher for DM and fellowship students. We humbly welcome you, sir, to the stage and also to request you to introduce the speaker for the session.
Good morning. Good morning, everyone. Good morning, Dr. Joseph New.
Morning.
And it's indeed a great pleasure to introduce Dr. New this morning for this talk on controversies in the nutrition of ELBW patients and babies. Dr. New is Professor, Department of Pediatrics, Division of Neonatology. He received his bachelor's and arts degree in 1971 at Wisconsin State University and completed his pediatric residency at Johns Hopkins Hospital, Baltimore. MD from 1975 to 1978 and 1978 to 1980 did a postdoctoral fellow in neonatology from the Stanford University. In 1987, he completed a sabbatical from Switzerland. Dr. New has received during his career several honors and awards. He chairs and is involved on national and international committees. Dr. New is active on several societal memberships, editorial boards, journal reviewer, service to the community, service to schools. He is well known for his lectures here and abroad. Dr. New has received many appointments as assistant professor, director, Division of Neonatology, associate professor, a huge list. I think probably at this stage, he is now currently the director of the neonatal intensive care unit at the University of Florida. His interest in teaching and research is in nutrition and the GI environment. It is indeed a great pleasure to welcome him to this morning conference, and we are looking forward for the next 30 minutes for his lecture on the controversies in the nutrition of ELBW babies. At the end of 30 minutes, we will have 15 minutes for discussion and any clarifications you would like. Dr. New, you could probably start now.
I'd like to start with thanking everybody for this very kind introduction and also for inviting me to this conference. Unfortunately, we can't be there in person. I think that you have done a wonderful job in terms of putting together this exciting 4-day conference, and I'm just very pleased that you're able to accomplish this very challenging task. So let me just see if you can see my screen, right? Okay. So I'll be talking the next half hour about some controversies in nutrition of the extremely low birth weight infant. This is a topic that is very broad, and I think it's very difficult to do justice to this area in just 1/2 hour. But I will try to pick out some areas that I think are of major interest to many of us, and we'll just focus on some of those areas. So let's start here, and here's a picture of a 27-week preterm baby. And the question is, how do we nourish this baby? And the agenda for the next 30 minutes will be I want to talk a little bit about the nutritional emergency of.
Sorry to interrupt, Dr. New, but
Yes.
the slides are not seen.
Oh, the slides are not seen. Okay, because I see them here. Let me.
Okay.
Okay, let's go ahead with starting screen again. And
yeah, now we can see. Yes, we can see the screen now. Yes, we can.
Beginning.
Yeah.
Okay.
Yeah, you can go ahead now. Thank you.
Now, let's make sure that we are seeing the same screen.
Yeah, this is a photo. Yeah, this is a growth chart that you're showing now.
Yes. Okay. Okay. So here is the agenda for today. I will talk a bit about the nutritional emergency of the low birth weight preterm infants. Talk about some of the consequences of early undernutrition. And then I'm going to focus on some of the controversies. And these will include intravenous lipids, then enteral feeding, how much and how much advancement, holding feedings during endomethacin and therapeutic hypothermia, checking gastric residuals. And then also I want to talk a bit about personalized nutrition and where we are going in the future. So here's a typical growth chart and a picture of Richard Ehrenkrantz, a colleague at Yale University that I had worked with in the area of neonatal nutrition. And he devised this growth curve where we see the fetal growth from the 10th week, from babies that are in the 10th percentile and percentile for fetal growth. But those babies who are born before 25 weeks, 26, 27 weeks, and 28, 29 weeks, you can see that these babies lag behind. And this is very unfortunate because this is frequently associated with some real problems after the babies get out of the neonatal intensive care unit, as well as having some problems within the neonatal intensive care unit. We see numerous adverse effects associated with poor growth. Now, when we talk about fetal nutrition, we see that these babies in utero have a continuous supply of glucose. Protein is taken up at around 4 grams per kilogram per day, and lipids at 3 grams per kilogram per day. When the baby is born preterm, this is interrupted, and this could be highly problematic. This interruption could be highly problematic. Why? Well, here we look at what a fetus looks like in utero in terms of body composition and energy stores. So here's 24 weeks gestation, 26, 28, and 40 weeks gestation. And here we see the weight, the water composition, protein, lipid, and energy store. So a baby that's born between 24 and 26 weeks gestation has very low energy stores. This kind of an energy store, 123 calories per kilo per day, is what this baby needs in 1 day for survival. If the baby does not get this energy, what begins to happen is that this baby begins to utilize protein from its own body in terms of proteolysis, in terms of energy, to be able to produce energy. And that will not last long. So this is a real problem in these very low birth weight infants. And we have to consider this an emergency, just like we do many other emergencies short of birth. So what are the requirements in most of our babies? There are 100 kilogram per day growth if the baby is fed enterally. If the baby is on total parenteral nutrition, we can attain positive nutrition balance, 60 calories per kilogram a day, with about 0.5 grams per kilogram per day of protein. Minimal caloric intake for weight gain is about 80 calories per kilogram per day if on TPN. So this is important to remember that TPN and enteral nutrition require different caloric intakes, but they are still highly significant and highly important in terms of this baby's survival and subsequent outcome. Now, when we think about this in terms of how much energy this little preterm baby is getting in terms of what the adult would be getting, if this baby is requiring 120 calories per kilogram per day, this equates to this guy here who is doing the Tour de France. The Tour de France cyclist is getting about 7,000 calories per kilogram per day. If you assume that he weighs 60 kilograms and is getting 120 calories per kilogram per day, that is similar to the requirement for this very low birth weight baby. So what happens at 18 months if you have a retrospective study of babies that may have been undernourished? So here is a slide that shows the first week amino acid intake. And this is the mental development index at 18 months. So during the first week after birth, for every 1 gram per kilo per day of protein increment, these babies get an 8.2 point increment in mental development index. When it comes to energy, for every 10 calories per kilogram per day at 18 months, there's about a 4.6 increment in the MDI, mental development index, at 18 months. So during this first week after birth, you can see that there is a major effect on energy and protein. Now, what are some of the problems that we have with lipid intake? Well, if a baby is getting total parenteral nutrition, classically, there's been major concern about hyperbilirubinemia, sepsis, pulmonary hypertension, lung disease, liver disease, and thrombocytopenia associated with lipid intake. All of these have been shown not to be based on evidence. And so I think that we need to get away from some of these excuses that we use to withhold lipids early on. What happens when we withhold lipids to babies? Well, this is very problematic. We need to provide around 2.5 to 3 grams per kilogram per day to try to match the in utero supply of lipid, as I mentioned before. We have essential fatty acid deficiency that occurs very rapidly if we provide lipid-free nutrition to these babies. And we also have to be giving them long-chain polyunsaturated fatty acids because many of these babies are not able to synthesize these long-chain polyunsaturated fatty acids from the shorter essential fatty acids. And these long-chain polyunsaturated fatty acids are very important in brain and retinal development. And lipids are also very important in producing energy. And if you provide enough energy, you can prevent catabolism and spare protein. Now, what about the essential fatty acids? There are 2 essential fatty acids. One is linoleic acid and the other is linolenic acid. The linoleic acid is an omega-6 fatty acid, and this is a precursor to arachidonic acid, a C20 fatty acid. Very important for growth. Linolenic acid is also an 18-carbon fatty acid that is an omega-3. And this desaturates and elongates to a 22 and 24 carbon fatty acid the 22 carbon fatty acid is called DHA, or docosahexaenoic acid. Also very important in terms of brain development. Deficiency of these two essential fatty acids occurs very rapidly, and in 80% of preterms, it will occur after less than 1 week of lipid-free nutrition. And here at the right, we see what it looks like when these babies get the dermatitis associated with essential fatty acid deficiencies. And just imagine what is going on in the brain of these babies when they are not receiving these fatty acids. Now, lipid is a very important source of energy. And as I mentioned before, if a baby is on TPN, that baby needs 80 calories per kilogram per day for growth. And if a baby is getting 8 milligrams per kilogram per minute of glucose, that will supply 39 calories. And if that same baby is getting 3 grams per kilogram per day of amino acid, that will supply an additional 12 calories. But this baby still needs around 30 calories for 80 total. So that calculates to about 3 grams per kilo per day. And this is what we recommend starting in terms of lipids very early and after birth. There have been dogmas that we have been concerned about giving this quantity of lipid, the 3 grams per kilogram per day in the first day after birth, but there is no evidence to support that it is disadvantageous for the baby to do so. And we think that to provide this kind of energy is certainly going to be advantageous for the baby. Now, here's a controversy. When to start lipids, and what about monitoring lipids? There are many neonatologists who will monitor triglyceride levels on a daily, every other day basis very frequently. And that takes a lot of blood to monitor triglyceride levels. But we have found that prolonged infusions of lipids are safe if we give them at less than 0.2 grams per kilogram per hour. It is unusual to see hypertriglyceridemia, although some extremely small babies may develop hypertriglyceridemia. The harm that will do is very well is not very well substantiated. We do not have good norms for monitoring triglycerides. There are different norms that are recommended in different textbooks, but none of these are evidence-based. And so because of this, many of us, including me and our neonatal intensive care unit at the University of Florida, have stopped doing routine measurements of triglycerides in our very low birth weight babies. Now, what about enteral feedings? We have many excuses to withhold enteral feedings. And why do we have these excuses? We are all very concerned that we are going to cause necrotizing enterocolitis. So traditionally, we've withheld enteral feedings in babies with low APGAR scores, babies who have umbilical catheters, who have apnea and bradycardia, who are receiving mechanical ventilation, CPAP, or vasoactive drugs. And we have this concept that TPN is available and we can just nourish babies with TPN for prolonged periods of time. But this is problematic. And again, none of these excuses to withhold enteral feedings are evidence-based. Now, here's a picture of a lady from the UK. This is Dr. Elsie Widdowson. And around 60 years ago, she did some very important studies on piglets, where she found that in the first 24 hours after birth, the suckled pig's duodenum gains about 42% of its weight. This is what is called a trophic effect of enteral feeding. If you do not enterally feed a piglet like this, the intestine does not gain weight. This has been seen in numerous studies in animals, that you have to provide enteral nutrition for this trophic effect to occur. Parenteral nutrition will not provide this. In the mid-1980s, Dr. Alan Lucas and colleagues did some work looking at the plasma gastrointestinal hormones in premature infants. And he looked at 5 different gastrointestinal hormones: enteroglucagon, gastrin, GIP, motilin, and neurotensin. And at birth, we see this level of these hormones. At 6 days, if the baby is not fed at 6 days, these hormones do not rise. If the baby is fed and is well, you can see that at 6 days, these hormones rise dramatically. And even if the baby has respiratory distress syndrome, these hormones rise very significantly. So in order to have this hormonal response, which is important for gut motility, for breaking down various nutrients in the gastrointestinal tract, for insulin production, it's very important that we put some food into the gastrointestinal tract. What happens to the liver if food is not provided and just parenteral nutrition is given? Well, here on the left, we see a liver after 7 days of enteral nutrition. And on the right, we see a liver after 7 days of TPN. And you can see, just grossly looking at the liver, that the TPN liver is very pale compared to the enterally nourished liver. And on H&E stain, you see ballooning of the hepatocytes. And you see fat staining in the liver that is getting parenteral nutrition, and also glycogen staining. So we are actually harming the liver by not providing enteral nutrition. This is a slide that shows what happens to the gut permeability at 15 days after birth if food is not provided in the gastrointestinal tract of preterm babies. And this study was done in the late 1990s by Drs. Shulman and Chandler. And what they did in this study was they had 2 groups of babies. One group was getting gastrointestinal priming, so small amounts of feeding in the gastrointestinal tract, and the other group was getting total parenteral nutrition to day 15. And they provided these babies with lactulose and mannitol. And they measured the lactulose and mannitol as permeability markers in the bloodstream of these babies. And here we see in the blue those babies who were getting TPN. And here in the gray, we see the babies that were getting GI priming. So the permeability was much higher in the babies who were getting TPN. And this means that the junctions between epithelial cells were more open in those babies who were getting only TPN and having no food in their gastrointestinal tract. And this could potentially lead to higher permeability and mucosal antigens getting through to a highly inflammatory submucosa that can cause intestinal inflammation. So having food in the gastrointestinal tract can actually decrease intestinal inflammation. And here's a study that seems to support that. This is a study that was done by Dr. Liza Konnikova at Harvard University and published about 6-7 years ago. And they had 2 groups that they evaluated observationally, retrospectively. One group was fed early, prior to 4 days, enterally, and the other group was fed after 4 days. And here we see some of the adverse outcomes in the early fed group compared to the late fed group. The late fed group had significantly higher adverse outcomes, such as retinopathy of prematurity, chronic lung disease, periventricular leukomalacia. And at 2 weeks after birth, this late fed group also had higher interleukin-8 and other pro-inflammatory mediators in the bloodstream, suggesting that the early feeding prevented the inflammatory response in these babies. What about rate of enteral nutrition advancement? This is a study that was just published a couple of years ago from the UK in the New England Journal of Medicine. And the title of this paper was Controlled Trial of 2 Incremental Milk Feeding Rates in Preterm Infants. One of the incremental rates was 18 cc's per kilo per day, and the other was 30 cc's per kilo per day. And what they showed in this study was that there was no significant difference in survival of these two groups, and no significant difference in terms of sepsis or necrotizing enterocolitis in these two groups of babies, despite one having a very aggressive rate of enteral feeding increase. Now, here's some further controversies, and I just want to ask you some questions here. Do you keep feeding if you are giving indomethacin for ductus arteriosus? Do you keep feeding if you're giving indomethacin for IVH prophylaxis? What about hypothermia for hypoxic ischemic encephalopathy? Do you routinely check gastric residuals? Do you routinely use suppositories in these preterm babies? Let's start out with this concept. This was a study that was done at Baylor University in the early 2000s. And what they did in this was they looked at piglet superior mesenteric artery blood flow during 2 epochs. One was an epoch where the babies were, where these animals were getting enteral nutrition, another where they were getting TPN. And here you can see the superior mesenteric artery blood flow was considerably higher when these babies were getting enteral nutrition compared to when they were getting TPN. Now, what is the concern with giving indomethacin to these preterm babies? Well, the concern that we hear the most is that it causes vasoconstriction. Well, here we're seeing that lack of feeding and TPN is actually causing mesenteric vasoconstriction. So you can actually make the situation worse by not feeding the baby and giving the indomethacin. So most neonatal intensive care units have gone away from this, especially after this study that was done by Kleiman and colleagues. And this was a multi-center study, and the title of this was Enteral Feeding During Indomethacin and Ibuprofen Treatment of a Patent Ductus Arteriosus. What this study showed was that infants required less time to reach feeding volume endpoint if they were given trophic enteral feedings when they received indomethacin or ibuprofen treatment. And again, giving feedings during indomethacin or ibuprofen treatment did not result in increased necrotizing enterocolitis in these babies. What about feeding during hypoxic ischemic encephalopathy and therapeutic hypothermia? Well, several years ago, it was dogma not to feed these babies enterally for those 3 days when these babies were getting hypoxic, when they were getting hypothermia for hypoxic ischemic encephalopathy. Well, practices were different in different countries, and in Scandinavia, they fed these babies, and in the UK, they did not feed these babies. And a paper was written looking at comparisons, and this was a paper in Acta Pediatrica Scandinavia in 2015, showing that really there were no differences in terms of inflammatory responses or necrotizing enterocolitis if these babies were actually being fed. We did a study at the University of Florida, and this was published in Neonatology in 2018. And the title of this was Enteral Feeding as an Adjunct to Hypothermia in Neonates with Hypoxic Ischemic Encephalopathy. And the results are seen on this slide. Minimal enteral nutrition subjects, this was during hypothermia for HIE. These infants had a reduced length of hospital stay. Minimal enteral nutrition was associated with less days receiving parenteral nutrition and time to full oral feedings. Minimal enteral nutrition was associated with a significantly reduced serum IL-12 at 24 and 96 hours. So we saw a decreased inflammatory response. And the brain MRI scores were not significantly different between these groups. So we have started to routinely provide some, at least minimal enteral nutrition to these infants during hypothermia. Here's the question. Here you have this little 27-week preterm baby that I showed you before, and you're on call at 2 o'clock in the morning. And the nurse reports that this baby was being fed 2 milliliters of breast milk every 3 hours, is having 2 cc gastric residuals. What do you do? Well, here's some options. Tell the nurse not to bother you at 2 a.m. Stop all feedings. Ask about the physical exam and perhaps examine the baby yourself. Those are some of the options that we had before. But the bigger question is, should we even be checking gastric residuals routinely? Well, we did a prospective randomized study, and this was published in JAMA Pediatrics about 3 years ago. And the title of this paper was Effect of Gastric Residual Evaluation on Enteral Intake in Extremely Preterm Infants. And again, this was prospective randomized in over 120 babies. And the conclusions and relevance in this study was that among extremely preterm infants, the omission of gastric residual evaluation increased the delivery of enteral nutrition, as well as improved weight gain and led to earlier hospital discharge. And these results may translate into evidence-based practice. We also saw no difference in intestinal damage in the 2 groups that were getting the gastric residuals versus not getting the gastric residuals. What about routine meconium evacuation for facilitating feed tolerance in preterm neonates? Well, there have been several studies that have looked at this, and here's a meta-analysis that examined these studies. And the conclusion from this study was that there was very low quality evidence, but giving the enemas or giving these glycerin suppositories did not improve feeding tolerance in the few studies that are available. Now, in the future, we are going to be looking more at personalized nutrition. Why? Well, here we have 2 babies, a baby born at 23 weeks preterm and the other born at 29 weeks preterm. These are very different little human beings, and their nutritional needs are very different. And we have to begin to think about the fact that one size does not fit all. And if we undernourish or overnourish some of these babies, we could be causing some potential problems. Here's some of these potential problems: NEC, BPD, ROP, late onset sepsis, growth failure. And overnutrition in a baby who's been undernourished may actually result in metabolic syndrome later on in life. So we need to have better ways to provide personalized nutrition for these babies. We use a lot of growth curves, and here's some examples of growth curves. And one of the problems with growth curves is that if the baby begins to fall off the growth curve, it's probably already too late and damage has been done. So what we need to begin to think about is preemptively treating these babies, and how can we use some of the technologies that are available now to be able to provide precision nutrition for these babies so that they don't even have growth faltering, and so that we don't we don't need to play catch-up growth with these babies. Well, we are getting there. And with the use of artificial intelligence and the use of analysis of the microbiome and multiomics, we are getting there. And here's a paper that was published just a couple of months ago. And the title of this paper was Integrating Longitudinal Clinical and Microbiome Data to Predict Growth Faltering in Preterm Infants. And in this study, there were babies that were taken from the network from the UK, and also 3 neonatal intensive care units in the United States. And they integrated data from these different neonatal intensive care units and found features that were highly related to the development of growth failure. And they also found that integrating the microbiome data with certain taxa of microbes, you could predict growth faltering in these babies very early on. So this is one of the first papers using multiomics and artificial intelligence to predict growth faltering. And I think that this will be very important in the future for personalized, precision-based nutrition. And so I'd like to stop the lecture here with some take-home messages. Early nutrition in preterm babies can be safe and efficacious and may prevent significant morbidity. Growth is important, but we also need to consider long-term neurodevelopment and other health consequences. Many of the dogmas that have prevented rapid incorporation of early nutrition have either been disproved, not based on fact, or weak. Not all preterm infants are the same. In the future, we'll need to focus on a more personalized approach that accounts for specific gestational age and degree of illness. And omic considerations, such as the microbiome, will be utilized for these predictive measures. I'd like to thank you for your attention, and I'd be happy to answer any questions, and I look forward to our discussion.
Thank you very much, Professor New, for that wonderful talk. Just to summarize for this talk, you started with the importance of adequate calories, protein, and fat for TPN, and that we should not be withholding lipids. Start lipids on day 1, because in no other way will you be able to maintain the adequacy of the calories. Then you went on to the enteral part of it and the importance of early feeding, both from the point of view of growth, from the importance of feeding on the liver, and even that it reduces the risk of anesia. And the points of no need for looking at residual feeds, no need for enemas, and to continue trophic feeds during indomethacin, ibuprofen, or even hypothermia. Thank you very much for all of that. I leave the discussion for the audience here. Do anybody want to ask a question? If anybody does, please stand up. They'll bring a mic to that. While they ask, can I ask you one question, please? Do you go for the aggressive protein on day 1, starting at 3.5, or would you start at something like 2 grams per kg per day?
This is a little bit controversial, and I am starting at 3 to 4 grams per kilo per day. And I think that there are some papers that suggest that there may be some metabolic imbalances with the use of 3.5 to 4 grams per kilo per day. But I think that it's also important to provide adequate amino acids to these babies. And I think that in the future, we are going to hopefully be able to fine tune the kind of amino acids that are present in the amino acid formulations for providing more precision-based nutrition in the babies. But at this juncture, I think that my tendency is to give more amino acids to these babies, 3 to 4 grams per kilo per day. especially in the smallest babies, because I think that those are the babies who need it the most.
And if so, how much of lipid would you start on the day 1?
3.
Right. So 3 grams of lipid and 3 grams of amino acid on day 1, right?
Yes.
Any questions from the audience?
We are starting lipid of 3 grams per kg per day in extremely low birth weight babies. When we are starting lipid at 3 grams per kg per day in extremely low birth weight baby, is producing lipemic blood. So what should we do for that?
So I think that this is something that you want to be a little bit careful about, okay? Because that lipemic blood may be not because you are giving too much lipid, but because that baby is so highly stressed. And so we really do not know exactly the reason behind that hypertriglyceridemia, but it could very well be because that baby is so highly stressed and still needs that energy and still needs those essential lipids. So I would, at the very most, just decrease the lipid intake if you are concerned about the hypertriglyceridemia to about 1 gram per kilo per day. But I would not stop the lipids.
Any other questions from anybody? Yes,
Thank
one
you.
more question. Yeah.
So thank you, Professor New, for the wonderful talk. So I have 3 questions. If these extremely preterm babies are extremely low birth weight babies, when they are on full enteral feeds, how should they grow? And what is our growth? What should be our growth target when they reach around 36 to 40 weeks? And how that growth affects long-term outcome? And if poor growth is associated with long-term outcome, what are the nutritional interventions that we can do at around 36 to 40 weeks after that to improve the long-term outcome?
Well, I think that at this juncture, we'd like to have them follow the growth curves, okay? And the growth curves that are standard for your region, there are, I think that there are growth curves that are different in different parts of the world. And I would use the growth curves that you have available to you and look at whether it's a boy or a girl, okay? I think that boys and girls grow differently. And there are certainly sex-related differences that we have to pay attention to. In general, the growth that we like to see is somewhere between around 15 to 20 grams per kilo per day. And certainly if you, I think that poor growth may be associated with poor outcomes at a later point in time. Now, I know that there are some studies, and Dr. Nina Modi has done some studies in the UK looking at certain of these babies. And so, for example, if a baby is born IUGR, there is some evidence that pushing those babies too hard may be problematic. And I agree with Dr. Modi that some of those babies, what you do is follow their Z curve, okay? And what you want to get is a Z, it's not a curve, it's just following their own Z score. And their Z score should be flat, not increasing, but flat. But we don't know at this juncture which babies we should really be doing that with. And I'm hoping that within the next few years, we are going to get a better precision-based approach so that we can look at each baby individually and say, this baby is going to require this kind of an approach.
Just one.
Yeah, question, please go ahead.
Hi, just a couple of questions regarding enteral feeding. I think we all agree that human milk is better than formula in these, especially in these preterm babies. Do you all use banked human milk if the mother's milk is not available? And about fortification of feeds, do you all prefer human milk fortifiers, or do you prefer, do you use whatever is available?
So good questions. Most of the neonatal ICUs in the U.S. Follow the American Academy of Pediatric guidelines, and that is that those babies that are less than 1,500 grams get human milk until they're about 1,500 grams. Okay. Now, in terms of whether donor milk actually provides a benefit in all of these babies can be argued. And the reason I say that is that you look closely at some of the studies, I think sometimes we use donor milk and that we sometimes do not adequately fortify that donor human milk. Donor human milk is for these very tiny babies is from a protein perspective, from the various different perspectives, is not adequate for these very low birth weight babies. You don't give them enough calcium, you don't give them enough phosphorus. So they do have to be fortified. What kind of fortification is the best? There are some studies that suggest that the human milk, that the things like the prolacta may be better than giving cow's milk based fortifiers. I am not convinced that those studies are as rigorous as they should be. And there are studies that are ongoing right now that are not supported by the companies that may tell us those results. But at this juncture, I am not convinced that those human-based fortifiers are necessarily better than the cows-based fortifiers. But there are some retrospective, some small prospective studies that suggest that they may be, but none of them is powered for looking at necrotizing enterocolitis with 1,500 or so babies, which is what is required in an adequately powered prospective randomized study.
Thank you.
There's a question, online question. If a mother is producing milk a lot, can they grade up feeds faster than the 30 ml? You said there are comparison between 18 and 30 ml per kg per day. Can we increase it even faster, say 40 or 45 ml? Is there anything wrong with that?
I think you have to look at each baby individually with that. And I know of some of my colleagues in India who have been doing that at a much faster rate, at 40 and 45. And I think that if it works for a particular baby, I don't have a problem with that. I have seen studies that suggest that it does work. And there are some pioneering studies being done in New Delhi that I think have shown that that is possible. So I'm not going to argue that point. I think it is possible in certain individual babies.
Any other question? No. Okay.
Sir, I have.
Yeah. Go ahead.
Thank you, Professor. We all understand mother's own milk is the best. But in case we are not able to do that, do you recommend for a separate preterm donor human milk banking? Is it okay to feed the preterms with term? And if we are going to bank only on preterm human milk, the increased protein content of the preterm milk, is it okay? Will that not be producing some feed intolerance? What's your opinion on that? Because even using donor milk, we are encountering feed intolerance a lot.
Yeah, I think that is a very common finding that even with human milk, donor milk, that a lot of our smaller babies do have feeding intolerance. And you have to be cognizant, especially in those babies who are getting non-invasive mechanical ventilation, with nasal prongs. A lot of those babies have abdominal distension, you have to make sure that you are decompressing those babies in terms of air in their bowel. So I think one of the questions that you were getting at is, should we be using preterm donor milk?
Should we have a separate banking for that? Do you suggest that?
I do not suggest that. I do not suggest that. I think that adds a level of complexity which is very, very high. And I'm not sure if you're going to get the benefit by using preterm donor milk.
Thank you.
You know, yeah.
Do you have any more time? Anyone? We can go ahead. Okay. So I think we still got time. If you are okay with that, we can keep asking questions.
Sure.
See, one of the problems in India is that donor milk is available in certain setups, but not everywhere. And there are these companies which market packed donor milk, which is extremely expensive. So if I start a preterm baby or ELBW baby on donor milk, how long do I need to continue with the donor milk? If the mother is not able to produce her own milk, say, should I continue for a week or 2 weeks or 3 weeks? How long do I do that? And when can I go to a standard preterm formula?
Okay, so the guidelines, the European guidelines and the American Academy of Pediatric Guidelines, they focus at around 32 weeks to 34 weeks corrected gestational age, okay? So I think that that is what is recommended by the American Academy of Pediatrics and also the European nutritional guidelines. But in terms of the use of the donor milk, my question to you is, when you look at the literature really closely, how convincing is it that donor milk actually is that advantageous for the prevention of necrotizing enterocolitis? That is the reason it's usually given, that it prevents necrotizing enterocolitis. But those are all retrospective studies. And the retrospective observational studies are, those are associations. They are not done in a way that we have a really rigorous way to looking at whether necrotizing enterocolitis is actually prevented by the use of donor milk. So it may be that some of these babies are having less feeding intolerance. And with less feeding intolerance with the use of donor human milk, we are doing less radiographs that show these findings that could be suggestive of pneumatosis intestinalis, but we see so many radiographs where the radiologists say suggestive of pneumatosis intestinalis, and then we write that the baby has necrotizing enterocolitis in the chart. So I think that we need to take a step back and ask, what is the definition of necrotizing enterocolitis? How do we actually diagnose this? And we need to come up with better definitions of these intestinal injuries that we see in babies. And necrotizing enterocolitis, I think, is not really a discrete disease. It's a diagnosis that encompasses several different entities. So even though we are making some progress in these areas, I think that we are not making enough progress. And one of the reasons is because we have this diagnosis of necrotizing enterocolitis, which is extremely diffuse and not well defined.
Thank you very much. I think we are run out of time. That was a wonderful talk, and thank you for answering so patiently all our questions so late into the night for you. Thank you very much, sir. Thank you.
Thank you, Dr. Joseph Hughes, for this wonderful session. We would also like to extend our gratitude to Dr. Binu Nainan. Thank you, sir. Next, We have a 45-minute session on what's new in heart-lung interactions, in critically ill neonates by Professor Patrick McNamara from University of Iowa, USA. As the moderator of the session, we have Professor Venkateshan Sundaram.
Dr. Venkateshan Sundaram is a professor, Division of Neonatology, Department of Pediatrics at the Postgraduate Institute of Medical Education and Research, Chandigarh. His areas of special interest are cardiovascular hemodynamics in severe sepsis, myocardial function assessment, and many more. He has several publications to his name and is a recipient of several awards, including the NNF Gold Medal for Best Research Paper in 2006. With much joy, we welcome you to the dais, sir, and also humbly request you to introduce the speaker for the session.
Thank you for the nice introduction. A very good morning to you all. Professor Patrick is there. He's online, I guess. Yeah, so Professor Patrick actually and PGI has a very close association, maybe more than a decade actually, because in 2008 and 9 when actually we all started learning actually functional echo and hemodynamics assessment bedside. So we had actually him for one of the workshops. He came to PGI and a wonderful interaction. And then we have been in close contact with him, and his students are there all over the world. And we are actually fortunate to learn from him. He was in SickKids Toronto for many, many years. And the last 2 years or so actually has moved to University of Iowa. He's a professor in pediatrics, neonatology. He's in charge vice chair of the internal acute care division actually of the internal medicine department. He's one of the pioneers in hemodynamics in neonatology. A lot of publications. If I keep talking, I think the whole day would end. And many chapters and books, many recommendations, many guidelines actually has been part of formulating the guidelines. We are really very fortunate to hear actually from him today about a very important topic. Why the topic is important? Because in neonatology, actually, I think interventions involved in the lung and interventions involved in the heart actually has been the most common interventions next to GA tract, which we heard a little while ago. Second important thing actually is that there are two organs which actually are moving organs in the same compartment. Not any two organs are actually in the same compartment, which are moving also, like the lung as well as heart. The movement makes special interaction and dynamic interaction, which keeps on changing with all the interventions. So Professor Patrick, it's all set. We are happy to hear from you. You can start.
Okay, can you confirm you can see my slides and you can hear me okay?
Yeah, we are able to see. Great.
And you can hear me okay?
Yeah, audio is okay. You can start.
Wonderful. Okay, so thank you so much for the wonderful introduction. It's a real pleasure to be speaking to everyone and all my friends in India. I remember very fondly my visit to Neocon in Ahmedabad. I believe it was around 2009 or so when I had a whirlwind tour of India and got to visit so many wonderful people and so many wonderful places. So what I'm going to talk about today over the next 40 minutes or so is, as mentioned, a topic that we perhaps have not paid enough attention to. And we oftentimes have consider the heart and the lung as separate organs, and many of the symptoms and signs of acute or chronic instability, we compartmentalize them into a heart problem or a lung problem without necessarily appreciating the interaction between both of them. But before we start talking about heart-lung interactions, I just want to review a little bit about, how and where have we evolved over the last 30 years or so, and talk a little bit about the importance of precision in care, particularly with respect to cardiovascular care. As you can see from the graphs on front of you, we've made tremendous improvement in neonatal survival all across the gestational ages. Yet when we think about most of the problems we face on a day-to-day basis in the NICU, blood pressure, the ductus arteriosus, bronchopulmonary dysplasia, interventricular hemorrhage, it doesn't appear that we've made a lot of progress, which is kind of surprising. And I just listened to Joe's talk a lot about individualization of care and the importance of understanding mechanism and so forth. But neonatology is a field that was born in physiology. And from the 90s onwards, we've recognized the importance of evidence, the importance of conducting carefully controlled trials. But when we think about the cardiovascular system, there's actually very little in terms of major progress in how we manage our babies. So if we think about, the simple and most important tenet, what do we define as a healthy cardiovascular system? Well, we really don't seem to know or are not well able to differentiate normal from abnormal. This is a study conducted by one of my colleagues, Reagan Giesinger, who looked at 71 academic centers across North America and reported 17 different definitions used for hypotension. In many centers, not just in North America, but across the world, an algorithmic approach to the cardiovascular system continues to be used. And we continue to have this very obsessive focus on mean arterial pressure and have elevated this to being a disease rather than a symptom. So in that same survey that Reagan conducted, only 20% of centers actually performed echocardiography to try and physiologically characterize the nature of hypotension. And dopamine continues to be the most common therapy used in most centers for most indications. So both of these babies don't look well. They both look sick. Unlike patients who are hypotensive, these babies actually had one on the left-hand side had high blood pressure, the baby on the right-hand side had normal blood pressure. So in many centers, how often do we consider in a normotensive or a hypertensive patient that the cardiovascular system may be compromised? And when we think about the relationship between blood pressure and cardiac output, you can see it's a nonlinear relationship, such that there are patients who are in a hypotensive state but may have preserved cardiac output. But more concerningly, there are babies who have a normal or high blood pressure that may be in a low cardiac output state. Now, we've recognized that blood pressure may not necessarily predict a low cardiac output state, but does recovery of low blood pressure, can we translate that to mean that the patient's problem has recovered? This was a 28-week infant who developed hypotension, blood pressure of 30/19, was treated with hydrocortisone, which made the blood pressure increase, but the lactate continued to rise. The image on the right-hand side is a RV 3-chamber view. And what you can see here, and you don't need to be an echo expert, the right ventricle is profoundly dysfunctional. So this infant had subclinical evidence of impaired RV function with a low cardiac output state, and the administration of treatment specific to the care of heart function led to resolution of the problem. And I think this is an important consideration that in providing care, we may have symptoms that we use to guide us as to whether the patient is well or not well, but the underlying pathophysiology may be very different between patients. And we'll come back to this a little bit later on. So how do we move beyond the status quo? And unfortunately, we try to make something that is incredibly complex, simple. There's nothing simple about cardiovascular physiology. It's incredibly dynamic. Secondly, if we want to have an enhanced approach to care, it's important to focus on not just providing care, but providing the best care, which requires enhanced diagnostic and therapeutic precision. This is not rocket science. If we actually go back to over 600 years ago, this is Philip Paracelsus, who was a Swiss physician and alchemist. And he reported that medicine is not only a science, but it's an art. It deals with the very processes of life, which must be first understood before they may guide it. I think that's a principle that will underpin pretty much everything that we're going to talk about today. So in moving forward, we need to go back. And it's important to recognize the reason we went to medical school was because, we were interested in physiology, biology. It's incredibly important if we are to help neonatology continue to advance, diagnostic precision and the provision of therapies specific to the underlying diagnosis really are the way forward. Yet, when I go across centers across North America and talk to neonatal trainees, almost universally, they report in their fellowship training, there is very little cardiovascular training, education, outside of talking about blood pressure. So we need to improve. So to better understand heart-lung interaction, it's important first to recognize that the goal of care is to optimize cellular metabolism, which is ensuring that the balance between oxygen delivery and oxygen consumption has adequate homeostasis. Oxygen delivery is dependent not only on adequate cardiac output, but having lungs that are well recruited. And if we change the paradigm from a cardiovascular perspective to the importance of tissue oxygenation, heart rate, preload, afterload, and contractility are incredibly important determinants of cardiac output, yet are very difficult to identify clinically. So in thinking about the immature cardiovascular system, it's first important to recognize that it's distinctly different to the adult heart. It has less muscle. The sarcolemma are much more scattered, poorly organized, and their contractility is much less efficient. As you can see from the image in the bottom right, the right and the left ventricular fibers are very interdependent. And unlike adults, we have shunts that have an important modulator role. But even more important is we think of the performance of the heart and how it responds to loading conditions. It also is very different. The graph on the right is the Frank-Starling law. And what you can see across a normal range of filling pressures, the adult heart will augment its contractility. The immature neonatal or fetal heart is flat, meaning that giving lots and lots of volume to increase filling pressures doesn't lead to any increase in the efficiency of heart contractility and may actually cause other issues. At a low atrial filling pressure, contractility will be affected. So maintaining a normal filling pressure is important. More important than the effect of preload is the effect of afterload. Afterload is what you do when you go to the gym. If you bench press or if you squat, you put a load on the muscle. If you look at the two graphs, you can see on the x-axis is wall stress, on the y-axis is contractility. The slope of the line for the newborn is much steeper, basically meaning that increases in afterload lead to a much more significant reduction in contractility to the immature heart. So let's look at our reality. And our reality is, for the most part, in most NICUs, in most countries across the world, we provide symptom-based care. Symptoms like hypotension may receive volume or pressors. Symptoms like oxygenation difficulty or respiratory acidosis may require changes to the ventilator, surfactant, nitric oxide, and so forth. But if we think about all of these symptoms and we put them all together and we think of a unifying pathophysiology, things like PDA, heart dysfunction, pulmonary hypertension, pneumonia, or other forms of lung disease may all give these symptom complexes. And if we just think from a symptom-based approach, we're highly unlikely to move the needle forward. I mentioned earlier the importance of evidence, and evidence is incredibly important, but I feel perhaps the needle has moved too far to the other extreme, in that we now find ourselves paralyzed by, we must wait for the results of the randomized controlled trial, and sometimes following them in a very evangelical manner without actually considering, do we understand the disease? Is the drug relevant? And so forth. And if we go back to the words of Dave Sackett, what is evidence-based medicine? It's the conscientious, explicit, and judicious use of evidence in making decisions for the individual patients. And you've just heard Joe talk about individualization of the care. So in thinking about research, it's important to ask the question first, does the patient actually have the diagnosis that we think they do? Second, do we understand the mechanism? Thirdly, Does the treatment make biological and pharmacological sense? And finally, how we interpret the results. My first interest in echocardiography and the importance of echo came as a neonatal registrar at the Royal Maternity Hospital in Belfast. It was mandated that we perform head scans, and at that point in time, there was really very little emphasis or interest in the cardiovascular system. And I was very much self-taught, unlike what we promote today as the way to train people. But I would say my epiphany, or the first time I really realized the importance of having echo available and helping understand patients, was as a registrar at Basildon Hospital in the United Kingdom. There was an infant who was 3 weeks old, who was having apneic spells and increasing respiratory distress. His chest x-ray showed some cardiomegaly. And my attending, who knew I had some skills of echo, asked me to take a look at the baby. When I put the probe on the chest, I was shocked. The ductus was closed, but I saw this big black shadow around the heart. So I reached out to a gentleman by the name of Mike Rigby at the Brompton Hospital in London, and I told him the story and told him about this big black shadow that looked like a pericardial effusion, and he said, drain it. So I put a needle into the heart and drained 25 mils of TPN. Now, in the year 2022, we don't think twice about this. It's not a big surprise. In the year 1997, we knew very little about the association of PICC lines and pericardial tamponade. And if I did not have that skill on that day, this infant ultimately would probably have had a cardiac arrest and most likely would have died, because nobody would have thought of needling the heart to exclude a pericardiocentesis. So for this and many other reasons, between 2001 and 2010, we started to build the expert model of care, which is based on thinking beyond blood pressure, recognizing that yes, newborns may have an increased risk of congenital heart disease, but more importantly, cardiovascular physiology is complex. And to provide the best care, we need to provide an individual approach to treatment. This led to the publication of the guidelines for targeted neonatal echo in 2011, which were based on two principles. The principle of competence, that individuals need to be trained to perform high quality imaging. And secondly, logic and reason, that the information should only be used in the context of the clinical scenario. Over time, this has now led to the expert hemodynamics consultation, where a trained clinician who has performed extensive training utilizes comprehensive and standardized echo in a very organized way to better understand physiology, formulate an impression and a diagnostic recommendation for care. In 2018, I moved to the University of Iowa, and Iowa is an incredible place. If you look at the graph, you can see our survival rates for infants at the limits of viability between 22 and 25 weeks gestation far supersede any other center across the Vermont-Oxford network, with survival rates up to 60% at 22 weeks gestation and close to 80% at 23 weeks gestation. Yet some babies continue to have problems. How can we move the needle even further? Well, our program has grown. We now have 5 faculty. We perform more than 1,500 consults per year and have a 1-year integrated hemodynamics fellowship. One of the first things we did was to recognize that if we were to provide the optimal care for extremely preterm babies during the transitional period, it's important to recognize that our symptoms are imprecise and there may be subclinical evidence of cardiovascular physiology. So based on an early screening echo, we performed treatment or phenotype specific approaches to care. Babies with progressive PDA shunts got intravenous Tylenol, babies with pulmonary hypertension got low dose nitric oxide, and so forth. What we've learned over the last 4 years is that up to 60% of babies will have subclinical evidence of abnormal cardiovascular physiology. And that doesn't really differ between infants born between 22 and 23 or 24 and 26 weeks. The most common problem in the transitional period was the presence of a hemodynamically significant PDA. I don't have time to go into all of the details, but I just wanted to share this with you before we talk about heart-lung interactions, to really emphasize the importance of having precise information. So we just reported at PAS data from 600 babies over the last 10 years. And despite the fact that in the modern epoch in which we started hemodynamic screening, there were more babies born at 22 and 23 weeks, that these infants were born to mothers who were more likely to have obesity, substance abuse, SSRI use. The babies were born by breech presentation. Despite all these disadvantages, the composite outcome of death or severe IVH, death in the first week, severe IVH, severe grade 3 BPD, and necrotizing enterocolitis were significantly lower in the modern epoch. And after adjusting for these adverse risk factors and protective factors, such as we're doing more delayed cord clamping, hemodynamic screening was associated with an improvement in survival free of severe IVH with an odds ratio of 3.5, really emphasizing the importance of having the right information. So how do we take these principles to heart-lung interaction? And I think there are two things that are first important to recognize is that, one, what are the hemodynamic impact of respiratory interventions? And then secondly, what are the respiratory consequences of heart disease? Well, I think the first thing we need to recognize, and I mentioned this earlier, is that we have this habit of compartmentalizing symptoms, such that low blood pressure, tachycardia, decreased urinary output we consider as heart symptoms, hypoxia, increased CO2, increased respiratory rate, we consider them to be lung symptoms. So when your blood gas shows that the CO2 is elevated, what do most people do? They rush to change the ventilator. We need to increase the rate. We need to increase the mean airway pressure. However, the causes of hypercapnia don't just relate to optimal lung recruitment or tidal volume. If your right ventricle is not contracting and there's very little pulmonary blood flow, you will have hypercapnia. So it's incredibly important to actually move beyond this compartmentalizing of symptoms. I first recognized really the magnitude of the impact of mechanical ventilation on the cardiovascular system with an infant who was born at 27 weeks gestation at a peripheral hospital at Niagara Falls. And I won't forget it. I was a young faculty. This baby was sent to me on a weekend. The infant had a PO2 of 12, the oxygenation index of 50, and reportedly had a chest X-ray, which was normally recruited. And as oftentimes are done, infants who are thought to have pulmonary hypertension, nitric oxide and the oscillator are wheeled out like husband and wife. When I went to echo this baby, I was struck by the fact that I could barely see the left ventricle. And when I looked at flow in the pulmonary veins, it was almost non-existent. So I asked the respiratory therapist to come and to actually take the baby off the oscillator and to start handbagging the baby. And when I did that, almost immediately you could see flow in the pulmonary veins and the left heart started to fill. Recently, we had a term infant sent to us from a community hospital. The baby had received 1 dose of surfactant, had a large subsequent pneumothorax for which a chest drain was placed, and the baby was transferred to us because of progressive hypoxemia. The team started him on nitric oxide, but there was really very little benefit. This was the image that we saw when the baby came to us, and the fellow immediately reached out to her faculty, Reagan Giesinger, because she's noticed that this very odd phenomenon in which I cannot see the right atrium. So the faculty said, okay, have you actually done a chest X-ray on this baby? And when she did the chest X-ray on the baby, you can see this huge reaccumulation of the pneumothorax. And what you see here is the actual atrium collapsing into the ventricle because the magnitude of the pressure was so high in the lung. So they drained the pneumothorax, and now you can see the heart. Immediately after draining the pneumothorax, you now see a right atrium that is completely filled. So this is a very dramatic representation of the impact of mechanical ventilation on the cardiovascular system, but this can happen. Our understanding of the impact of breathing on the cardiovascular system was first described by Stephen Hales in 1733, an English clergyman who also was a physicist. And in a study on an equine model where he placed a catheter in the crural artery, Stephen demonstrated that during inspiration, blood pressure fell. Our understanding of the impact of mechanical ventilation on heart-lung interactions has expanded significantly over the last 300 years, and we now recognize it's a complex interplay between mean airway pressure, tidal volume, PO2, PCO2, vasoreactivity, and heart function. But for the purpose of today, I really want to focus on two or three things. First, what is the impact of mechanical ventilation on systemic venous return? Well, what we know is that systemic venous return is dependent on a pressure gradient between the extrathoracic vessels and the right atrium, and such that during normal spontaneous breathing, as the diaphragm collapses, abdominal pressure will rise and pleural pressure will fall, leading to normal passive blood return into the right atrium. However, during mechanical ventilation, the increase in intrathoracic pressure will lead to an increase in pleural pressure, which will actually decrease the gradient between the extrathoracic pressure and the right atrium. And then the administration of PEEP will then further prevent airway pressure returning to atmospheric pressure levels. Now, where is this relevant? Well, this is going to be most relevant in patients in which preload is important. So infants who have right ventricular dysfunction or a preload dependent circulation, such as the Fontan circulation or hypertrophic cardiomyopathy, are very, very dependent on preload. So we need to be cautious with how mechanical ventilation impacts systemic venous return. But what we don't pay much attention to, and actually there's very little research on, is the impact of intrathoracic pressure on the pulmonary veins and on left atrial preload, but more importantly, on pulmonary venous congestion. Secondly, the impact of mechanical ventilation on pulmonary vascular resistance. The graph in front of you shows on the y-axis pulmonary vascular resistance. And what you can see is that there is an sweet spot in which at optimal FRC, pulmonary vascular resistance is at its lowest. However, if the patient becomes under-recruited, PVR will be elevated. If the patient becomes over-recruited and is hyperinflated, pulmonary vascular resistance will also be elevated. And again, this is particularly important if you elevate PVR because of mechanical ventilation. Diseases like pulmonary hypertension, right ventricular dysfunction, you're going to increase the afterload to the right ventricle and potentially lead to more RV dysfunction. There are, however, situations in which an augmentation in PVR may be beneficial, managing the physiology of high volume PDA shunts or cardiac patients with single ventricle physiology. Thirdly, I think it's also important to recognize that mechanical ventilation initiates a pro-inflammatory cascade. And this may be most relevant in the delivery room. And this has been pointed out by Graham Polglaze and the group in Australia, who demonstrated that during the immediate transitional period after birth, where there are major changes in systemic blood flow, add up to changes in the cardiovascular system, excessive mechanical ventilation leading to a significant inflammatory cascade may further add to compromise flow to the brain and white matter injury. So we've talked that not all heart disease is of heart origin. Well, what about lung disease? This is always of lung origin. In 2003-04, I was asked to develop a process in Toronto for triaging babies for PDA ligation. And one of the things that I learned over the next 4 to 5 years is that after PDA surgery, babies get sick. Their left ventricle fails, they develop a low cardiac output state, and they end up with a chest X-ray that looks very edematous and very sick. And over the next 5 to 10 years, we characterized the physiology and demonstrated that this relates to increased LV afterload, and that a drug like milrinone decreases the risk of post-ligation cardiac syndrome. But we're now in an era where we're doing less surgery and we're sending babies to the cath lab for PDA closure. Is this more benign? This is the baby recently in our center who went to the cath lab for PDA closure. After intervention, you can see that the lungs look clear. His ventilation is low, 1 hour. However, the baby, based on our PDA surgery criteria, met criteria for milrinone, which was started. Despite the addition of milrinone, the baby developed progressive oxygenation and ventilation failure, which you can see is very different from the previous chest X-ray. But during that same interval, the patient was noted to be very hypertensive. So the clinical team increased the milrinone to manage the hypertension. And you can see by 24 hours, with recovery of his blood pressure to a normal level, his chest X-ray improved. So is this lung disease, or actually is this a lung problem that is due to a heart problem? Well, we know that after PDA closure, preload decreases to the left heart, but systemic vascular resistance, and more importantly, left ventricular end diastolic pressure increases. And the increase in end diastolic pressure leads to increase in atrial pressure, leading to pulmonary edema, and provides a biological rationale for the deterioration in lung disease that we see. Adrian Bischoff at the University of Iowa just reported in a cohort of 50 babies that many babies indeed do get a worsening in oxygenation, as you can see in the top graph, and an increase in respiratory severity score. And using comprehensive advanced echo measurements, Adrian demonstrated that after PDA cath closure, these babies develop an increase in arterial elastance and end systolic elastance that was associated with impaired indices of left ventricular diastolic function. Now, I'm not an expert on lung ultrasound, but this case was recently shared with me by Marilena Savoya, who just reported a case series of infants after going PDA closure. And what you can see in their preoperative state, there is something called coLSB lines, and this is pathognomonic of pulmonary edema. 1 hour after PDA closure, you see the appearance of these A lines, which is consistent with resolution of the edema. However, by 8 hours, you can see that there's a loss of the A lines, and the picture again develops pulmonary edema, further providing evidence that this phenomenon that we're seeing after PDA closure is truly lung edema related to increased LV and diastolic pressure. Finally, I want to talk about one probably more controversial issue, which, is BPD an exclusive lung problem? Well, BPD is something that we have elevated to be a very important endpoint in neonatology. We've searched for the magic bullet and we failed. The incidence of BPD has remained fairly static, and actually a recent study from the NICHD Neonatal Research Network actually shows in the last 10 years that BPD rates are higher. So as a hemodynamics clinician, how do we think about BPD? Well, the first thing we recognize is it's very complex. There are many, many determinants of this illness, some of which may be cardiovascular. Secondly, we actually question the purity of this as an isolated respiratory disease. And thirdly, it's important to recognize that infants with BPD have a higher than normal risk of chronic pulmonary hypertension and cardiovascular maldevelopment. So if we think of the determinants of abnormal lung, parenchymal, and vascular development, it's incredibly complex. There are antepartum factors, there are delivery-related factors, and there are postnatal factors, some of which you've already heard about today, that influence both abnormal lung parenchyma and lung vascular development. Traditionally, our assumption is that the lung parenchymal dysregulation occurs first and the vascular occurs second. That may not necessarily be true. But more importantly, if we think about BPD as a diagnosis, it's actually not really a diagnosis. How we define it, and this is Eric Jensen's very good criteria, but they still define it not as a disease, but by the receipt of therapy. If you need oxygen, if you need CPAP, if you need mechanical ventilation, you have BPD. This is the receipt of therapy. And even more importantly, as I mentioned previously, we have elevated BPD to be a very important endpoint. We use it to adjudicate whether treatments are successful or not, or relevant or not. So then it would be very important to be sure that this is a precise definition. And as I mentioned previously, it's a symptom-based definition. Secondly, if we're going to use it to adjudicate therapies, it's important to recognize that these therapies must be biologically plausible, targeted to a population at risk, and the treatments are clinically effective. Is this true? Well, if we think of the most controversial cardiovascular problem that's been associated with BPD, the ductus arteriosus, we've known now for 70 years that PDA is associated with pulmonary hypertension. And if we think of the physiology of a ductus, increasing left to right flow, if it's of sufficient magnitude and prolonged duration, through both excessive pulmonary blood flow and increased PO2, theoretically leads to intimal and medial wall hypertrophy, which increases the risk of pulmonary arterial hypertension. Yet, when we look at our trials, they actually don't show any benefit to BPD, and this has led to a secular movement away from PDA therapy. However, going back to evidence, have we done trials based on defining the problem? No. Have we a true controlled population? No. Are the medical therapies we use universally effective? Probably only in 50%. So it's highly questionable. And this is where we have to be very, very careful in actually using BPD to adjudicate interventions if the interventions are not targeted to the right patients. What's even more important, I would say, is actually what happens when you stop treating the PDA. This is some data from a center in Montreal, in which in 2013, they completely stopped treating every PDAs. And what they found was a 31% increase in the incidence of BPD over the next 10 years. Never in the history of neonatology have we seen things getting worse. I think this is very important data. Now that we send babies to the cath lab, we're actually getting much more physiologic information on the impact of chronic shunts. Some work from Sham Sathanandan in Memphis, where they have a large cohort of infants that go to the cath lab, demonstrates very clearly the infants who have PDA interventional closure at the latest time point, meaning more than 8 weeks, have much higher pulmonary vascular resistance. We just reported this observational study at the PAS meeting. So taking the same center in Montreal, Center A, in which they provide non-intervention approach to the PDA, and comparing to a center that provides early intervention, you can see that in the non-interventional center, the risk of need for postnatal steroids is almost 2 times higher. The risk of a diagnosis of chronic pulmonary hypertension was also 2 times higher. And after adjusting for gestational age and sex, non-interventional approach to PDA was associated with an increased odds of chronic pulmonary hypertension. So is chronic pulmonary hypertension perhaps a better differentiator of this patient population with lung disease? Well, certainly, infants with chronic pulmonary hypertension are more likely to die, and they're more likely to be much sicker with need for tracheostomy, hospital readmission, and so forth. However, the incidence is variable, ranging from 10% to 60% across centers, which may reflect a true variance in incidence, but may also reflect a detection bias, because not everybody is yet ready to believe that we should be screening for chronic pulmonary hypertension. So if we think about the importance of screening, there are really 3 or 4 questions. What's the value? Are the methods reliable? Are the screening thresholds appropriate? And how precise are the diagnostic methods? This is a recent survey comparing 37 centers in the Canadian Neonatal Network and the Neonatal Research Network in the US. 57% of centers screen for chronic pulmonary hypertension, but in most centers, the assessment is subjective, and that may be very important. Only 70% perform right heart catheterization, but up to 86% reported use of pulmonary vasodilators. So let's ask those questions. Is it of value? Well, if we look at these two babies here, the baby on the left was a 24-weeker who at 36 weeks has grade 2 BPD on CPAP with 30% oxygen. The baby on the right was a 22-weeker with grade 3 BPD who was on mechanical ventilation. Yet, when we look at their screening echo, the baby who you expect to have a higher risk of chronic pulmonary hypertension does not. It was actually the less sick baby who had pulmonary hypertension. And this has been reported by Arjun Zidan, who actually demonstrated that yes, more severe BPD is more likely to develop chronic pulmonary hypertension, but it's not an absolute. There are babies with no BPD or mild BPD that still have a significant risk of chronic pulmonary hypertension. How reliable is subjective assessment? As I mentioned previously, that's what most people do. It's not very reliable. This is a study we published about 4 years ago, where we asked 6 experts to look at 60 echoes, 30 from healthy babies, 30 from babies with pulmonary hypertension. And you can see that the kappa coefficient for subjective assessment of RV dilation, septal flattening, and RV dysfunction is almost universally very poor. Is objective quantitative better? Yes, it's better, but it's not perfect. The images in front of you were taken at 15 minutes apart. B and D reflect the optimal images. A and C were images that were intentionally taken incorrectly. And the reason we did this was to show that if the image acquisition is not good, the measurement error may be as high as 30% for RV area. And look here at the eccentricity index, which is an objective measure of septal flattening, almost 2 times higher. So again, the importance of correct and accurate image acquisition. Is 36 weeks the right time? Well, if we say yes to that, we're actually condemning the 22-weeker to wait much longer. Who has the higher risk of chronic pulmonary hypertension? Probably the 22-weeker. So if we choose an arbitrary threshold of 36 weeks, that infant has to wait 98 days. So for that reason, at our center, we will screen babies at 8 weeks or 36 weeks, whichever comes first. Finally, how precise is the definition of BPD? Well, if you look at these 3 cases, which are real cases, all at 36 weeks, all on CPAP in about 30 to 40% oxygen, subjectively, the right ventricle does look dilated and the septum looks flat. The baby on the left actually has got a large left to right atrial shunt. The baby in the middle actually has got pulmonary vein stenosis. The baby on the right has got pulmonary arterial hypertension. So for what looks like a same disease, meaning BPD with pulmonary hypertension, the physiologies are very different. And it may even be more complicated for some other babies. This is an infant born at 22 weeks with severe BPD who did not respond to most of the therapies we use for lung disease. We were asked to see him on day 102. The baby's lungs look terrible. The baby's on NAVA with a very high PEEP in 80% oxygen. And we noted him to be hypertensive. This is the echocardiogram. If you look at the top right image, this shows notching in his pulmonary artery Doppler, which is a sign of elevated pulmonary vascular resistance. However, if you look at the image on the left, what you can see is that the left heart is very dilated, and the indices of left ventricular diastolic dysfunction were uniformly abnormal. So we made a diagnosis of elevated PVR in the setting of diastolic heart failure with preserved ejection fraction. We recommended that they monitored the systemic blood pressure closely, and we started him on an enalapril to decrease his systemic blood pressure and to help with left heart function. Our understanding of the relationship between systemic hypertension and heart and lung maladaptation is really at its infancy. Some work recently conducted by Amy Stanford and Melanie Reyes at the University of Iowa provides some insights. They looked at a cohort of infants with BPD and elevated pulmonary vascular disease. And what they demonstrated was that the hypertensive babies were more likely, as you can see on the graph here, to have higher arterial elastance, abnormal indices of left heart diastolic function, and increase in volume loading to the left heart. In a subsequent study, we looked at the impact of enalapril in a small cohort of infants and demonstrated that temporal improvement in left heart compliance, diastolic function, and volume loading that parallels the improvement in systemic blood pressure and respiratory support. So going back to the baby you just saw, what happened after we gave him enalapril, you can see his chest X-ray improved remarkably. His blood pressure fell and his respiratory support improved significantly over the next few weeks. So it's important to recognize that when we're thinking of BPD and pulmonary hypertension, we got to go back to physiology. Pressure is the product of flow times resistance and left atrial pressure. To date, we have exclusively focused on chronic pulmonary hypertension and its relationship to resistance. But in the cases you've just seen, the determinants of pressure may be atrial level shunt, pulmonary vein disease, or left heart phenotype, all of which require a unique approach to care. Finally, this is highly relevant as we move forward in neonatology. We've started to learn that preterm babies are growing up to be adults with a 17-fold increased risk of heart failure, an increased risk of ischemic heart disease, and also pulmonary hypertension. We've learned that adults born preterm have ventricles that are smaller, stiffer, and got myocardial fibrosis. Yet, when we think about the gap between the NICU and adulthood, we have really no idea as to the neonatal and environmental modulators of cardiovascular or pulmonary remodeling. So in building the bridge to adulthood, how do we move forward? Well, we must recognize that prematurity is a state of being and not a disease. It's important to characterize the natural history of heart and vascular development, not just in sick babies, but also in well babies, determine the modulators of mal development, and look at the impact of both neonatal and beyond neonatal interventions. Tools like MRI in the NICU will help us better understand heart and lung development. Artificial intelligence will provide much better insights into when babies get sick. So in conclusion, a symptom-based approach to care is imprecise and leads to therapeutic non-judiciousness. Whether it's the heart or whether it's the lung, to select the right drug or right intervention at the right time requires a high level of understanding of disease, characterizing the ambient physiology, and understanding how drugs work. With respect to heart-lung interaction, it's important to better characterize the modulators of abnormal cardiovascular and respiratory maldevelopment and how they relate to each other. And the growth of neonatal hemodynamics as a subspecialty offers great hope for the future. So I'd like to thank members of the Iowa hemodynamics team, all the nurses and all the wonderful people in our program to help provide such exceptional care to our babies. Thank you very much.
Thank you, Professor Patrick, for the really exhaustive coverage of hemodynamics in general and cardiovascular hemodynamics in particular, and the impact of lung and heart on the lung. I think for the audience sake, actually, I thought that the key points which we got is, one is a terminology would use very nice, hemodynamics clinician, which is an important take-home message. I think actually many of us work in hemodynamics, so on clinical neonatologist. It's a new term for us. You told us actually that, as in the last slide, the first point is that don't treat the symptom complex, look at the underlying pathophysiology, look at the whole spectrum, understand the whole process, and then manage. That's a very important key point. And you give multiple examples that where many lung diseases like BPD and many other problems has a cardiac origin. And with the cardiac problems, whether it be acute problems or chronic problems, has a lung involvement. You showed some examples of pneumothorax creating a problem in acute setting. You showed an example of an earlier days of an TPN-induced effusion causing actually a cardiac problems. So very wonderful examples. I'm sure all the audience would take home these messages. I would open the talk for questions and comments from the audience. I'm sure a lot of questions and comments. I just have one or two questions before to start with. In LMIC countries, developing countries, small for date is a big problem. Like say, if you look at our own place, around 30-40% newborns born there are IUGR, small for date neonates. And there are data coming in actually on small for date newborns, whether it be a BPD as an incidence, whether it be actually cardiovascular function, right ventricular function, pulmonary artery hypertension and all. So what is the current actually evidence on this small for date newborns? And the small for date newborns also have polycythemia as a very common problem, because nearly 40-50% of the newborns, at least in our center, they actually have polycythemia, higher hematocrit, and which can lead to sort of vascular stasis and can increase the pulmonary artery pressures and can create problem in the management. So that's one question from my side. We can look for a response and we can take us from the audience then.
Yeah, that's a great question. I think, you know, the infant who is born growth retarded has, as you have correctly appreciated, suffered chronic intrauterine hypoxia ischemia, potentially due to placental maladaptation or other factors. And what we know from a cardiovascular perspective is that these babies, they don't have a single phenotype. So you're hearing this over and over again. You know, I think the main message I wanted to share with people today, a little bit of shock and awe tactics, that we're dealing with something very complex and you can't make it easy and you can't guess it. And to provide, you know, the highest level of care, it's important to recognize these distinct differences. So within the IUGR patient population, there are also different phenotypes that we've seen. There are some infants that present with a kind of a classic pulmonary vascular disease that can present very early, in which it's really important to recognize the potential benefits of early pulmonary vasodilators and so forth. But then there's a second phenotype that present with kind of abnormal left heart development that may present like some of the case I presented there at the end. They present with more of a pulmonary venous or post-capillary phenotype, in which pulmonary vasodilators actually will be very harmful in that situation. And the approach should be to optimize left heart function. And in other infants, prolonged exposure to kind of left to right PDA shunts, which if left untreated, may lead to then a late secondary pulmonary hypertension. And again, we've seen all of these different phenotypes present in very, very different ways. And I think, you know, I think the key thing is to recognize that what might look as a similar clinical presentation, meaning respiratory deterioration, a problem with your blood pressure, could have many different reasons for that. And neonatology has to embrace this. And to embrace this, we need to have individuals in the NICU that can perform comprehensive and standardized echocardiography. And I think you spoke about the hemodynamics clinician, and that's what we talk about now. We don't talk about targeted neonatal echo. We talk about the hemodynamics clinician, an individual who has received extensive training, not just in echo, but in cardiovascular physiology, pharmacotherapeutics, who has a lot of exposure to seeing lots of sick babies. They have a unique expertise, and this has formed the basis for our 1-year post-fellowship kind of subspecialty year.
Dr. Patrick, good morning. Thoroughly enjoyed your work and lecture. Just a small query from our side. You talked about post-device closure pulmonary edema occurring in neonates who underwent a device closure. Does it also not occur following medical closure? Or is it the medical closure is so gradual that your pulmonary edema is not seen so often, but we see it often with your abrupt device closure? Thank you.
That's a great question. Nobody has reported post-medical closure edema. I believe the reason that we see it after device closure is that the infants undergoing PDA closure, interventional or surgical, have a more prolonged shunt. So their kidneys have been theoretically exposed to chronic hypoperfusion. So you have an upregulation of the renin-angiotensin system. So when you then eliminate the ductus, you have a much higher level of circulating angiotensin 1, angiotensin 2. So you develop this post-closure hypertension. If you look at the medical babies who have early treatment in the first 1 to 2 weeks, typically when the ductus closes, the blood pressure normalizes. It doesn't increase. So it's a fascinating question. We have not noticed it. That doesn't mean that it's not possible. We don't know when we give medical therapy, does the PDA close in 2 hours or does it close in 3 days? Because we typically give a course of therapy and we don't check in between. So it's biologically possible, but certainly I think the main message I wanted to share with you is that when you close these babies with device, it's not completely benign, and the respiratory deterioration is most likely to be related to this systemic hypertension. And you need to treat the hypertension, not keep increasing the ventilator.
There's one more question.
Patrick, Sony from Sidra Medicine, Qatar. We only do the device closure of the PDA, not surgical ligation. And yearly, I think about 6 to 7, sometimes 8 device closures happens across the Qatar, not just in our hospital. All the babies come to our hospital for device closure. The observation is we have not seen as much post-device closure, post-syndrome compared to when I was working in UK, where post-surgical ligation, there were more such syndromes. And my observation and talking to the cardiologist there is, but the device does not close the PDA completely. There is some residual stent is there, which takes about 8 to 12 hours or even up to 24 hours before duct fully closes. So there is a bit of a gradualness here as well compared to what was described earlier in the medical. What is your observation of, about the device closure in your unit compared to surgical ligation?
I think that it's a great question. The one thing I can tell you for sure is, unlike the babies who undergo PDA surgery, the dramatic post-ligation cardiac syndrome with a lot of hypotension, a lot of instability, we don't see that. The case I presented in question is the most likely phenotype we see, this hypertension with this progressive respiratory deterioration. I think the key question, just like in PDA surgery, is how old is the baby when you're doing the intervention? And if you're closing the duct at 3 months, the afterload to the right ventricle is already high because of chronic PDA, pulmonary vascular resistance, and so forth. So those babies tend to not get sick from that perspective. But if you're closing the PDA early in a very tiny baby, and again, most of our babies that we close are 22, 23 weekers that are probably 2 to 3 weeks old. So they fall into that kind of much more vulnerable period, and again, our ethos from a PDA perspective is that if you have a bad shunt, and again, we're very selective in who we treat, the earlier you eliminate it, the better. So we don't like to leave babies with shunts for more than probably 3 to 4 weeks maximum. And I think the big plus for us is that our rates of chronic pulmonary hypertension, even though we have 60% survival at 22 weeks, 80% at 23 weeks, our chronic pulmonary hypertension rate is less than 5%. And I believe it's because we're not leaving babies exposed to bad shunts for a very long period of time, causing pulmonary vascular remodeling and so forth. So I've kind of answered your question in a roundabout way, but we've seen the same thing, that if you're doing a very late closure, you don't get much instability. And if you're, I would recommend that you look at early closures in the first month versus beyond the first month, and look at the respiratory course afterwards, and you probably see that there are some differences there, you know. So
thank you.
So before closing, I should ask one small question, Patrick. In pediatric practice, if you go to the PICU, intensive care unit pediatrics, they look at the intra-abdominal pressure very commonly. So like many centers in India, they do actually follow the intra-abdominal pressure, because higher pressure in the intra-abdominal area can compromise the lung inflation and then can eventually compromise the cardiac output. Premature newborns tend to have like NEC, abdominal distension, or feed intolerance, tend to have a descended abdomen. But we don't see much of centers looking at intra-abdominal pressure or trying to bring down the intra-abdominal pressure to make the lung ventilation effective and cardiac output effective. What is your take on this?
Yeah, it's very interesting concept. And I equally am not aware of any center that is monitoring abdominal pressure. All I can share with you in my personal practice over the years, absolutely, the compartment syndrome that you can get with NEC or other causes of severe elevations in intra-abdominal pressure can have a huge impact on mechanical ventilation. And, you know, if you have an infant who you have an intestinal problem that is forcing you to keep increasing the mechanical ventilator to counteract elevations in abdominal pressure, decompressing the abdomen is one of the things that we do by placing in a drain or decompressing the intestine. Certainly, we've also seen that that has a huge impact on the cardiovascular system and may also impact, you know, afterload to the left ventricle, preload to the heart, and so forth. So absolutely, you're absolutely right. There are things going on there that are really important. But outside of our eyes and hands assessing, that's about it that we do at this point in time. And it's very, very non-scientific, but there are definitely babies that you have to decompress the abdomen. That's all I would say.
Thank you once again. Thanks for the really wonderful lecture. I think no more questions, so we should call an end to this talk. Thank you once again, Patrick, to be with us. Thank you.
You're very welcome.
Thank you, Patrick, for joining us.
Thank you.
And for sharing your views on the topic. We extend our sincere gratitude to Dr. Venkatesha Sundaram for his contributions to the session. Kindly note, KL46W0092, a black Kia Seltos, is obstructing the pathway. Do take care of the matter. I repeat, KL46W0092, a black Kia Seltos. Thank you. Next, we begin with a 45-minute session on noteworthy publications of last decade and implications for practice by Professor Smita Sardesai from USA. And to moderate this session, we have Dr. Mangala Bharati joining us.
Dr. Mangala Bharati is Professor and HOD, Department of Neonatology from Madras Medical College, Chennai. His areas of special interest are perinatal interventions, milk banking, research methodology, and many more. We humbly welcome you, sir, to rise.
Yes. So good morning, everyone. So I think we're going to have another interesting session. We all know that we do come across hundreds of publications every year. Though each and every publication is important and keeps adding some or other to our existing knowledge on understanding the disease process in the babies. It's not many papers do not reach the level where they make a significant impact on the way we manage babies or approach babies. So we do have with us Professor Smita Sardesai. Professor Smita Sardesai is a clinical professor of pediatrics and an associate director of neonatology at Keck School of Medicine, USA. She has completed her medical education at Goa Medical College, University of Bombay, India, and her graduate training in pediatrics at King Drew Medical Center, Los Angeles, and fellowship in neonatology at USC. She's a full-time faculty at USC since 1993. A dedicated educator, she has obtained her MSc degree in medical education from Rosier School of Education of USC in 2004, and is an associate program director at the USC CHLA Neonatology Fellowship Program. She is also medical director of NICU at the Good Samaritan Hospital, Los Angeles, and chairman of pediatrics at the Good Samaritan Hospital. Her research interests include prevention of acute and chronic lung injury, neonatal skin and birth injuries, pulmonary hypertension, and use of nitric oxide, nutrition and feeding disorders in neonates. So we welcome Professor Smita Sardesai. Ma'am, over to you. We're ready to listen to you.
Good morning, everybody, and thank you for the kind introduction. This talk that I'm going to give today, I have basically found some interesting articles that are present. I'm not going to go back to 10 years. Neonatology is very dynamic, and therefore I've selected some articles just from the last year or two, so as to bring you up to date with some of the things that we may use in our current practice. Can you guys see my slides? So I have nothing to disclose. So my first topic is on long-term outcomes of infants exposed to antenatal corticosteroids. As you know, administration of antenatal corticosteroids has been among one of the most important considered significant therapies to improve neonatal outcomes. However, some animal studies have found that there are harmful neurologic outcomes associated with antenatal corticosteroids. So this article by Ninan K had the objective to conduct a systematic review and meta-analysis of long-term outcomes associated with preterm exposure to antenatal corticosteroids compared with no exposure in all children, as well as children with preterm and full-term births. This is a systematic review and meta-analysis of 30 studies, more than 1.2 million children with a follow-up more than 1 year. Primary outcomes were identified as composite of any adverse neurodevelopmental and or psychological disorder. Secondary outcomes were specific measures of psychological disorders and neurodevelopmental delay, anthropometric and metabolic and cardiorespiratory outcomes. In extremely preterm birth, exposure to single course of antenatal corticosteroid were associated with significant reduction in risk for neurodevelopmental impairment and cerebral palsy. We all know that from all the other previous publications as well. In late preterm birth, however, exposure to antenatal corticosteroid was associated with high risk of investigation for neurocognitive disorders. And in full-term birth, exposure to antenatal corticosteroid was associated with higher risk for mental or behavioral disorders and prone or suspected neurocognitive disorders. One of the limitations of this study was included limited randomized control data and possible bias associated with observational studies. Given the fact that more than 25% of the fetuses who are preterm exposure to antenatal corticosteroids are born at full term, this study provides some new insight into potential adverse effects of antenatal corticosteroid exposure. There is an excellent editorial published by Shrivan in Arch Disease Child regarding this use of antenatal corticosteroids. So what we already know on this topic? We know that antenatal corticosteroids are associated with health benefits in preterm infants. And in neonates exposed to antenatal corticosteroids were delivered at or near term, health benefits are of less significance, and there is concern regarding potential long-term adverse outcomes. As you can see, I have listed some of the most recent articles published in 2019, 2020, and in 2022, all looking at neurodevelopmental disorders among term and late preterm infants exposed to antenatal corticosteroids. Why is that? In a normal pregnancy, there is endogenous corticosteroid that is produced by the mother, does not cross the placenta, and therefore does not reach the fetus. Fetus also makes its own corticosteroid, which induces the maturation of various organs, but that does not reach the fetal brain because it is blocked by the 11-beta hydroxysteroid dehydrogenase 2. When we give synthetic steroids to the mother, being more potent, it bypasses the 11-beta hydroxy barrier and reaches the fetus. Not only does it cause effect on the lungs, it also crosses the brain and has significant effect on the brain as well. So that is the understanding behind why these long-term neurologic abnormalities happening in these babies exposed to antenatal corticosteroids. So take-home message from this study is the conviction that there are only benefits should not be cast in stones. As you can see, recent publications raise issues of possible harm of antenatal corticosteroid. These studies highlight the importance of follow-up at least through school age to ascertain the efficacy and safety of perinatal interventions. And recommendation to administer antenatal corticosteroids to more mature infants may need to be re-examined until sufficient safety data are available. Just for food for thought, there is an excellent research publication by Alan Job in Pediatric Research on antenatal corticosteroid reappraisal of the drug formulation and dose, in which the authors have defined the minimum corticosteroid exposure for fetal lung maturation using sheep and monkey models. And they hope that these results generate new clinical trials of antenatal corticosteroid at much lower fetal exposure to antenatal corticosteroid, possibly maybe even given orally to the mother with a fewer risk for the fetus. Worth the read, and maybe generate some more publications coming out from various people. Points to ponder. What are the optimal dosing, strength, and duration of fetal exposure for antenatal corticosteroid? Because the same dose is given to all the mothers, irrespective of their weight. What is the risk of neurodevelopmental impairment after antenatal corticosteroid exposure in late preterm and term infants? And what about intraamniotic cortisol, as this may retain efficacy in the lungs, but not have much effect on the fetal brain? Next article that I chose for you guys today was the risk factors for spontaneous intestinal perforation. SIP is an important neonatal disease and has numerous complications. As you know, metabolic acidosis, hypotension, sepsis, surgical intervention, and the outcomes of neurodevelopmental abnormalities when they survive. Infants with SIP need longer prenatal nutrition with intravenous nutrition, longer hospitalization, and also have higher mortality. It is important to lower the risk for SIP as much as possible to avoid all these complications in this baby. And a reasonable way of doing this is to avoid predisposing factors whenever possible. These authors are Notovic, published a most recent article in Journal of Pediatrics with the objective to determine if antenatal variables affect the risk of spontaneous intestinal perforation among preterm infants when prophylactic indomethacin is used. This study was a single-center retrospective case control study of infants less than 29 weeks of gestational age. SIP was defined as acute abdominal distension and pneumoperitoneum without signs of necrotizing enterocolitis at less than 14 days of life. Each case was matched with two controls for gestational age and birth year. Maternal and infant data were abstracted until the SIP or equivalent day for controls. Univariate analysis were followed by adjusted conditional logistic regression and reported as odds ratio and 95% confidence interval. What did they find? The mothers of cases were younger, more often delivering multiples, and had less abruptions, but did not differ in intrapartum betamethasone, magnesium, or indomethacin usage. Prophylactic indomethacin was given on day 1 to 99% of the infants. SIP was associated with shorter intervals from last betamethasone dose to delivery, 46 hours versus 96 hours in control. Dopamine use, volume expansion, higher grade intraventricular hemorrhage were related postnatal factors. The adjusted odds of SIP increased by 1% for each hour decrease between the last dose of betamethasone and delivery, and with multiple births. So they concluded that antenatal betamethasone given shortly before delivery is associated with an increased risk of SIP. Potential interaction with medications such as postnatal indomethacin needs study. There was a similar article published from Canadian Neonatal Network of over 4,000 preterm infants with birth weight less than 750. They reported that combination of antenatal corticosteroid with prophylactic indomethacin increased the risk of SIP compared with antenatal corticosteroids alone. And interestingly, in their subgroup analysis, the exposure for less than 7 days with the prophylactic indomethacin co-exposure was associated with significantly higher odds of SIP. Whereas with the latent antenatal corticosteroid, which was more than 7 days before delivery, with prophylactic indomethacin co-exposure was not. Mortality was lower among those not exposed to antenatal corticosteroids and received prophylactic indomethacin compared with those with no prophylactic indomethacin. There was also another article of interest on this similar topic. I just bring it out. This was by Prasad. They looked at the spontaneous intestinal perforation associated with premature twins, and they found that being twin had an increased risk or odds of SIP 29-fold higher than singleton. So there's something to kind of think about when we manage these babies who are exposed to antenatal corticosteroids. So what do we already know? SIP is associated with early use of postnatal steroids administered to prevent lung injury or prophylaxis for early adrenal insufficiency and in arterial pressure support concurrently with indomethacin. What do we learn from this article? SIP risk is exacerbated by select forms of polypharmacy. Because neonatal care of ELBW infant is commonly standardized, the habitual combination of risk factors potentially amplifies the risk of SIP. You heard in 2 previous talks about how care should be individualized for each of the babies. Our challenge lies in understanding how these drug interactions leads to harm. No one size fits everybody. So next article that I chose today was evaluation of sepsis in preterm infants. The current guidelines from American Academy of Pediatrics and Committee on Fetus and Newborn recommends that infants born less than 35 weeks of gestation by cesarean section because of maternal non-infectious illness or placental insufficiency in absence of labor, attempts to induce labor or membrane rupture before delivery are associated with relatively low risk of early onset sepsis. In these cases, physicians should consider the risk-benefit balance of early onset sepsis evaluation and empiric antibiotic therapy. The authors, Chiruvula, had an objective to examine the utility of blood cultures and identify the factors influencing the decision to perform them in preterm infants at lowest risk for early onset sepsis. What is the yield of these blood cultures done in these babies? So this is a retrospective cohort study of 284 infants at 23 to 34 completed weeks of gestation born by C-section for non-infectious maternal or fetal indication in absence of labor, rupture of membranes at delivery with no intraamniotic infection. Early blood cultures, which were done less than 4 hours after birth, were obtained in 56 of the infants, and their mean gestational age and mean birth weight were significantly lower compared to the infants on whom early blood cultures were not performed. The decision to obtain blood cultures were totally left to the neonatologist. What did they find in their study? None of the early blood cultures performed less than 4 hours after birth were positive. Blood cultures between 4 and 72 hours were performed on 21 infants, and none of these blood cultures were also positive. Antibiotics were initiated in 14 out of 21, that is on almost 67% of the infants on whom cultures were sent for evaluation for early onset sepsis between 4 and 72 hours. Even though the blood cultures were negative, these babies continued to get antibiotics for median duration of 5 days. This prolonged treatment may attribute to greater clinical instability, interventions, or abnormal lab values in low-risk infants due to in utero stress, bone marrow depression, growth restriction is what the authors think they were getting antibiotics for this long time. They conclude that utility of blood culture performed soon after birth in preterm infants at lowest risk of early onset sepsis is negligible. With approximately a quarter of preterm infants born in these low-risk circumstances, efforts must be made to spare them of sepsis evaluation and empirical antibiotic administration. What is already known about this is that risk of early onset sepsis among infants with low risk delivery characteristics is extremely low. Despite this, a substantial portion of infants are administered antibiotics. Low risk delivery characteristics usually include C-section delivery, no labor, no membrane rupture before delivery, no concerns for intraamniotic infections, and non-reassuring fetal status. What can we learn from this article is that neonatal sepsis is a dynamic condition. Rigorous evaluation of clinical symptoms over 36 to 48 hours in combination with appropriately selected biomarkers may be used to support or refute sepsis diagnosis. We need to recognize that the differential incidence of early onset sepsis among low-risk infants and account for it in their antibiotic management decisions. In the meantime, additional studies aimed at validating these results in extremely and very premature infants would be much helpful for our clinical practice. So something to think about. Should we consider preeclampsia a low-risk scenario? Because preeclampsia has been shown to be associated with neutropenia in very premature infants, which increases the risk of sepsis. And will low risk criteria for early onset sepsis in very preterm infants mean less use of antibiotics? That would be wonderful. Should we opt to just observe these babies who are low risk for signs of clinical instability and start antibiotics only when they get sick? Some of the things to kind of think about. The next article is about hydrocortisone for BPD. Many studies have been published and have looked at efficacy of glucocorticoids for bronchopulmonary dysplasia because systemic corticosteroids have anti-inflammatory properties and they provide clinicians with options to prevent, treat, or mitigate the lung injury. Hydrocortisone has potential advantages over dexamethasone, as some of the studies have shown, because in animal models, it does not have apoptic effect on the hippocampus or growth restricting effect on the brain as does dexamethasone. So this study by Waterberg, Christie, on hydrocortisone to improve survival without PPD, they found it to determine both the efficacy of hydrocortisone in increasing survival without PPD and its longer-term safety as assessed by survival without moderate or severe neurodevelopmental impairment at 22 to 26 months of age, adjusted for prematurity. So what this study is about and what did they find? This is a multi-center, double-blinded, randomized controlled trial. We studied 800 infants born less than 30 weeks of gestation, intubated for more than 7 days. They had 398 infants in hydrocortisone group, but they got 4 milligram per kilo per day of hydrocortisone tapered over 10 days. And in the control group or the placebo group, there were 402 infants. Survival without moderate or severe BPD at 36 weeks post-menstrual age was noted in 16.6% of hydrocortisone infants compared to 13.2% in the placebo group. No moderate or severe neurodevelopmental impairment at 2 years was 36.9% in hydrocortisone group and 37.3% in placebo group. However, they noticed that antihypertensive treatment was slightly more in hydrocortisone group, 4.3% compared to 1% in placebo group. They also noted that probability of being extubated by the end of the treatment period was 44.7% in hydrocortisone group and 33.6% in the placebo group. There was no significant differences in the duration of supplemental oxygen or length of hospital stay. The limitation of this trial was the fact that only 35% of eligible patients were enrolled and higher incidence of subsequent use of open label dexamethasone in the patients. They concluded that hydrocortisone started at 14 to 28 days did not improve the outcomes, and it may be ineffective in infants with established inflammatory injury of the lungs. These results, however, are also consistent with previous multi-center randomized control trial of hydrocortisone treatment initiated between 7 and 14 days of age. The take-home message from this article is that the cause of BPD is multifactorial. It is highly unlikely that one single therapeutic intervention will have any significant effect on the outcome. Therefore, we should not look at hydrocortisone as a silver bullet for serious lung disease in the premature babies. No, AAP and Canadian Pediatric Societies do not recommend use of systemic steroid in preterm infants just for prevention of bronchopulmonary dysplasia. There is an excellent review for trainees on BPD published in the Nature Review Disease Primer 2019. Talks about pathophysiology, etiology, various treatment, and I think every trainee should read this article about, it's a review article about bronchopulmonary dysplasia. The next article that I chose today was endotracheal intubation. Because of use of non-invasive ventilation, very few opportunities get to the clinician to become very proficient in neonatal intubations. These days, we don't even suction the infants born through meconium-stained amniotic fluid, so the exposure is becoming less and less for intubations. However, intubation is still necessary for the sickest and the most immature infants. Neonatal endotracheal intubation often involves more than one attempt, and during this process, there is oxygen desaturation in these infants. So these authors evaluated nasal high flow therapy during neonatal endotracheal intubation, published recently in New England Journal of Medicine. Their objective was to assess whether nasal high flow therapy during oral neonatal endotracheal intubation improves the likelihood of successful intubation on the first attempt without physiological instability in the infants. This is again randomized controlled trial at 2 Australian neonatal ICUs. They evaluated 251 oral endotracheal intubation in 202 neonates. They had 124 intubations in nasal high flow therapy group and 127 intubation with standard care. Successful intubation on the first attempt without physiological instability happened in 50% of the infants in the nasal high flow therapy, compared to 31.5% in the standard care group. Overall percentage of intubation successful on the first attempt was much higher, 68.5% in nasal high flow therapy compared to standard care group of 54.3%. They conclude that nasal high flow therapy improved the likelihood of successful intubation on the first attempt without physiological instability. We know that rates of success on first attempt intubations are low, with one study that showed a ranges from 23% to 60%, depending upon whether the clinician is experienced or not. And most of the time, because of the physiologic instability, that has been reported as one of the most common reasons why we stop intubation process in these babies. Preterm babies that are less than 32 weeks can be effectively stabilized on high flow nasal cannula in the delivery room or for the resuscitation. Also has been published by the other authors. The take-home message is that the nasal high flow cannula may be of value as method of stabilization for preterm infants in the delivery room. And stabilization on the nasal high flow may reduce rate of failures of intubation in the delivery room or even in the neonatal intensive care. In our center, we've been using RAM nasal cannula for resuscitation for over last 10 years, and we have beautiful success in our resuscitation. And intubation process also is associated with less desaturation episodes for these babies. And these nasal cannulas come in the 3 different sizes. So if you're using the RAM nasal cannula, you can use these during intubation process for these babies. The one last article that I've chosen for today is, can neurodevelopmental impairment in infancy predict neurodevelopmental impairment in the middle childhood? We use information on long-term neurodevelopmental impairment risk when counseling families, interpreting clinical trial results, and referring children at high risk for early intervention. The changes in neurodevelopmental outcomes for ages 2 to 10 years for children born extremely preterm was assessed by the relationship between 2 and 10-year neurodevelopment of extremely preterm infants that were less than 28 weeks of gestation, using a well-known 2-year definition and 10-year definition developed by an expert panel by Taylor, published in Pediatrics 2021. Using data from the early extremely low gestational age newborn study cohort, they classified 2-year neurodevelopmental impairment using definition developed by Eunice Kennedy Shriver and ICHD Neonatal Research Network. They classified 10-year neurodevelopmental impairment using definition developed by an expert panel, which added epilepsy and autism spectrum disorder at 10 years. And this is a graph that shows what they used in their evaluation at 2 years for profound and for moderate to severe disability. And for 10 years with expert panel, they looked at profound, severe, and moderate disability, including the autism spectrum disorder area. So what did they find? Of 1,500 infants, or so, 80% survived. The data were classified severity of neurodevelopmental impairment at both 2 and 10 years were available for 67% of the survivors. It were 802 infants. What they found was that in the babies who had moderate to severe disability, 63% of them at 10 years had none to mild. And for those babies that had profound disability at 2 years of age, 36% of them had none to mild disability. They used Cohen statistics indicated minimal to fair agreement between neurodevelopmental impairment at 2 and 10 years. So this data presented in this study strongly supports the plasticity of the central nervous system in these children and the ability to improve neurodevelopmental outcomes even in the most profoundly affected neonates born extremely premature. We know that neurodevelopmental impairment is found frequently among individuals born extremely preterm, but developmental assessment during infancy are not always predictive of long-term neurodevelopmental outcomes. So we can take home that neurodevelopmental impairment in infancy, as defined in this study, only weakly predicts neurodevelopmental impairment in middle childhood. The optimistic perspective reflected by the authors is helpful to counsel parents or guardians of these children in your practice, especially the ones that want everything done for their babies, no matter what. With this, I conclude my talk and I leave you with this. Education is not the learning of the facts, but the training of the mind to think, as per Albert Einstein. Thank you. If anybody wants any of these articles to read in details, please email me at sardesai@usc.edu for more information. Thank you. Thank you for inviting me today for this talk.
Thank you. It's wonderful listening to you. I think she had discussed 6 papers and bringing or endorsing the trend in which the management of neonates is going on. She emphasized on the possible adverse events of antenatal corticosteroids, especially if you use steroids in bigger children. That was the first paper about. And antenatal, we know that corticosteroids, especially postnatal corticosteroids, with or without added drugs like indomethacin or risk factors for spontaneous intestinal perforation. And there was an interesting paper which she presented saying that even antenatal corticosteroids, if they're given very close to delivery, the interval is short. Again, if added with drugs like indomethacin, it seems to be increasing the risk of spontaneous intestinal perforation. We have to be careful. There's one more paper on steroids, which was on hydrocortisone, early hydrocortisone. Again, bringing out the fallacies. So we don't seem to have, even though there are many papers for and against, this paper didn't support the use of early use of hydrocortisone in preterm. There's no significant
late use.
In terms there.
It's late use of hydrocortisone.
Sorry, ma'am. Can you please go ahead, please?
It is a late use of hydrocortisone after 7 days.
This is about late use of hydrocortisone. Fine.
Yes.
Sorry,
For
just
BPD. Yeah.
And of course, there's an when in babies more than 34 weeks of gestation, especially being delivered only for maternal or placental indications, we know that blood culture has not been shown to have any value. So the current recommendation is just closely observe these babies, and we don't need to do anything unnecessarily in them. Don't need to investigate or start these babies on antibiotics. And intubation looks mostly, we know that non-invasive ventilation is the first line of support. This paper found that babies who are on HFNC, if you have to intubate them, don't take them off HFNC. Just let the HFNC be on, and then you intubate. The stability, the hemodynamic stability seems much better. I think this should apply for babies on CPAP as well. Good learning. Continue non-invasive and just go ahead and intubate. Don't remove the non-invasive support just for the sake of intubation. So these are the main messages that came out of these papers. Thank you again, ma'am. If I think we'll open the session for any queries or comments.
Thank you.
Professor Peter, you want to make any comments?
Thanks. I'd like to ask a question. It's debate about what is a late steroid and what is an early steroid. Christy Waterberg has devoted her career to hydrocortisone, hasn't she? And I'm just wondering if the last bastion is the early steroids or the prophylactic use of hydrocortisone in the first days of life. I'd just be interested in your opinion about where that field is heading.
Yeah, so we know that postnatal steroids have a lot of effect when used with prophylactic endomethacin causing intestinal perforation. But antenatal steroid, because that also increases the cortisol levels in the fetus. And when they are delivered, and when we use all this medication in close proximity to elevated cortisol levels, what is the impact of that with the other things that we do to the patient in that first 12-24 hours? I think is very important because we still don't know the different effects of maternal steroids on these infants for other things, because we are more focused on the lung maturity of these babies. But we don't know what is the long-term impact on their hypothalamic pituitary axis, how it is altered, and what it does to them. And as you just mentioned, in what it does to the adult when this is altered in the fetal life and its implication in the neonatal period. I think those are some of the things worth looking at in future.
So do we have any more questions or comments? Okay, in that case, again, I thank Professor Smita Sardesai for the wonderful presentation, and we close the session. Thank you.
Thank you.
Thank you, Professor Smita Sardesai and Dr. Mangal Bharati for the interesting session. Thank you once again, sir. Now I invite Dr. Manoj CV, the organizing chairperson of IAP Neocon 2022, to rise for an important function.
Ladies and gentlemen, thank you for continuing to stay on the day 4. We had on the day 1 of inauguration, we had honored all the guest faculty who had come from all over the world to join us. But we could not honor 2 of them. So I would like to request them to come onto the dais. Just as a token of our gratitude, may I call upon Professor Sumesh Thomas and Professor Esa Labad to come. They come all the way from University of Calgary, Canada, to do a 2-day continuous scan workshop, which was jam-packed, and then they had contributed. They were judges for the much appreciated NeoSim Wars, the simulation competition as well, and then they were doing sessions also. So the contribution to this conference is immense. So from the bottom of my heart, both of them are good friends of mine, but from the bottom of my heart, on behalf of the team IAP Neocon, we extend our gratitude to you, sir, for coming over and participating in this conference. Thank you so much.
This is what I told you. Oh, we all get well. Okay.
We missed honoring you at the inaugural function. That's why we're calling you. Thank you so much. Back to the scientific sessions.
Thank you.
Next, we have a symposium on neonatal hemodynamics. We have Dr. Srinivasan VK, Professor and HOD of Neonatology, Amala Institute of Medical Sciences, Thrissur, and Dr. Jose O, President-elect IAP Kerala, and Additional Professor, Department of Pediatrics, TD Medical College, Alappuzha, as the moderators for the session. We humbly invite the moderators to the dais. The speakers for the session are Dr. Shiv Sajan Saini, Dr. Kiran Moore, and Dr. Mohit Sahni.
Good morning, everyone. First of all, let me thank the organizers for letting me part of this wonderful international seminar. Now, next is a symposium on neonatal hemodynamics, and this is a very complex topic, as we all know, and there is no easy solution to that. And to discuss the various aspects, some of the aspects in this neonatal hemodynamics, we have on the first part on septic shock, we have Dr. Shiv Sajan Saini. He is an associate professor at a prestigious PGI Chandigarh and is a DM in neonatology from PGI. His special areas of interest are neonatal functional echo, neonatal sepsis, and septic shock. He has got various publications, articles in index journals, as well as chapters, contributed chapters in various textbooks. And we have a doyen in the field of neonatal treatment of neonatal septic shock and sepsis. So over to you, Dr. Shiv Sajan Saini.
Thank you very much, sir. A very good morning to all of you. At the outset, I would like to thank the organizers for inviting me here, and it is an honor to be a part of this prestigious academic event. Septic shock is a common occurrence in neonatal ICUs, especially in the part of the world where sepsis is common, like in developing countries. The sad part is that it is associated with a very high mortality rates. The outcomes are not as good. While the mortality rates of 40% have been documented in Western world, in developing countries like India, the mortality of up to 60 to 70% and even up to 80% has been documented in the studies. So the question is, can we make difference in the outcome of these babies? And I will like to discuss 4 areas where we can make an impact on the management of these babies. I will like to discuss the definition and whether we can identify these babies at an earlier stage, the rationalization of the fluid therapy, choice of vasoactive agents, and what to do in the catecholaminé resistant shock. So let us begin a discussion with a baby, and let us discuss this issue as they emerge while the management of this baby. So it's a baby 28-weeker, 1.1 kilogram, was born. The mother had a risk factor for infections. The baby had a smooth perinatal transition, had early distress, and started at within minutes of life, and baby was stabilized on 5 and 25% oxygen, CPAP of 5 and 25% oxygen. At 32 hours of life, baby had lethargy, had worsening distress, and 12 hours later, the respiratory distress worsened. The temperature was 36.4, meaning thereby there was cold stress, so mild hypothermia. The heart rate was 180 per minute, tachycardia. The pulses were normal, CFT was normal, was 3 seconds. Urine output was normal. The blood pressure the mean arterial pressure was equivalent to the post-menstrual age, and the baby in addition had hypoglycemia. So the question is, does this baby have shock? Now, if I'll take opinion, the opinion will be divided. Some will like to say yes, some will like to say no. So here we would like to, we should know what are the caveats of clinical hemodynamic monitoring parameters. So basically, we monitor these baby for deterioration by the clinical parameters, clinical hemodynamic parameters, and we should appreciate that they have their own caveats. While some of the parameters, they are subjective, for example, pulse volume, some may have inter-observer variability like CFT, some are maintained till very late in the stage of sepsis continuum and will be affected at a later stages, for example, blood pressure. So with this caveat, whether following the clinical parameters, we are able to diagnose these cases at an earlier stage, it is debatable. So therefore, the clinical practice, International Pediatric and the conference statement, the definition by the International Pediatric Consensus Statement says that the shock is defined, septic shock is defined if the blood pressure is less than 5th centile for age, or the systolic blood pressure is less than 2 standard below the normal for age, if there is requirement of vasoactive agents, and the two of the following. In addition to the 3 clinical parameters, that is oliguria, prolonged capillary refill time, core periphery temperature difference, they also include the metabolic parameters in form of metabolic acidosis, the base deficit more than 5 milliequivalents per liter, and lactate, which is more than 2 times of normal. So we add the metabolic derangements on the top of along with the clinical parameters in order to diagnose these cases at an earlier stage. We did blood pressure, the blood gas in this baby, and this baby had high in-gap metabolic acidosis and lactate was elevated, and we diagnosed now it's clear that this baby is possibly having septic shock, early stages of septic shock, and we should start treatment. I would like to, in addition to the clinical parameters and metabolic derangements, there is increasing interest of the clinicians for the microcirculatory parameters. We know that derangement in microcirculatory parameters is an integral part of sepsis pathophysiology. People have started looking at the microcirculation in the form of non-invasive markers like perfusion index and pleth variability index. And the preliminary data have shown that neonates with shock, they do have different microcirculatory parameters as compared to the babies who are not having shock. And in future, it is possible that few years down the line, we, in addition to the clinical and metabolic derangements, we also have the microcirculatory parameters included in the definition of septic shock. Moving ahead, the second part is the fluid. So we gave first fluid bolus, and this baby did not show much improvement. We gave second fluid bolus, not much improvement. Still the baby is hovering just below the 5th centile. So what to do? Now the next question is, should we go ahead and give more fluids, or we should be start vasoactive agents? Now the problem with the fluids is that this intuitive to give more fluids in septic shock because of the pathophysiology involves deranged preload, and the preload is deranged because there can be a relative hypovolemia because of increased capacitance and a dilatation of the capacitance vessel, that venodilatation or vasodilatation, both cause relative hypovolemia. There can be absolute hypovolemia because the settings might be there, or there might be third space lossing, so there can be absolute hypovolemia. So it makes a case to give more fluids. But on the flip side, we can have these babies are likely to have a hemodynamically significant PDA. This baby may be likely to have a diastolic dysfunction, and both of them can cause problem with excess fluid. So the baby is on a having a tightrope walk, and we have to rationalize the fluid therapy. So what are the how can we judiciously use the fluid therapy? So if you see recommendations, the clinical practice parameters, they say that you can give fluids in the septic shock in neonates, in the term neonates, we can give fluids up to 40 ml per kg. The 40 ml per kg. But the individual authors, they have their own reservation, and they say that you can give the fluids 10 to 20 ml per kg. So how to go about it? So we should look at the setting. If there is setting of volume loss, if yes, for example, there can be upper GI losses, lower GI losses, blood losses. So if that is the case, then possibly you can choose to give more. You can take help of the clinical parameters like weight, urine output, sodium, osmolality. But it is important to realize that these parameters tell us about the extracellular fluid compartment and not the intravascular compartment. And these two are, although intravascular is a part of that, the extracellular fluid, but it is a small component and need not necessarily, the changes in ECF does not translate well inside the intravascular compartment. So how can we know about the changes which are going to happen in the intravascular compartment? We can take help of central venous pressure, or we can take help of functional echocardiography. So what is the role of central venous pressure? Now, this is a study which was done in the neonatal age group, and the authors have compared the babies who were spontaneously breathing and the babies who were on conventional or high frequency ventilation. And these babies have reasonably balanced hemodynamic parameters. And if you see the central venous pressure was high, significantly high in the babies who were on conventional ventilation as well as on high frequency ventilation in comparison to the babies who were spontaneously breathing. And it is intuitive also. In the positive pressure ventilation, we have our intrathoracic volume pressures which are elevated, and therefore it gets reflected in the central venous pressure, and it is falsely elevated. So basically, if we see the central venous pressure, it will not give us lead, especially in the babies, because majority of these babies are going to be ventilated anyway. So it does not help. Interestingly, it is a meta-analysis which was published in the adult age group few years back, and it has shown that the authors have concluded that there is no data to support the widespread use of central venous pressure even in adult age group. So therefore, the CVP is not going to help in rationalizing the fluid therapy in these babies. So the second modality is functional echocardiography. There are some parameters which we can use. Essentially, they are directed towards the visual eyeballing, which is the, you look at the how well the ventricles are getting compressed during the systole. If walls are touching each other, which is famously known as kissing sign, it suggests that possibly they are not feeling well. And second is we can see the diameter of IVC and its dynamicity with the respiration, which is, there are a couple of indices which we can use. Collapsibility index, which is generally quoted, which is generally used when the babies are spontaneously breathing, and distensibility index, which is generally used when the babies are on mechanical ventilation. So we can use these indices to inform our clinical practice of giving fluids. The sad part is that we don't have a normative data in the neonatal age group. Luckily, we have a few, some papers are coming now. This is the paper which was done in the healthy cohort. This compared the babies who are undergoing surgery for cardiac diseases, and they are compared with the healthy children, and the 10th and 90th centile of the group of IVC collapsibility was less than 50%. So a reasonable cutoff of 50% is also observed in the adult age group, and we can see that if the maximum diameter minus minimum diameter of IVC divided by maximum diameter, that is collapsibility index, if that is over 50%, it is intuitive to feel that infer that this baby might be benefited with the fluid. However, there are some caveat associated with it. The collapsibility also depends upon how hard the baby is breathing. If the baby is having pain, if the baby is having distress, which is not adequately answered by the respiratory support, then these babies are having retractions, and the IVC collapsibility will be more than usual, and incorrectly we can infer that the fluid load is deficient. Secondly, on the flip side, if the baby has diastolic dysfunction, myocardium is not relaxing well, the baby has a limited ability to handle the fluid, and we may incorrectly infer that this preload is sufficiently normal. So basically, these are the things we should keep in mind. But if there is setting, the baby is improving on fluids, and you see the clinical parameters, they are also going in the same direction. There is no signs of fluid overload, and the echocardiographic findings are also supportive. There becomes a case for giving additional fluids. So we saw the IVC collapsibility in this baby. Yeah, so this was the IVC collapsibility, and you can see that the IVC, which was, this is the IVC draining to RA, and IVC was collapsing, fully collapsing. So we decided to give the third bolus. And after 3 boluses, still the baby had peripheral circulatory failure. CFT was 5 seconds. BP was hypotensive. So now what to do? We decide that this baby is having fluid refractory shock. and we look for the vasoactive agents. Now, to choose vasoactive agents, we look at the pathophysiology. In the pathophysiology, the septic shock, there is both derangements of myocardial functions and the derangement of vasomotor failure. The proportion may vary, and you need to decide in individual baby which is the dominant pathophysiology, and you answer that pathophysiology. So how to decide clinically which is the dominant pathophysiology which is going on in a particular baby? So we can take help of the blood pressure, and we can skin perfusion, and very simplistically we can make 2x2 contingency table, although that is not the final word, but we can make 2x2 contingency table which can guide us the what is the pathophysiology. So if the BP is normal, CFT is normal, that is peripheral circulation is normal, we feel that it's good. If there is problem in the peripheral circulation, that is CFT is delayed and the BP is normal or elevated, we infer that possibly this is the systemic vascular resistance which is high, which is leading to decreased cardiac output, or more importantly, decreased tissue perfusion. The cardiac output is not equivalent to tissue perfusion. So decreased tissue perfusion. If the BP is low and the skin perfusion is normal, then it is possibly the decreased systemic vascular resistance, and the cardiac output is actually heart is beating at a faster rate, is hyperdynamic circulation. And if it is both are delayed, then possibly we have a decreased systemic vascular resistance and we have a decreased tissue perfusion. The cardiac output may be decreased and may be elevated. So we in this baby, it was the baby was hypotensive. The baby had poor circulatory failure. It was intuitive to believe that this baby has decreased systemic vascular resistance, decreased tissue perfusion. Just to confirm, we calculated that the cardiac output in this case, and the cardiac output came out to be 336 ml per kg per minute. So this we know that the cardiac output is 150 to 300 ml per kg per minute. In the baby who has a higher cardiac output with hypotensive, it is inferred that systemic vascular resistance is markedly low, and this is the pathophysiology of septic shock. So how to go about it? The blood pressure, which is if we are having warm shock, we give vasopressor. If we are having circulatory failure, we give inotropes. If we are having derangements of both, we take help of both vasopressor as well as inotropes. What are the agents? These are the agents which give mainly the alpha actions, which is vasopressor actions. These are the agents which give inotropic actions. And in our case, because we have both, we have to choose one of these four: norepinephrine, epinephrine, dopamine, and dobutamine. Now, the dopamine is one agent which has dose-dependent action, stood the test of time, and all the other agents have been compared against dopamine. So let us see what is the evidence for rest of the vasoactive agents in septic shock. This is a busy table. Sorry for the busy, the cramped slide, but for the sake of simplicity, I have colored the results. If the dobutamine, these are the 6 studies which have compared dobutamine against dopamine. The predominant etiology was non-septic, and you can see that dopamine has got variable effects. Some of the studies show dobutamine is better. Some say, red colored say dopamine is better, and yellow say that they more or less have equal efficacy. But it is important, the first study is important, that although dopamine increased BP much better than dobutamine, but dobutamine was associated with increased cardiac output. And it is intuitive to believe that because it has predominantly, it affects on myocardium and causes improved inotropy. There are 3 studies comparing epinephrine and dopamine, and predominantly it is 2 studies predominantly took sepsis babies. They both these drugs show equal efficacy, but if used in non-septic etiologies, predominantly they have efficacy similar, but side effect profile was for epinephrine. Norepinephrine, predominantly retrospective data. We have more data to come in the future. The vasopressin, there is only single randomized controlled trial in 20 babies comparing these two with the similar efficacy, and rest says the retrospective data shows that intermediate outcomes are improved in non-analytical fashion. To summarize, if the baby is hypotensive, normal peripheral circulation, we can use dopamine or epinephrine to begin with, and if the third line, we can use stronger vasopressors. If you have peripheral circulatory failure, maybe dobutamine and the inotropic action of these two agents can be exercised. If hypotensive and poor peripheral circulation combination, we can choose either of these two to the beginning and the alternative drug as a second line in norepinephrine. And if the elevated pulmonary pressures, just remember that dopamine may cause elevation of the pulmonary pressure at high doses, so avoid that high doses of dopamine and use your agents to decrease pulmonary pressures. If the baby is hypotensive, you can use maybe vasopressin or epinephrine vasopressin or norepinephrine. And if the baby is normotensive, you can take help of Miladon and dobutamine. So in catecholamine resistance, we consider adrenal insufficiency. We start steroids, hydrocortisone, in doses of 1 to 2 milligram per kg, 6 to 8 hourly. We check preload, and we have essentially a checklist to check whether everything is in order. Check preload, vasoactive agents dose, if they are going appropriately or not. Check whether there is blood glucose is normal, hematocrit electrolytes are normal, whether there are any air leaks, whether there are any pericardial effusion, tamponade, pulmonary hypertension, rhythm abnormalities, etc. We check virtually everything and decide whether anything is correctable or not, and then move ahead. So the take-home messages are: we have to identify early, we have to look beyond the clinical, probably blood gas parameters to consider early, and maybe in the future we can have the microcirculatory parameters. Remember that the BP is a late sign of shock. The BP gets deranged late in the course of shock. The preterm neonates, usually the fluid requirement is 10 to 20 ml per kg. If you want to give additional fluid, we have to look. We have to, in addition to clinical parameters, we have to consider echocardiographic parameters, mainly based on IVC indices, based indices, and visual eyeballing. And remember that in high frequency ventilation, distressed neonate and diastolic dysfunction, these parameters may be fallacious. Look for BP and peripheral perfusion to judge whether there is what are the dominant pathophysiology, and decide the vasoactive agents based on the pathophysiological changes. And echo, you can take help of echocardiography if you are borderline, you're not able to decide based on the clinical parameters, and or if the baby is not improving, then we can take a help of echocardiography. In refractory shock, we go through the checklist and we consider adrenal insufficiency, start hydrocortisone. So I acknowledge the contribution of my my teachers and my residents, and I have learned a lot during the interactive discussion with them. This is the place where I work. Thank you very much.
Thank you, sir, for giving us clear concept on the management and diagnosis of septic shock. I think we'll have the discussion at the end of the session.
Thank you, sir. Kindly take your seat on the dais. I humbly invite the next speaker to the stage, Dr. Kiran Moore, and he will be speaking on the hemodynamic challenges in CDH. Over to the moderators.
Thank you, the organizing team, the given the opportunity to chair on the important topic in neonatology, the hemodynamics, series of hemodynamics. Already we covered the septic shock and different aspect by lucid talk by the sir. And now we move on to another important scenario, congenital diaphragmatic hernia hemodynamic changes. In congenital diaphragmatic hernia, there is a lot of issues in the along with the pulmonary vasculature abnormalities, and we can have intracardiac abnormalities. And the issue is that the management of hemodynamic maintenance pre-operatively and post-operatively, the management of congenital diaphragmatic is challenging in our day-to-day practice of neonatology concern. To talk on the topic, the hemodynamic change in the congenital diaphragmatic hernia, we have an excellent speaker, Dr. Kiran Moore from Mumbai. He's the head of the Department of Neonatology, BJ Wadia Hospital, Mumbai. Former consultant neonatologist at Qatar, assistant professor, Will Cornell Medical College. Over to Dr. Kiran Moore for the talk on hemodynamic changes in congenital diaphragmatic hernia. Over to sir.
Thank you, sir, for a kind introduction and setting the tone for the talk. So, good morning, everyone. A lot of hemodynamics talks and a lot of echoes will be seen, and I hope I won't get you bored. And I'll try to, give the salient features about the CDH management. So, I'm currently just in a transition. I've just left my previous workplace, Sidra Medicine, and recently joined BJ Wadia Children's Hospital. So I have a no financial conflict of interest to disclose, but I'll be presenting my experience and CDH data from my previous workplace in Qatar. So as sir highlighted, basically CDH is one condition which is very complex, and it involves very sort of challenging balance of cardiorespiratory, cardio-hemodynamic management. And specifically because of the condition, there are a lot of challenges we can face, either because of the vasculature or severity of the PPH and cardiac dysfunctions, the debate about the timing of the repair, and also associated chronic pulmonary hypertension. Now in 15 minutes, it's very difficult to cover this topic. So I'll try to see, I can at least give you some basic principles to manage. So CDH it's not that uncommon. It's an overall prevalence of 3.5 per 10,000. And survival at 1 year is about 77 to 85%. And now this is reported in the developed world. The survival might be lower in the developing countries. It is known that severe PH is associated with very high mortality, more than 50%. And interestingly, to point out, and the focus of today's talk, that 30 to 40% of these babies with CDH may have either left, right, or biventricular dysfunction, and that predicts the disease severity, mortality, and need for ECMO. And late pulmonary hypertension in CDH is also essential part of the management, and it involves targeted pulmonary vasodilator therapy, which we'll go through. Now, over last 5 to 6 or 7 decades, a lot of therapies have been tried in management of CDH with various success. And we moved from, one sec, just trying to get the pointer. Okay, there's no pointer here. Okay, so there's no pointer here, but you can see this thing. So we moved from immediate repair to a delayed repair. We moved from hyperventilation to permissive hypercapnia. And currently what we see is, yeah, thank you. Okay, fine. So currently what we see is what is highlighted in the green. So delayed repair after achieving the stabilization, allowing gentle ventilation or permissive hypercapnia, use of ECMO in selective cases, and antenatal fetal interventions like FITO has been tried in some centers. Now, if you look at the trend of the mortality over last 2 to 3 decades, the survival has been 30 to 35%, and there is an improvement over a period of time, but it still remains very high. So what is the cause of the high mortality? Is it the pulmonary hypoplasia, or is it the complex interaction with the cardiac dysfunction? And how can we manage these babies better? And that's how the focus of my today's talk is. Just to highlight the basic pathophysiology, which all of you are aware, in CDH, it's a complex interaction. The primary issue being the pulmonary hypoplasia because of the intestines lying in the chest for a long period of time. And that leads to abnormal vasculature development, not only on the same side, but also on the contralateral side. And then associated maldevelopment of the heart, especially the LV and RV, are affected significantly, leading to cardiac dysfunction. And this complex interplay leads to severe pulmonary hypertension, which is the challenge in management of these babies. Just to highlight this slide, that the pulmonary vasculature is really abnormal and very much like thickened in this particular babies as compared to the controls. And that's why the role of pulmonary vasodilators remains debatable, and we don't know which dilators these babies will respond to. Now, focusing on the right ventricle dysfunction, there are a lot of reasons for the RV dysfunction. Firstly, the low RV preloads. A lot of these babies are on high MAP, high frequency, so there is a decreased venous return and decreased preload to the heart. Then there is impaired contractility because of the intrinsic RV dysfunction, plus a lot of these babies get septic, hypoxemic, so there is a progressive RV dysfunction. And then importantly, this RV is subjected to very high afterload, and because of the severe pulmonary hypertension, which remains elevated for significant period of time, leading to, again, progressive RV dysfunction. So again, the management involves managing this complex interaction and managing all these RV dysfunction factors. Again, not only RV, but LV also significantly affected in CDH. And there are a lot of evidence suggesting that there is LV hypoplasia in the autopsied or fetuses which are died. And that's why managing LV also becomes very important. Now we know that when these babies are born, suddenly the PVR which needs to be dropped doesn't drop in most of these babies. And on top of that, there is a significant rise in the SVR happening. And that's why the whole idea of management becomes the balancing of the SVR and PVR. We saw that RV diastolic dysfunction and hypertrophy is already there. And we know that these chambers don't work in isolation. And Patrick also alluded this morning, there is something called as ventricular interdependence because the fibers are interconnected. So whenever there's a RV dysfunction, there is associated LV dysfunction. And on top of that, if there is LV hypoplasia, this aggravates the whole situation, leads to reduced left ventricular output, systemic hypertension, and acidosis. And all this leads to our associated outcomes as prolonged duration of ventilation or length of stay, decreased survival, and need of ECMO. Again, this is a very important slide to highlight, published by Neil Patel in 2019. And this is again emphasizing the importance of LV or RV dysfunction. As you can see in this Kaplan-Meier graph, if there is normal ventricular function, then the survival is best, followed by if there is only RV dysfunction, followed by if there is a LV dysfunction. And if there is a biventricular dysfunction, then the mortality is worse. So again, emphasizing we need to take care of these ventricles. Now, how we manage, in next few slides, we'll go about approach to management. And it starts from the antenatal because we need to plan where to deliver these babies and which centers can really manage. And there are various parameters explained which tells us the severity of the CDH. So position of the liver, lung head ratio, observed expected lung head ratio. In some centers, they do fetal MRI, like in our centers. So you can actually calculate the fetal lung volume, and there are other predictors which will tell you that what kind of a baby you're going to expect. Is it a severe form or a mild form? And then you can plan accordingly. Just delivery management, the principles we need to follow. Avoid hypothermia. A team needs to be prepared in managing these babies. Avoid hyperoxia. So you don't start with room temperature. You start about 25 to 50% oxygen, but don't start 100% oxygen because oxygen can cause free radical injury. Then importantly, you allow good lung expansion. Now, Euro consultant and many centers sort of advise elective intubation, especially in the moderate or severe forms, unless babies are presented late or they're spontaneously breathing very well. You can electively intubate them, avoid bag and mouth ventilation so that you recruit the lungs immediately. Prevent acidosis, and if possible, do physiological cord canting. So you do resuscitation with the intact cord if there is a lifestyle tolly or similar is available in the center. Now again, before managing hemodynamics, you need to manage the ventilation, but that itself is a separate talk. We don't need to go into details of it, but again, we need to have an open lung strategy. And as you know, because for managing the PVR, you need to have a optimum lung ventilation. So your lungs should be recruited enough and not over or under so that your PVR drops naturally. So again, it's controversial whether we want to use conventional or high frequency, and its center-based approach is different. But generally what we follow is we start with certain pressures on conventional, we avoid volume guarantee, and then we look at the expansion on the X-ray and the gases, and then we titrate accordingly. And as you can see, the X-ray sort of is a guide to tell you that from mild form, which might be managed on the conventional, followed by high frequency, or some patients needs ECMO, depending on the severity of the hypoplasia and severity of the pulmonary hypertension. Now coming to the important part of the talk, hemodynamic assessment. And again, we have a session coming from Dr. Mohit, who will be explaining more about PPHN. So I'll be talking more so on CDH specific management and echo assessment. So we need to do first echo, preferably by the cardiology, just to assess if there are any associated cardiac anomalies, and also to rule out any other intrinsic structural defects, and also to do a formal echo to assess the dimensions, and also to assess the severity of pulmonary hypertension and cardiac dysfunction. But to summarize the focus, and those who are aware of the various parameters, I will just enlist that how you assess the RV comprehensively. So first is to assess the afterload, and then assess the degree of pulmonary hypertension or PVR. So you have either measurement of TR, or you have a septal flattening, or you have a PDA, which is bidirectional or right to left shunt, or PFO, which is either bidirectional or PF, right to left shunt. Also, there are surrogate markers of PVR like measuring the right ventricular ejection time to peak acceleration time to right ventricular ejection time. And also there's something called as eccentricity index, where you compare the dimensions of the RV in the 2 dimensions. Then you assess the RV systolic function. So there are 2 parameters mainly to highlight for RV systolic function. First is the fractional area change, where you're just comparing the systolic and diastolic dimension of the right heart. And secondly, something called as TAPC, which is tricuspid annular plane systolic excursion, because RV sort of contracts vertically. So you just see how much tricuspid is moving, and that's also a good marker for systolic function. Then you assess diastolic function by not only 2D, but also by advanced echo sort of assessment, such as tissue Doppler, where you can look at the isovolumetric relaxation time, something called as T index, and you can also do deformation measurements, and a lot of publication based on that, how it helps us to assess the degree of LV dysfunction. And also some dimensions can be measured, which again tell you if there is an RV hypoplasia or a RV hypoplasia. Now again, left ventricle also we need to assess carefully. We need to measure the left ventricle output. We need to measure the dimensions, and also calculate the fractional shortening or ejection fraction, which again tells you the systolic function. And there is something called as left ventricle ejection time, or sort of mean velocity of circumferential fiber shortening, which is again independent of the septal movement, and that could be an accurate marker again for a systolic or diastolic function. And then there are other parameters like EA ratio, which can again tell you about some diastolic function. So again, just to focus that how important is to assess and then titrate the therapy in these babies. Now this is the algorithm in Sidra which we follow, and is based on various protocols in Glasgow and some other centers, and I think this is a good guide for people to follow, and how we do select the targeted inotropic management in these babies. So now if you look at this first part, so again, you need to clinically, if these babies are already behaving, they're in 100% oxygen, they're behaving like significant pulmonary hypertension, you need to initially optimize the sedation, ventilation, and try to aim for good pH above 7.2. And while awaiting echo, sometimes you can still empirically start nitric oxide. But in our center, most likely we usually get an echo before sort of starting nitric for the ruling out other conditions. Now, if there is pulmonary hypertension and already systemic hypertension setting in within first few hours, then we sort of allow 1 or 2 boluses till echo is awaited. And that's again to just temporarily increase the preload for RV and LV. But again, you don't give too much, because you can compromise if the LV is already compromised. Now, first sort of inotrope of choice we follow is epinephrine, for the reason, again, if we don't know if there's a dysfunction happening in LV or RV, this is a good drug to start. And a lot of time, we often give hydrocortisone within first 6 to 12 hours to optimize the sort of catecholamine response, and also optimize the inotropic action. Now, if the pulmonary hypertension persists, and if there is no response to nitric oxide, which is there seen in a lot of 30 to 40% cases, and especially CDH more so, then we tend to start IV sildenafil as a second line quickly at 25 to 100 micrograms per kilogram per hour, and then we titrate as per the response. And we consider prostacyclins if there is sort of suprasystemic pulmonary hypertension and there is RV dysfunction happening, and especially if the PDA is getting narrowed. Now, coming to the hypotension part, so if there is, after doing an echo, if you know there is ventricular dysfunction, if there is a right ventricular predominant dysfunction, we tend to start milrinone. And again, as I mentioned, prostacyclin, sometimes we start early because we want to support the RV, which might fail if there is suprasystemic pulmonary pressures. And then if there is a left ventricular dysfunction isolated, we tend to start epinephrine. But if there is a biventricular dysfunction, we have sometimes started even a combination of epinephrine and milrinone, and usually epinephrine first followed by milrinone. And then these are the indications of ECMO. Again, I will not go into the details, but it is either because of the severe PH or severe LV dysfunction or ventilation failure. Now, I'll just share quickly the data from our last 3 to 4 years. We had about 42 patients with prevalence of 4.17 per 10,000 live birth. Majority were left-sided, but we also had some bilateral, and these were the demographics. And we had a very high anomaly, sort of genetic anomalies in our cohort, and that can explain the higher prevalence. Almost 23% babies had some genetic anomaly, and 5 babies had major genetic anomalies or syndromes. So our survival to discharge was overall was 71%, but if you remove the major genetic anomalies, then it was about 83%, which is quite good and comparable to a lot of other centers and reported data. We looked at the trends of our data in various echo parameters, and to highlight, we looked at the respiratory sort of severity score, which again tells you the marker of illness severity. And we saw that initially the severity was higher, and pre-op there was a stabilization of the scores, and then post-op there was temporary rise and followed by stabilization. If you look at the TAPSE, the TAPSE was poor or low in the first 72 hours, followed by improvement in the pre-op stage, and it continued to improve in the post-op period. And if you look at the pulmonary pressures, they were elevated initially, and most of the babies, we got the pulmonary pressures down before the surgery, and then they were temporarily elevated post-op period. So we basically highlights that, we tend to achieve the hemodynamic stability before going for surgery, and that improves the outcome. We tried to look at the various parameters which can predict mortality, but the only 2 parameters we found positive was, if the baby is a smaller preterm, less than 2.8 kilo, that increases chances of chance of mortality, and also if the cutoffs of right ventricular systolic pressures are more than 45, it increases the chance of mortality. So again, pulmonary hypertension playing a very important role in this. And these are the various medications which we used, and strikingly, we still use good nitric oxide, about 59%, and milrinone in 64% of the babies. Again, this is a comparison based on, if you compare the groups based on respiratory severity score, below 4 and more than 4, and you can see there were many parameters suggesting suprasystemic pulmonary pressures or need of inotropes was higher in the babies who are sick. So again, pulmonary pressures and the cardiac dysfunction is driving the cardiorespiratory physiology. Just last 3-4 slides based on various inotropic agents. So nitric oxide, as I mentioned, it is still commonly used, but a lot of literature doesn't support use of nitric oxide. The biggest trial, NINOS trial, actually has suggested no benefit of nitric oxide in CDH. In fact, it can cause increased mortality. And but there are a lot of studies showing that there could be helping in initial stabilization. So as you saw, when you're stuck and you're in 100% oxygen, they tend to use nitric oxide, at least for the temporary period, till we achieve some stabilization. Now, other specific ventricular afterload reduction, again, as I highlighted, milrinone is one drug which is very good, which improves the biventricular function and also improves the afterload, and which is commonly used. And there is a currently an RCT going on in US in various centers, and probably we'll get more direction from that. And PG, as I mentioned, again, it afloats the RV and maintains the cardiac output, and it helps in RV function. And pulmonary vasodilators, you have to use carefully. Specifically, nitric oxide, you should be cautious if there is an LV dysfunction, because if there is LV dysfunction, there is a back pressure changes in the LA, and then there could be pulmonary venous hypertension. And if you give nitric oxide, it can worsen the pulmonary edema and also worsen the pulmonary venous hypertension. So you have to, again, use very carefully and monitor regularly with the echo. Again, some other drugs, IV sildenafil has shown improvement in the oxygenation index and also improvement in the MAP. Vasopressin has shown some improvement. Again, as before going on to the ECMO, is a drug which often we can try. And coming to the chronic pulmonary hypertension part, again, I will not go into much detail. A lot of drugs have been tried apart from sildenafil and bosentan, but one drug which is again coming as promising is treprostinil, which is a prostanide, and it can be used in IV or subcut form. And there are some case series suggesting IV treprostinil to be useful in reducing the chronic pulmonary hypertension in these babies. So it can be used in this subcut sort of injections. If it's available, then it is a drug sort of very much useful. So to conclude again, I've been emphasizing the importance of the echo assessment and assessment of the RV and LV dysfunction, and target your therapy based on that. And not only before starting, but also serial echo monitoring after starting the therapy, pre-op, post-op is very much essential. And severe and persistent PH is a risk of mortality. So you need to choose and try different vasodilator and see which babies will respond. But again, we need sort of more studies to protocolize the management, which will improve the outcome. With that, I'll stop with some future directions for India, which I feel should be there, considering like a national registry or something, and unified guidelines for managing CDH. Thank you.
Thank you, sir, for an excellent talk on different aspects of tackling starting with the pulmonary vasculature maintenance and regarding the RV ventricular dysfunction maintenance and the recent advance in the management of hemodynamic management of congestive dynamic is concerned. And we will have a question at the end of section, and we can move into the next. Thank you, sir.
Thank you, sir. Kindly take your seat on the dais. We kindly invite the next speaker, Dr. Mohit Sani, to discuss on PPHN. Over to the moderators.
Yes, next topic is on hemodynamics of PPHN. And PPHN, we all know, is a nightmare for all of us practicing pediatrician. And to clear the concepts regarding diagnosis and management, we have Dr. Mohit Sani. Mohit Sani is one of the stalwarts in the practice of neonatology in India. He's a director of Institute of Child Health, Nirmal Hospital Private Limited, Surat, and he's also the director of Neonatal Focus Echo Academy, Surat. He's an editor-in-chief of Journal of Neonatology, India, and he's the present president of the Gujarat chapter of NNF. And he's also an editor of many books, and is a doyen in the field of neonatology. Over to you, sir.
Thank you, sir. I would like to thank the organizers for inviting me. So in next 15 minutes, we'll just talk about PPHN. And nitric oxide has been talked about. There are a lot of things which Dr. Kiran has already discussed. But, we decide to give nitric and let the baby smoke or not to smoke nitric oxide in order to let the baby smoke this. It means the mortality to decrease the mortality. Okay. So in this slide, I just want to have your inputs. It is very important. Nitric oxide is a wonder drug. How many of us believe this? Okay, I think so. I overestimated it. So these are the percentages. I thought the people will tell yes or no on the left side. So this is my wrong estimation. How many of us are using surfactant for PPHN, treating PPHN on ventilators? Yeah, okay, MAS, if it is meconium aspiration. Okay, not 50%. Okay, again, my estimation was wrong. Fine. How many of us are using high frequency with or without nitric oxide? Okay, fine. So this is underestimation. And I think so nobody is using ECMO except for Kiran. And yes, in India. So this is a dream for us, which may come true. No, not for cardiac, but for PPH. Okay. So my friends, this is a baby delivered with MS, and they get a call that baby has delivered with MS via PPHN. So all the units with HFO, they got active that they want baby. But who wins? Who wins? The one who has got the nitric oxide wins the show. So we will just see whether this nitric oxide is a wonder drug or not, and with PPHN. Okay, let's talk about one scenario. This is a term baby. born to with thin MSL, vigorous, Apgar's 8 and 9 at 1 hour. Nurse noted that baby to be dusky with rapid breathing. These are the vitals. In specific case, SpO2 was 55% in room air. CFT is prolonged, mean blood pressures are low. Pre-ductal 69, post-ductal 50%, and FiO2 almost 100%. Clear? So this was the X-ray. This is the X-ray. What is the X-ray? Anyone? Loud. What may be the X-ray? Meconium. Okay. So baby was intubated, started on high conventional ventilatory parameters. FiO2 of 100% still. Pre-ductal saturation 85%, post-ductal 69%. This is the first ABG, arterial gas. pH is low, okay, high CO2s with increased base deficit. So this was the condition for this baby. So what may be the differentials? What is the most appropriate out of this? Color, you speak out the color. Yellow, fine, yes, because we are discussing PPHN and MAS, yes. Okay, fine. So what is PPHN? It's a misnomer, yes. What it is? Anyone? So simply, if I want to define, basically it's a failure of normal postnatal adaptation with persistence of high pulmonary vasculature leading to right ventricle failure and pulmonary systemic channel shunting. So this is, in simple words, is the PH, pulmonary artery hypertension. So this is what this diagram tells the same. If you have high pressures over here, this thing is not working fine. So if you have high pressures on here, okay, all the areas where you have a shunting, you have right to left shunting. Okay, this is very important because that's how we keep in mind and then tend to treat the pulmonary artery hypertension. So this is how to treat and approach PAH physiologically. And if I want to classify, why this classification is important, because instead of theoretical thing, you know, I just want to concentrate on things which are reversible. Those which are irreversible is of no use to me clinically. So I want to concentrate on the reversible issues of the PPHN. So first thing is, we do talk about, in hemodynamics, we do talk about echo. But before that, the one thing that comes is clinical assessment. That is very important and we should not forget that. So you have to clinically assess the baby. Okay, the babies, they do have respiratory distress, they have difference in pre and post-ductal saturations. You have hyperoxia test to diagnose that whether it is a CDH or PPH, and sometimes it is confusing, but yes. And you know, why we are talking about this? Because if you don't have readily available echo, if you don't have echo machine at your unit, or you don't have a pediatric cardiologist coming to you immediately, so these are the things which can help you. Okay, so PPHN, first thing is clinical assessment. Confirm it. How to confirm it? The confirmation is by the echo. That is very important because we have to rule out congenital heart diseases. Once you rule out congenital heart disease, then it confirms your diagnosis of PPHN. Then after that, you have to concentrate on the treatment. That is very important. First assessment, then comes your treatment. In treatment, you have to tackle with 3 or 4 things. One is your pulmonary hypertension. One is your ventricular dysfunction because of pulmonary hypertension. And the other thing is your ventilation. So they all must go hand in hand. You just cannot tackle ventilation on one side and then you will think, first let me tackle the ventilation and I will tackle the cardiac issues afterwards. No, it has to go hand in hand. That is very important. So for PPH, again, this nitric oxide comes in. I've been concentrating on this because in West, all the units, they have nitric oxide, but in India, it is not readily available. Again, then the controversy comes whether it is medically graded or not, because it has not been medically graded. It's a commercial grade. Then again, controversy will come. So that will be there, and many units, they don't have then what they have to do to tackle, because we do have a lot of babies with the pulmonary hypertension. So one thing is clear, clinical assessment is important, but we just cannot assess PPHN alone with clinical assessment. You have to have something add on to this. And what that add on is, basically a echo. So those who have been trained in hemodynamics, again, is a caution for them. If you are not a certified trained pediatric cardiologist, you should not be handling the babies without getting one echo done by a certified trained pediatric cardiologist to rule out the congenital heart diseases. And the most common lesions that present like PPHN at birth are, anyone? What can be the most common lesion which mimic PPHN? Okay. So these are the one. TAPVC is one of the most common ones, which may mimic as PPHN. So now, can you see two videos of echoes on both sides? Okay. So those who have done the workshop, they would be able to identify. This is a apical 4-chamber view, and you can see just by looking at, you can see the one with the severe PPHN, you can see eyeballing the cardiac contractility is low, and your right-sided chambers, they are pretty dilated. So if even you are not trained, but you are confirmed that this is not a congenital heart disease, then you can assess that how bad this PPHN may be. And this is again with the color Doppler, and this blue jet, what you are seeing in a apical 4-chamber view is your TR jet. Okay, that's one of the few ways how we assess pulmonary hypertension in echo. And this is then on the basis of clinical parameters and functional echo parameters, we tend to classify the PPHN as mild, moderate, and severe. Why it is important? Because suppose you have assessed the baby, and the baby is having a severe pulmonary hypertension, and you have intervened, you have started something, like if you have nitric oxide, you have started nitric oxide, okay? So if you have started something, then you reassess that baby, just to see whether the intervention you have done has worked or not. So if the baby was in the category of severe pulmonary hypertension by functional echo, and clinically, you have done one intervention and reassess whether it has gone from severe to moderate or not. Okay, so this is just a classification for that. Why this NEFCO thing is coming again and again, I will tell at the end of my presentation. But though the one who answers this question will get one of our book, we will courier that book to you, free of cost. Those who will answer that within India, please. that is the thing. And he should not be hemodynamic trained person. Okay. Which of this baby A, B, C, D is having pulmonary hypertension? Anyone? B, D. Anyone else? So all are having pulmonary hypertension. You see, the pulmonary hypertension is, all the arrows are raised of PVR. They all are having pulmonary hypertension. Which baby is the most critical and bad baby out of this, A, B, C, D? D. A is the right answer, because all the shunts have been closed, and this is what Dr. Kiran in management was mentioning. Why to start prostaglandins for the babies with the severe pulmonary hypertension? Because to open up some way to release pressure on RV. If RV fails, then it will cause trouble. So you please note the details at the end of the thing. Please message us your address. We will post the book to you. Great, good. So we again come to that our scenario, what we discussed. So this is our scenario. The baby who was pretty bad. Okay, high ventilatory requirements, FiO2 100%, pre-ductal 85, post-ductal 69%, and this was the X-ray. So out of these two, which one you want to achieve? Which ABG you want to target? The first one or the other one? Second. Okay, very much right. Those old concepts of hyperventilation, attaining alkalosis, hyperventilating the babies are gone. It has to be moderate lung protective ventilation with adequate opening up of the lungs, and then you start, because if your lungs are not well recruited and if you start with the nitric oxide will not work. That's why if you are using surfactant for some indication, like you have meconium aspiration syndrome, okay, and your lungs are not well recruited, so first recruit them well. If you want to give surfactant, give it, and then start with the nitric oxide. If your lungs are not recruited, you're given nitric oxide, it doesn't work, and then you decide to give surfactant, is the other way around. Clear? So this is just a management protocol, initial management protocol. Confirm the diagnosis of PPHN that we have talked about. Correct the underlying metabolic. All these things first you have to diagnose and correct it, because they contribute in increasing your pulmonary hypertension. Ventilate conservatively. PO2s and the targets old we used to think should not be now your targets. It has to be conservative. Okay, and then surfactants, ECMO, I will not talk high frequency ventilators or nitric oxide if you need to recruit, if your conventional ventilators are not working. Like in conventional ventilators, what we follow is, if your MAP, mean airway pressures on that is more than 12, FiO2 requirement more than 60, we tend to switch the mode of ventilation from conventional to high frequency. This is what we follow to switch the ventilators. And then the alternative, vasodilators. Why I'm talking about this? If you don't have nitric oxide, if you have high frequency, and you don't have a referral center nearby with the nitric oxide or other advanced techniques, okay, then you can try with the sildenafil and milrinone. Again, it has shown some use in decreasing your pulmonary hypertension. Nitric oxide, I will just talk, like there are indications, still more than 34 weeker has to be enrolled, and we follow the rule of 20-20 and 60-60 when we start nitric oxide, and when we wean nitric oxide. It's a whole big talk, that I cannot discuss in this, but there are indications and there is a rule how to start and how to wean nitric oxides in your units. So these are the drugs. Nitric oxide is well studied. Sildenafil has got some studies to support that. Maxelf, again, we used to use when we didn't have sildenafil. It's in babies, they go into shock. So that's why this is something which can be counterproductive. Milrinone, still now we have the studies that has shown that it does work because it acts as a pulmonary vasodilator. Then inhaled prostacyclins we don't get in India. So that is one issue, but that can be used. Vasopressin has used and has shown some results. So this is what, in terms of drugs, when you talk about. So what in the hemodynamics? First, that echo, you have ruled out that, and then as I've already talked about, ruled out the structure. Functions of the both heart has to be managed by the inotropic agents. PPHN has to be managed, and then you have to manage the volume. The baby should not be hypervolemic or hypovolemic if you want to tackle the shock part of the PPHN. So this is slide by Dr. Soni, he's sitting there. So this is a very good presentation, a slide that makes you how you can manage with the help of echo your PPHN. So in this, you see this one down corner is the shunting at right to left, atrial shunting at the level of PFO or atria. Oh, sorry, at the level of PDA. In x-axis, in y-axis, it is atrial level shunting. Okay. So now, if you have right to left shunting at the atrial level when you are doing the echo, and you have left to right shunting at the level of PDA, okay, that means it is a duct dependent pulmonary circulation. Okay, the treatment is you need to keep the duct open. If you have a baby in which the ductal level shunting is right to left and at atrial level shunting is right to left, this is what happens in the severe pulmonary hypertension. You need to treat the pulmonary hypertension. You can start with the nitric oxide. If you have a baby with PDA shunting left to right, atrial shunting left to right, it means more issue is with the lungs. Try to manage your lungs well. Okay, the pulmonary hypertension component is not that bad. And this is something which is very important. If you have a baby with shunting at the ductal level is right to left, and the atrial level, at the atrial level it is left to right, it means it's LV dysfunction. So these are the babies in whom you will not start nitric oxide. You need to first take care of LV. strengthen your LV, make it work better, and then otherwise it will, nitric oxide will be counterproductive in this. So this is what, like, first, second, third choice, normally it's been done in most of the units. We start with the dobutamine and milrinone. There has been clearly now many papers, dobutamine versus dopamine in babies with low perfusion and PPHN. Dobutamine is a better drug as compared to dopamine. In terms of milrinone, if you have a severe diastolic hypotension, diastolic component of your blood pressures are low, then you should be careful in starting your milrinone. Then the other thing is, nowadays, many units, they start with the low dose epinephrine, and few units, they even start with the low dose norepinephrine. In low doses means 0.1 to 0.05 to 0.2 mics per kg per minute. It acts as a pulmonary vasodilator. And some units, we even use vasopressin because, again, it is a pulmonary vasodilator, but it has other side effects also. So you have to be comfortable in using it, but there are studies which they support that vasopressin is helpful in treating your pulmonary hypertension. So my friends, it's all focus. Okay, you need to focus. See, she was focusing on something she could not achieve. Should you leave it? I don't think so. If your focus is right, aim is to achieve it. Achieve the focus. So that's what is NEFCO is. It is just a platform to get you trained. And there is a YouTube channel of NEFCO neonatal echoes and Insta page. All academic material is uploaded on that. You can follow and get weekly updates on that. And there are numbers and email. You can please message your address. We will send you the book. Thank you very much.
Thank you very much, sir. That was a brilliant talk, explaining clearly the concepts of diagnosis and outlining the management. We'll have discussion at the end of it, sir.
We move on to next section. The next section also dealt by Mogus Chani, and that already we covered the common topic of PPHN, septic shock, and hemodynamic congenital diaphragmatic hernias. Still, we have a dilemmas in hemodynamic in newborn is concerned. To narrate on this, again, I invite Dr. Moginsu to continue the topic on dilemmas in hemodynamics in newborns.
Thank you.
A humble request to the moderators and the speaker. Can you wind up in next 5 minutes? 5 minutes, because otherwise there is an online session. Professor Anne Hellstrom from Sweden. The online sessions we cannot delay. Before that, we have a round table and one talk also. So please wind up in 5 minutes if it's possible.
Then should we continue with this, or we can take the?
Or we can actually discuss, because that is all PPHN has been already discussed in various things. We can have a 5-minute discussion.
Take a query and discuss.
You can discuss between yourself in the this thing, and then you can take the discussion.
Okay, what I can do is, they can be the panelist. I will just discuss one case. And
go ahead. 5 minutes. Exactly 5 minutes.
Yeah. So just make 2 mics available. 2 questions for audience.
Questions from audience.
Okay.
Queries from audience we can be.
So, Dr. Suryavanshi couldn't come because of some issues. So then I refused to vacate the stage. I want to be here. So please bear with me.
Hello, sir. It was a wonderful presentation.
No, it's not in the question. I will ask the question.
Okay, you will ask. I thought that we can ask. Okay.
Yes. The first. No. Start with the first slide. Yeah. This is the one. Start with the first slide. It should not happen like this, huh? Please bear with me. Ask the question. Should not happen like this. And one thing I just want to bring. If people think all people who are hemodynamic and know the functional echo, they are Superman, I just want to indicate that Superman does have the limitations. So everything comes with the limitations. That is very important. Even though we think we are Superman, but actually we are not. Okay. I will not go into this. I will start with one case. So this is, may I have 1 or 2 mics available? Yes, thank you. So this is a preterm 28 weeks male delivered by normal vaginal delivery, cried immediately after birth, developed distress at birth, started on CPAP, delivery room CPAP, birth weight is 1.1 kg. Baby is on ventilator and ICU, given 1 dose of surfactant. The baby was better at 12 hours, was extubated to CPAP. This is not, normally we do lesser invasive ventilations, given surfactant after 48 hours, the baby is still on CPAP of 5 centimeters, FIR to decrease to 21% and was tolerating feeds well. And then on your rounds, you started noticing that baby is having desaturation episodes, and it generally happens if some senior takes the round. And just now, he had one big episode of bradycardia with SpO2 gone down to 81%. Clear case? So I just want to ask, if you're on the bedside, you are there, you are trained in functional echo, and the very nice, good machine is there at your bedside. What will be your initial approach to manage this baby? Anyone want to answer this? There, please, can you give me the mic?
Would like to rule out the pneumothorax first with either X-ray, or if I am trained in the lung ultrasound, then better with the lung ultrasound. And the second would be echo to rule out PDA.
Great. So she has given all the major answers. The first thing first, you have to do your what we have learned. Like if the baby is on positive pressure ventilation, what we do first?
Dope.
Yes. So rule out dope, rule out pneumothorax, that is the most common thing, and then go for the other assessments. Okay, fine. And she has already told about the lung ultrasounds. That is very important. So now you have done the echoes of this way, and this is what you are seeing. You have already told, yes. Anyone else? So this is your ductal view, and this red thing is PDA. So that baby was having HSPDA, hemodynamic significant PDA. That's why this baby is having issue. So, Dr. Kiran, if such a baby is there in front of you and you ruled out dope, you have ruled out pneumothorax, and this is what you have diagnosed. So, how you will manage the shock in this baby? If I am doing NIBP, or if I do have IBP, normally these babies, they won't have IBP. I have NIBP, and it is giving me the numbers as 40/12.
Okay, sure. Thank you. I mean, yeah, you've given me a really number which is pushing me to treat, but otherwise, normally I wouldn't treat the number. I look at the baby. This baby sounded very stable in room air, and if the perfusion would have been good, I would definitely probably would have treated. But now considering the diastolics less than 15, they can interfere with coronary perfusion. So you would need to do something. So either you choose to treat the ductus, or you can consider starting some sort of inotrope to correct it. So again, in our
This is what I want to do. If you want to start inotrope, which inotrope would you have started?
So again, it depends on the echoes. If there is if this baby is preterm, if there is a dysfunction associated with the PDA, then I would prefer either dobutamine or low dose epinephrine as a choice.
So dobutamine or low dose epinephrine is the takeaway point in babies with HSPDA with shock. And if you want to treat, don't start with the dopamine or high dose of epinephrines. That is takeaway point. Thank you very much.
A 0.05 and above will be higher dose of epinephrine. So when we are talking about low dose, make sure it's 0.02 to 0.05 to start with, and then modulate with the further function assessments.
Thank you. Thank you for that, sir. Oops. We finish? It's gone. Still, okay. I will just conclude with one thing. Okay, fine. We will stop here then. No, it's fine. We will discuss now the questions from the audience. Yep. Thank you.
Any questions from the audience, please? Sorry if we have to wind up. All 4 sessions. Any questions? Talk.
Already we are running short of time. If there is no more questions, we will wind up the session. Thank you all the panelists for one question. Okay.
Thanks everyone for wonderful presentations. So I want to ask whether you give surfactant for all the babies with PPHN or it is only with babies with specific lung pathology, because PPHN is associated with, could be due to birth perinatal asphyxia or anything. So wanted to know that your personal practice.
So we don't give surfactant for all the babies with the PPHN, but then if you don't have proper recruitment of the lung getting, if you have a bad meconium and recruitment is not enough to, and it has been shown on X-rays or lung ultrasounds if you're doing it, then to recruit the lung properly, we use surfactants. Yes.
So in sepsis also?
Not in sepsis, no.
Not in
if
sepsis,
your lungs are well recruited,
meconium or RDS.
if under recruited, you can use this as an extra intervention to attain the appropriate recruitment of the lung before going one step ahead, a nitric oxide or something like that.
Okay, thank you, sir.
So this is in all the condition where we are dealing with secondary surfactant deficiency and lung is showing a low volume lung conditions. The condition could be aspirations, blood aspirations, severe infections leading on to ARDS, meconium aspirations, where you are having pulmonary disease, is having a low volume lungs, and the baby is having PPH, raised pulmonary pressures.
Thank you all. We are.
Can I have just last quick question? Yeah. I just wanted to know what's your actual experience with use of prostaglandin in this PPHN. Do you have really managed such kind of cases? Because just few days back we have lost a case of congenital diaphragmatic hernia. It was a really bad. This one we were just about to start it and then we just lost because I had nothing worked in that case and we didn't have access to ECMO. Yeah,
sure. So I think you are asking prostaglandins or prostacyclins or either of them?
Prostaglandins.
Okay. So PGE2, like you were saying about the opening of the ductus specifically.
So how many cases have you used?
So I think we had that percentage. I think we had 39% of the babies we had used prostins. I think 11 or some babies we used prostaglandins. So there are studies using prostaglandin prophylaxis, and there are some centers trying proactively starting prostaglandin in all suprasystemic and systemic pulmonary hypertension just as a pop-up wall. But I think in our practice, what we use is if there is a ductus is closing, then only we open up with prostaglandins. Where we usually start prostins only if the ductus is getting smaller and the pressures are elevated, or in cases where RV is severely dysfunction and the pressures are elevated, we sort of keep them on prostins even during the surgery and post-op period to achieve the stabilization. So is that what you are specifically asking? So
because we don't have much experience with that, so I wanted to get some.
So I think you need to monitor. You will need to protect the RV. The reason for these babies to get suddenly sick and die is sudden RV dysfunction when they get into pulmonary hypertensive crisis, and when these babies get even agitated, there is no time to recover them. So that's why having that pop-up wall is very essential, and supporting the RV with epinephrine, melinone is what is essential. And you need to really stabilize these babies. And about prostacyclin, just to add on in the similar light, so we have used iloprost in 5 to 6 babies in 2 cases of CDHS. Again, we've got variable responses. And treprostinil I used in previous center, but I have not in our center. It was not available. So again,
I don't think we have
prostacyclins
in India.
No,
we
I
don't
think it's
have
not
that.
yet. So that's something probably we need to. I know some adult patients are using it, but they are to import from outside. So
thank you all. We are winding up a session. Thank you all the participants and the panelists for the beautiful discussion on hemodynamics. Thank you all.
We thank the speakers and the moderators for their active participation in the symposium. Thank you once again. Kindly note, there's a lucky draw at the stall number 2 of Jowhari Healthcare. We request all the faculty and delegates to visit stall number 2 of Jowhari Healthcare for lucky draw. You might win exciting Apple products, and the winners will be announced today at 3 p.m.
Next up is a roundtable session on surfactant therapy, present and future. We have Dr. Karthik Nagesh to moderate the session.
Dr. Karthik Nagesh is chairman of Neonatology and Neonatal ICUs, Manipal Hospitals Enterprises Private Limited. He is also the chairman, Manipal Advanced Children's Center, Manipal Hospital, Bangalore. He has many publications to his name and is also the recipient of many prestigious awards. We welcome you, sir.
Thank you so much. It's indeed a proud privilege and a pleasure to be here today. I invite my colleagues on the panel, the experts from all over the world, please.
The panelists taking part in this session are Dr. Shivani Shankar, a senior consultant neonatologist, South Paris University Group. Her areas of academic interest are neonatal respiratory care, surfactant, and hemodynamics.
Dr. Giridhar, Professor of Neonatology, Chettinad Hospital and Research Institute. He has several publications to his name and is a recipient of many awards.
And finally, Dr. Akash Pandita is a senior consultant neonatologist from Lucknow. He is the recipient of National Award by ICMR for Best Young Scientist in the field of pediatrics in the year 2020. We humbly invite all the panelists to the dais.
I'm sorry, I just met Dr. Giridhar. Can we make an announcement? He's in the lobby outside, I think. He was just here.
I request Dr. Giridhar to please report to the dais. I request Dr. Giridhar, Professor of Neonatology, Chettinad Hospital and Research Institute, to kindly report to the dais.
Okay, anyway, since Giridhar is just coming, I just called him. Thank you so much, Professor Shivani and Dr. Akash Pandita for having joined us here. So, yes, Professor Giridhar is just on the way here. Welcome, Professor Giridhar, and he's from Chennai. So we have a very, very dynamic panel of experts here. Our surfactant journey in this country, probably I have been very fortunate enough to have been associated with almost from the ring side and from the earlier works in the earlier parts of the 1990s, we have been looking after surfactant, and treatments of surfactants has grown exponentially in this country. I'm going to just do a little brief overview of what we are going to talk in the next 35 minutes or so. So we all know that lung protection is very important and surfactant therapy is very, very important to the treatment of babies extremely preterm with RDS. So typically, these are the kind of gestations now we are looking after more and more in this country as well, in high resource situations, both in the private sector and, as I know, even in some good governmental sectors like PGI, Chandigarh or HGPGI and AIMS, they look after gestations, even at 25 weeks of gestations, where the babies are breathing spontaneously, but they're not apneic, but they still need some respiratory support in many a times. And what is the data is that in spite of giving some good antenatal steroid, which is almost ubiquitously used nowadays, and surfactant administration is still needed to be given about 35 to 40% of these babies. And we learned from the early COIN trial, which was published at the late parts of the decade of 2000s, that in spite of giving early rescue CPAP to babies gestationally less than 28 weeks of gestation, you would still need to give 50% of the time surfactant to these babies to be able to support them better. The support trial also suggested that though you would do prophylactic CPAP, still about 35% of the times only they would not need surfactant. So you would still need to give surfactant. Some meta-analysis later on suggested in the later part of this last decade that in extremely small babies between gestations of 24 to 27 weeks, 60% of the times you still need to give surfactant. So you would still need to give surfactant and you cannot escape it in spite of giving early delivery room CPAP or whatever you have. And for the reason it reduces morbidity and mortality. So I'm going to now ask my expert panelists, Dr. Akash Pandita, maybe to start with. What would you think are the reasons when we need to give surfactant to babies who have been given antenatal steroids and maybe decent resuscitation and early delivery room CPAP?
Thank you, sir, for that very practical question. When we talk about the pathophysiology, the main indication for giving surfactant is respiratory distress syndrome. And the pathophysiology which is there is that there is end expiratory collapse of the alveoli because of the lack of surfactant. Now, when we talk about delivery room CPAP, it takes care of the radius of the alveoli. We all know that the tendency of the alveoli to collapse by Laplace's law is governed by that it is directly proportional to the surface tension and inversely proportional to the radius. Now, when we give this delivery room CPAP, it takes care of the denominator. That is, it opens up the alveoli, opens up the radius, thereby decreases the tendency of the alveoli to collapse at end expiration. Now, when we give surfactant, there is decrease in surface tension. Therefore, the denominator, which is T, that is, it decreases the surface tension, as well as when it is used along with the CPAP, it increases the radius. So both go hand in hand in decreasing the incidence of severe RDS and need for intubation. Now, do we give surfactant to all babies? No. Only when they have moderate to severe RDS, which in objective terms, when there is high FiO2 requirement, according to the latest guidelines, which is more than 30%, or if we do an ultrasound lung where we show that there is actually end expiratory collapse. These are the babies who go on and need surfactant.
Okay, thank you. Now, while you are at it, Akash, would you tell us what are the new ways to give surfactant?
Now this is the age of ventilation. Gone are the days when we used to talk about ventilation. So as neonatology is evolving, we are moving from invasive to non-invasive techniques, and same thing is happening in surfactant. Gone are the days when Ensure was the primary technique for giving surfactant. Now we are moving to LISA, MIST, which is using a thin catheter. And there are other upcoming methods like using LMA and using nebulizers to give surfactant.
Okay, so we have heard, can I just, the slides are not showing up, please. So in fact, we are all very fortunate to have Akash with us today on this panel. He has recently done the meta-analysis on surfactant which got published, and he's going to talk to us a little bit about what he calls his own classification. Can you just tell us a little bit about this?
So when you talk about actually non-invasive surfactant, there is only one non-invasive technique of giving surfactant, and that is nebulization. Right now, we don't have much evidence to put into clinical practice. So if we talk about thin catheters, if you really tell me that it is non-invasive, I don't agree. It is minimally invasive, but it is still invasive. So the only technique which is actually non-invasive is surfactant. So that's why we put up this classification way back in 2016-17, which is the only classification which divides the different techniques into three terms. That is invasive, where we talk about the classical Ensure technique. Then we have minimally invasive techniques, which takes care of LIST, MIST, LMA, and CalMIST, which is a combination of thin catheter and LMA. And finally, the actual least invasive or non-invasive technique, that is using a nebulizer to give nebulized surfactant.
I'm going to just probably demonstrate. Most of us are now using techniques of non-invasive measures or minimally invasive methods of giving surfactant. So, of course, Dr. Giridhar is probably the expert in this, but I'm going to show to many people who are probably not yet doing minimally invasive surfactant or the Ensure techniques, just a short video of how we would do it in our unit. This is classically how we would start CPAP initially. Of course, the baby can be given CPAP through the ventilator or the bubble CPAP. And you adjust the FiO2, and we still wait for 30% as per European guidelines for the FiO2 to increase in the baby developing severe RDS, or babies if they're having prolonged apnea and increase FiO2 right at birth, we would even do invasive ventilation right at birth and watch the baby and try to maintain target saturation. But if the FiO2 goes to more than 30%, these babies would also need to be given surfactant. In the olden days, we'd intubate and keep the baby intubated and surfactant given. But now, of course, we all do the Ensure technique, which our panelists will explain further. So this is a baby we are doing intensive care, ventilated, PICC lines, everything done, and is still waiting for the FiO2s to slowly develop to more than 30% before deciding on surfactant. And more of us now, if babies are just on CPAP and or NIV, we will do LISA technique, and our residents like this third year DNB neonatology resident of us is quite an expert in doing LISA. And we think not much about it, using a simple feeding tube, which is an infant feeding tube we use, or sometimes umbilical catheters, which are stiffened a bit. We would use the LISA technique. And at the end of the infusion, which you can see here, we would just closely monitor the child. And in the insure technique on the other side, there's the other twin we did insure, and you would extubate the baby soon as possible after that, but more about that by a panel of experts here. So I would just go back to Dr. Akash again once more. What would you say? This is the kind of protocol for insure. Do you agree with this?
We don't apart from these steps which are mentioned in the slide, we don't use thiopentone in all the babies. We do use fentanyl or morphine along with the atropine. That's all we use for pre-intubation, and then we give surfactant. Again, we don't have a fixed duration for keeping the babies intubated. We extubate them as soon as possible, preferably within 10 to 15 minutes. Rest, we follow the same.
Dr. Giridhar, would you agree with this protocol of insure, or would you suppose the earlier days when you're doing insure?
I think, I agree with this protocol, but because there is a lot of variation with the pre-meds that is actually required before the insure procedure. And we as a policy don't use morphine and thiopentone, sir. I think most of us, even with Lisa also, I think we're comfortable with 25% dextrose and swaddling. That is what we use before the procedure. And so that, we know that these pre-meds are useful. The ease of doing the procedure goes up, the field becomes more clearer, but they've come with complications. So there might be an issue that, with the babies requiring more positive pressure breaths during the procedure. So we are not comfortable with doing this. Apart from that, the broad protocol, I agree with that, sir.
Dr. Shivani, you have some negative thoughts about insure. We'll come to that later because Dr. Shivani has recently published the insure paper. But nevertheless, your thoughts on the insure technique when earlier days in your unit at Paris, you were doing that. Would you agree with the same protocol?
It was more or less the same protocol. We don't use the same pre-medication. We've moved towards using propofol now, rather a small dose propofol. The idea is not to sedate the child, the baby, too long enough. Use a shorter acting sedative, and you don't want the child to be completely comatose. You just need it to be just comfortable enough, still spontaneously breathing. So really, the minimal sedation needed to get the baby comfortable. That's the only difference.
So we have our misgivings about insure as well. Most of us agree that it has no doubt advantages, but then we would worry very much about things like the baby is hemodynamically unstable. We would be very worried about still doing insure and difficulties in extubation. I remember when insure techniques were published long back and we tried, and one of our DNB neonatology students, we gave a thesis on insure. The average time it took us at that time to extubate the baby was about 10.8 hours, which we subsequently presented at various fora. So these are some misgivings about insure all of us have now. So we definitely realize, and more data analysis has suggested, that even a brief period of intubation can cause the child to have problems later, and chronic lung disease increases. And even now there's data reported that white matter injury in the brain increases if you were to ventilate babies for a very long time, extremely preterm babies, that is. So I'm going to now talk to my experts again about these three things which we're going to discuss more in the next few minutes. Brief tracheal catheterization, more and more of us are using the term called LISA for this, less invasive surfactant administration, and non-invasive surfactant administration through laryngeal mask and aerosolization, of which some expertise is now available. So I'm going to ask Dr. Giridhar, this is the steps in the LISA, which as a standard protocol, most of us have been following. Would you have any suggestions on that?
Yes, sir. I think the candidate for receiving surfactant are remaining the same. I think we have the baby with a clinical diagnosis of RDS, manifesting with respiratory distress, who's stable on CPAP with an oxygen requirement of more than 30% or 40%, whichever cutoffs you are using. And caffeine is universal in these cases. I think we have to go with caffeine. Caffeine 20 milligram per kg has to be given. And then option of, I use 25% dextrose and analgesia in these situations. Sucrose right now in India, it's not available. It was briefly available. Right now it is not. When atropine, I have used in some situations. Basically, people who have used atropine on a long-term basis, they have told that the bradycardic episodes which occur during the procedure are ameliorated with atropine. So I think atropine has a role there, but I have not much experience with that. And the procedure, I think I maintain these babies on nasal CPAP. But the video just shown earlier, I think the video which you had shown the baby to be on bubble CPAP. I want these babies to be basically on ventilator CPAPs. The basic reason being that if there is any problem with the babies don't breathe well at that point of time, I would just briefly shift them over to NIPPV and I mean, that would actually give some positive pressure breaths. So I prefer having these babies who are receiving LISA on ventilator CPAP rather than on bubble CPAP. So the method which we actually use in our unit is we use the feeding tube. When I do the procedure, I would prefer, I don't actually stiffen the tube by refrigerating it earlier. Although, I mean, it also doesn't work well. In fact, the refrigeration, if you keep it for a longer time, taking it out, and when it might remain more stiffer for some time. By the time that we start doing the procedure, sometimes it becomes very lax and becomes again a very flexible tube. So if you have expertise in this procedure, I think doing it with a simple feeding tube actually works out very well. And Miguel's forceps also, earlier we have tried using, we have dedicated forceps in the unit for doing this procedure. But now with because people become better with the procedure. I think after having done many LISA procedures, now we are able to do it more or less without using the Miguel's forceps. We are able to introduce it perfectly. So so once the baby is on CPAP, we insert the laryngoscope, visualize the airways, put in the feeding tube inside. Then once the feeding tube, once we know that it has just crossed that vocal cord, that is the time we start administering the medication. So medication, because I think because of cost constraints and other things, I mean, we are more or less using the bovine surfactant and not the porcine surfactant. I think probably there might be a discussion on this later also. So I think bovine surfactant being a high volume one, we are worried about the reflex which happens. So during the procedure also, the feeding tube is there in place. Before the procedure, we aspirate the stomach. And after the procedure, with the feeding tube, we aspirate and see whether some surfactants entered the stomach so that we know that some reflex has happened. And across studies also, it has been clearly shown that with the high volume surfactant used like a bovine surfactant, reflex is more when compared to the low volume surfactant like the porcine surfactant. So this is the rough method which we use. And I've also, since there is an availability of a dedicated catheter, that is the surf cath and LISA cath is also independently available. So we can use those things. It increases the ease of doing the procedure. So that is how we do it in our unit, sir.
There are some 2-3 contraindications to the standard procedure which you have mentioned. Akash, this is the meta-analysis or maybe the RCT which you published. Some comments upon this, your main findings in this.
So we have 6-7 papers on surfactant, and this is initially the largest RCT which was on this topic, which compared Ensure versus the LISA, or which I called as Assure, that is surfactant without endotracheal intubation, in which we demonstrated that the need for mechanical ventilation was almost reduced by more than half. We had less DPD, although the mortality was same. Then we followed up with a systematic review and meta-analysis, which confirmed our findings. And finally, we had one network meta-analysis, which I will be talking about at the end of all the procedures. Just to add a comment to what Dr. Giridhar has added, that we continue these babies on bubble CPAP. We increase the CPAP pressures by 1 to 2, because when you are opening the mouth for giving the surfactant using thin catheter, the pressure is going to drop because now you are opening the mouth. So whenever you are using LISA, increase the CPAP pressure by 1 to 2 centimeters. That will catch up with the pressure drop, which happens because of opening of the mouth. So once you are finished with the surfactant, come down on the previous settings. That decreases the need for positive pressure ventilation, need for NIPPV, and need for positive pressure breaths. The other thing which is used to decrease the reflux is use porcine, because it is more concentrate, and keep the head elevated by 15 to 20 degree. That decreases the incidence of reflux by a large chunk. Thank you.
Shivani, I'm going to ask you, Dr. Giridhar mentioned bovine surfactant. Traditionally, Lisa is meant for porcine surfactant at the rate of 200 mg per kilo. You have any comments on this because of low resource situations? Sometimes do you have, because I have not really thought about, because whenever we have done Lisa, it's with a porcine surfactant. Both you and Akash need to comment on that.
Well, I have to say I have zero experience with bovine.
I have not had much experience on bovine surfactant doing Lisa.
Yeah.
But Akash, any experience on that?
Definitely porcine is better because it is more concentrated. The other thing is, do not use these fancy, it may be useful for some, but I don't found any addition with using these fancy catheters, because there you are spending 2,000 to 3,000 rupees. Why don't you use those extra rupees in giving that porcine surfactant?
Okay, so the meta-analysis, of course, definitely favors Lisa over Ensure, both in terms of reduction of intubation, the risk of death or chronic BPD, and of course, a lot of reasons why Lisa is much more preferred now. So I'm going to give a hypothetical situation now. We'll go on to a case-based discussion now. There is a lady who has probably come at 24 to 25. Again, as I said, in many high-resource situations in this country also, even in high-resource government sectors like PGI, we are seeing gestations of 24 to 26 weeks. Antenatally not steroided mothers, suddenly not booked, she comes in, she's in labor, and this mother has likelihood of delivering the baby. So a poll to maybe the audience first, it's likely to be a male baby, so therefore likely to be severe RDS probably. Are you all thinking of giving surfactant straight away? People are doing surfactant in their units. Anybody who wants to give surfactant straight away, not waiting for the baby to develop more oxygen needs? Raise your hands if somebody says A. Not many. So B. Yes. So the poll is more in favor of B. We want to wait for surfactant. So the panelists here, the experts, please tell me, starting with Akash and Shiva. Yeah.
I will give surfactant right away. Now, can we improve this technique? Yes, if we have a lung ultrasound available, we can make it more objective. But the incidence of RDS in a baby who's 24 weeks is 85 to 90%. So 90% of the babies are going to need surfactant. And when this baby has no antenatal steroid, the incidence is going to be high. So I will not wait. I will directly give surfactant.
Dr. Shivani?
I agree with Akash. The likelihood that this baby is going to require at some point surfactant early on is very high. But I would still do a lung ultrasound to confirm my diagnosis. Also to have a baseline lung ultrasound to see from where it goes after that. Yes.
Very nice. Many high-resource units in this country have a lung ultrasound and the expertise to do that at the bedside. Giridhar, of course, works in low-resource and high-resource both. Giridhar, what would you say?
I don't have access to lung ultrasound right away at birth. So, but still, this babies would be stabilized on CPAP. And I wouldn't say that I would give it right away, but I would give it in any way in this situation. I won't wait for a diagnosis of RDS to be there. In terms of an X-ray also, I would give it off.
We are all agreed that we need to give surfactant selectively.
Yeah, only thing is I would tend to ship these babies to the NICU and then give it rather than give it in the delivery room. Because access to an ultrasound in the delivery room, it's fine. But I would tend to ship these babies on CPAP to the NICU and give surfactant in a controlled setting, irrespective of the diagnosis.
So I have this contention that in my units traditionally till now, we give surfactant based on these European guidelines. The baby reaches 30% or more, just FiO2. On CPAP or NIV, we would then think of giving surfactant. But then I understand the earlier, the better you give it. And typically, if you look at this policy, you would then have to wait for the baby to reach that. That may take, as you saw in the earlier video, like I'll show you another video here, that we would sometimes take about 4 hours or sometimes 3 hours or so for the baby to reach that much. Sometimes you have to wait for the X-ray and maybe then a lung ultrasound. But if you go by this criteria, you would be delaying surfactant a little bit. So this is just a video for some of us. Maybe Girdhar, you can explain the video.
Yeah, I think we see the neonatologist administering surfactant in a child who is on CPAP. The baby is there on CPAP. So the laryngoscope has been inserted, and I believe it's your hand, sir. There?
Yeah, this is our department.
Okay. Yeah. So Dr. Karthik is there. I think we see the tip of the. I think now the catheter is being inserted. We know that the catheter length has to be earlier known. with using the NTL+1 formula, or the tip to lip to 6 centimeters. That is the formula. And once a catheter has been inserted, surfactant is now being administered. Yeah. So generally, that's a preference. People tend to use small aliquots also, like probably 1 ml aliquots. They give it slowly over a minute's time. Otherwise, we can push it. You don't have to give it as small aliquots. We can give it as a bolus also slowly. But generally, the procedure gets completed between 30 to 60 seconds. That is general duration. The baby continues to be on CPAP.
So this is the basic component of LISA, just for people who are still not doing it, is it is uninterrupted NIV, whether it's CPAP or NIV you're giving, and you would need to introduce the LISA catheter and the direct laryngoscopic vision. And once you're below the vocal cords, we are using, of course, a kind of frozen infant feeding tube, which is not really the ideal. We should be ideally using the surf cath or the LISA cath, which is there. The picture is seen on the right side there. You can see it's more stiffer and 4 French gauge size. But nevertheless, we make do with whatever is available because the cost of these catheters is high. And at the end, so as soon as the introduction of the catheter is done and you're very sure, then you would probably remove the laryngoscope, fix the finger of your finger on the catheter at the alveolar margin, you keep it fixed so that it doesn't move away. Then you connect the syringe loaded already with the surfactant and then give it very slowly over 30 to 60 seconds. And at the end of the procedure, you take, if you saw me doing that, you will take a little bit of air and just push the air into the catheter as well, so that the rest of the surfactant also from the catheter goes into the lungs. So I have a question of Dr. Shivani. She is probably not a very strong proponent of LISA. Can you just tell us why? She was telling me she has some reasons.
So with all due respect to all the studies done before and all the meta-analysis, I think what they've been able to show is that LISA is superior to intubation, surfactant, some mechanical ventilation, variable, and then extubation. So might LISA be better than, can you go back, please, sorry. Why could LISA be better than Ensure? So the claims would be it has better CPAP transmission. The surfactant distribution is better because the baby is spontaneously breathing. It avoids unnecessary injury because of the ventilation. It might be comfortable because it might be shorter. And there's less airway trauma because of the ET tube. So I'd just like to draw your attention to the diagram just next on the right. On the first round that you see is an adult trachea with a flexible bronchoscope inside it. So it is 25 millimeters with the bronchoscope in the middle. The second is a term neonatal trachea with a 4 French catheter in it. And the third you see is a preterm neonatal trachea with a 2 millimeter, which is about between 2 to 4 millimeters with a 4 French catheter in it. So based on this, can we go to the next slide, please? My contention is CPAP really transmitted better through an obstructed airway? We know that the resistance is proportional to 4 times the power of the radius of the tube. So we can imagine that whatever pressures, even though we increase the pressures because of the mouth opening, even if it is 2 to 3 centimeters of water. I mean, it's not just the leak from the mouth, it's also the resistance with the tube being in there, which would impair better CPAP transmission. The surfactant is better distributed. So we are looking at surfactant being distributed in a spontaneously breathing baby with CPAP through an obstructed airway versus if you do Ensure properly in a spontaneously breathing baby with mechanical ventilation, gentle ventilation via an ET tube. So I think physiologically, it seems more likely that the distribution is better via the ET tube and better controlled pressures. avoidance of injurious ventilation. Now that we use volume guarantee, I'm not sure that is the case anymore for the 5 or 6 breaths that the baby takes via it. Is it comfortable? I'm not sure that the pain is related to the actual ET tube going in. It's related to laryngoscope, it's related to the exposure. We see that all the events, bradycardia, hypertension, or whatever, especially in non-sedated babies or non-swaddled babies or whatever, is related when we start exposing and not really when the ET tube goes in. So I'm not sure that is a real claim. And less airway trauma, if you leave the ET tube for 5 minutes, 10 minutes and take it out, I'm not sure that really causes trauma. So I think we can be reasonably sure that LISA is better than intubation, ventilation, intubation, surfactant, ventilation, extubation, but I can't see why it would be better than intubation, surfactant, and extubation.
So you can see where we are heading. We all realize now that giving surfactant early is important in the typical case scenario which you're discussing, and preferably don't delay it more than 2 to 3 hours. But FiO2 requirements, according to European guideline standard, if you're waiting for, is going to take some time, maybe even more than 3 hours. So the question is, how do we give surfactant earlier? So that is where, again, I'm going to come back to your statement earlier that we can use lung ultrasound, Dr. Shivani. Please let us know more about what you're doing.
Yeah, exactly. So it was after the meta-analysis came out, the Cochrane review, when we looked at our practice, what was our time to administer surfactant in babies who required it, who went on to achieve 30% FiO2 requirements. And surprisingly enough, most of it was around 6 to 7 hours, even going up to 24 hours, 12 hours. So we wanted to get our time to surfactant under 3 hours. So we had this lung ultrasound we were interested in. It was a couple of years we were doing it. So in the beginning, we just looked at all the lung ultrasounds in all the babies and divided them into groups requiring surfactant on FiO2 requirements and not requiring. And with a very simple, really simple semi-quantitative score, we were able to predict surfactant requirement in less than 34 weekers with a precision of about 80 to 90%. And if you bring the gestation age down to 28%, the specificity and the sensitivity is very, very high. So going from there, we started administering surfactant before the FiO2 level went up to 30%. So it's part of our golden hour protocol now. So in the first hour, when the baby comes in, when everything, the line placement, everything is going in, when the caffeine has been loaded, when TPN has been started, you do your lung ultrasound. If it's unequivocal, superior to 8, you give it directly now. And the best part, what I think is for the resident on call, it's a less stressful situation. It's not a baby who's already become unstable. You have the time to prepare your stuff and take your time to do it calmly. So just a graph to show that even lung ultrasound can be useful to predict surfactant retreatment. This time the lungs ultrasound score would be more than 10, and that would predict whether the baby would go on to require a second surfactant dose or not. So this is our data from Esther, the echo-guided surfactant therapy. And you can see it's the time to surfactant was diminished to less than 3 hours. So there was one contention that maybe we were using too much surfactant in too many babies. Would we be giving surfactant to babies who probably would not require it? So in the pre-echo period, that's the gray bars, you can see that about 20% of all admissions, it's not just premature babies, or all admissions less than 34 weeks required surfactant. And in the post-lung ultrasound, the black bar, it did not change that much. We looked in our consumption of surfactant vials, and that remained nearly the same. So it wasn't as we weren't giving more surfactant. And in the 4-5 years we've been using it, about once a year, it happens that on the lung ultrasound criteria, we don't give the surfactant and the baby fatigues and might go on to require on FiO2 requirements, which might be attained after 3 hours. So this is just a protocol for our enhanced Ensure protocol, which actually Ensure has been around for a long time, but there is no particular guideline to tell you what timelines to do what and how to go about it. Everybody does it according to their own comfort level, if I might say. So for the enhanced Ensure, you prepare your material, laryngoscope, ET tube, end-tidal CO2, etc. Analgesia, very important. So we use propofol, as I said. You confirm your oral intubation with, and the timer goes on. I have a small video, yeah, that would be good.
Video,
yes,
can I share your video? Yeah.
Yes, please. So this is a 25-week baby who's less than an hour old now. So we have the monitoring here. We have our ventilator. So it's getting CPAP via the ventilator, as Dr. Grish said. So that's propofol being injected. So the baby's already had his lines. So there's the umbilical venous catheter in place, TPN going in, caffeine loaded. Unfortunately, in this baby, we did not manage to put in an umbilical arterial line. I think it was decided not to. Otherwise, we would have had the arterial graph as well to show that with propofol, actually, we do not see hypertension as some of the teams have reported. So that's the exposition. And I don't know whether you can appreciate, if I may comment, with the last Lisa video, you can see the baby is moving much less. So the baby is spontaneously breathing, but calm enough to let the laryngoscope go in and let you do the procedure without struggling. So there your end tidal CO2 goes in, and you can look at the scope, monitor, and there's your graph, and then the timer goes on. So that's our timer going on now. So volume guarantee, 5 mils per kilo. And just talking about surfactant reflux, we see it, even though Poractant has a lesser volume, we see it too, even with our Ensure. You'll probably appreciate it on the video. So through the lateral, so it depends on the ET tube that you use. You can either use the lateral channel or continue the mechanical volume guarantee ventilation and start giving surfactant, and you will see there is a bit of reflux in the ET tube. So when that happens and you see that the volume curve starts to flatten out, you wait a little bit, wait for it to get distributed, and then restart again. So all this time the timer is on. This is your real Ensure time. You can see the baby starting to move a little bit now. So the effect of propofol is weaning off a little bit. I don't know whether you can see under the hand, the big hand, which is there, you can see chest movements. The baby is still spontaneously breathing. It's a shame we don't have the sound. There was a nice music behind it. And there you go, improving compliance. So that's our NIRS, which didn't show any difference in the cerebral NIRS. So we don't fix the tube. So you just check that the baby is breathing, and it's usually 5 or 10 breaths, not more than that. And the tube comes out. There you go. And we as a policy, we've decided lately to wean them off after Ensure on some dual pressure mode, either by PAP or using your infant flow driver, or just an IPPV with some dual pressures. So that's it. So, I mean, you can't compare this Ensure with the old Ensures where you have, even though it might be 2 to 3 hours of mechanical ventilation, it wouldn't be the same in my view.
So it's like Ensure with a very short time on Ensure,
Yes. So,
and within 5 to 6 beds you would extubate.
yes. So this baby, I don't know whether it was shown, the average, it was a condensed video. It took 6 minutes. The 6 minutes the tube stayed in, and our the latest study we did in our unit, it was from 3 minutes to 15 minutes. So
so that's fantastic. So this is just another thing. Most of us now, 4-5 years, have been using lung ultrasound. It's not very great rocket science, but some of us are also using criteria where, similar to your results, we also found in units like ours that surfactant needs can be described better if you were to use lung ultrasound score.
Absolutely.
So that's a great learning now, the Ensure technique for this thing. So we have just 2 minutes left now, so we can probably discuss a little bit more beyond neonatal RDS. What are the other reasons for giving surfactant? So starting with Dr. Giridhar, would you use surfactant for any of these indications?
Yes, sir. I don't use it routinely for meconium aspirations. In case the meconium aspiration, there is an aspiration, the lung is white and the oxygenation index is pretty high. Then I tend to use, I consider giving surfactant. Baby is having PPHN. Only thing is I prefer larger doses, like 150 to 200 milligram per kg in such scenarios. And I don't wait. Generally these babies are on ventilator. I don't rush in to reduce the settings also, but only certain scenarios of meconium aspiration I use them. In terms of pulmonary hemorrhage, frankly, I have not used it so far. We know that pulmonary hemorrhage could be a complication of surfactant also, the changing lung dynamics that happens after surfactant administration. Pneumonia, because diagnosing pneumonia itself is very difficult, at least in the first initial, at birth. So I think if the X-ray is consistent with RDS-like pattern and the baby is having significant respiratory distress on CPAP, I would still go ahead and give up surfactant, even though the diagnosis could later become pneumonia.
Briefly now, Akash, would you use in any of these indications?
I agree with what Dr. Giridhar said. In MBS, if it is a secondary surfactant deficiency in X-ray picture is synonymous, we use. Pulmonary hemorrhage, pneumonia, very rarely.
Okay, I'm going to skip some slides, but I want to go on to what Dr. Shivani is doing. Bronchoalveolar lavage for surfactant, now they're going to publish the data very soon. Can you just explain, please?
Yeah, it's just to help us. As you said, we can't use it on every I have to go back to the neonatal definition of ARDS. I'm sorry. For the time being, we were still using the adult or pediatric definition of ARDS, whereas we know that our neonatal population is not the same. So the European Committee came up in 2017 with the Montreux definition of NARDS, which helps us to decide what is obviously taking away the RDS and the TTN babies, which helps us to decide what is the extent of your ARDS in your neonatal population, which would decide later, would you do anything else other than just mechanical ventilation? So yes, apart from just giving boluses of surfactant, we know that the reason why they develop ARDS is there is some surfactant catabolism because of maybe bile acids or cholesterol or the free blood or inflammation related to that. So our unit practices bronchoalveolar lavage just to try and, in severe ARDS, neonatal ARDS, to try and clear away these inflammatory products. And what we found, surprisingly, is when you do the lavages, sometimes you don't need to give the surfactant boluses that you would have given otherwise for a severe ARDS. So that would be more than 40-50% FiO2 and index of oxygenations more than 8. So our protocol based on Dagaville and Romanoli is using 75, I'm sorry, there's a typo, milligrams per kilo of surfactant diluted in 15 milliliters of normal saline with aliquots of either 1 milliliters per kilo or 3 to 5 milliliters. You prepare the baby, recruit adequate sedation, pre-oxygenate the baby, and then you start injecting these aliquots, wait for 5 to 10 respiratory cycles and aspirate it. You don't aspirate everything because some of it is absorbed, but when you aspirate, you do see that you are clearing away the meconium, or you're clearing away some of the blood, or and then you repeat it. And if the ARDS persists, you might go on to need a surfactant bolus to improve the oxygenation. Just talking about recruitment, I forgot to just mention there are some studies going on regarding INSURE to do intubation, recruitment, surfactant, and extubation. So we're waiting for these results to see if that improves any of the outcomes. Yeah.
Great. This was just to sensitize people that apart from RDS, we're using a lot of surfactant in our indication. Most of us use that. So Akash, I'm going to come back to you with one last question. Laryngeal mask airway, you have some exposure to that using surfactant with that?
Quite often in our country, the expertise for intubation is not available, especially in SNCUs in other places. They are, in fact, LMA we use even in difficult airways. So in those cases, we can use LMA, which is again a less invasive technique compared to the standard INSURE technique. And it has been shown to be beneficial, and the results are comparable to LISA and INSURE for giving surfactant. The only caveat in using LMA for giving surfactant is babies who are less than 1.5 kgs, because as of now, we don't have a size which fits there. But there are anecdotal reports which have used LMA in a baby as less as 800 grams. So it is one of the easiest and safest technique to
It's wonderful work. Giridhar, you have some idea about aerosolization, because some modest benefits maybe we don't know much about it.
See, I'm very skeptical about aerosolization, especially when it comes to bovine surfactants. In fact, I've been through a sponsor which we got from the bovine surfactant company. We tried aerosolizing using this vibrating membrane nebulizer. This is not the e-flow system, the another system called AeroNev. And that system, we tried it, using it, but it was not getting aerosolized that much. Okay, so I'm not really skeptical whether, because for aerosolization to happen, the surfactant has to be slightly more viscous, which is more ideal with your porcine surfactant or some other surfactant which could be coming up later, like your synthetic surfactants. I'm really skeptical whether it is going to happen with your bovine surfactants. Of course, there's a study with calf-length surfactant aerosolization, but when we know that aerosolization, it brought down the intubation rates in the first 72 hours, the oxygen parameters improved. But trying it in a pragmatic way, looking at it in a pragmatic way, I wouldn't trust aerosolization as an alternative to LISA or INSURE.
Some of the points are well taken. In fact, Veena Sood, my colleague from Michigan, has published the phase 2 study trials on surfactant using bovine. But we are going to start probably with some good funding available on porcine surfactant with standard nebulizers, the aero nebulizations which are available. So probably some people in the audience, if they're willing to want to join this study, are most welcome to write to me and probably get in touch with us. We're hopefully going to start this project. So with this, I must thank all my experts. They've been brilliant. Thank you so much.
Thank you.
And it was wonderful discussing. If you have time for any questions, most welcome. Otherwise, we can be contacted anytime later. Thank you so much. It was a pleasure. Thank you so much, Dr. Manoj and Dr. Vishnu Mohan, for giving this opportunity, and my colleagues in the IIP Neocon. Thank you so much.
Excuse me, sir.
We thank moderator Dr. Karthik Nagesh and the panelists for their valuable contributions to the session. Thank you.
Sir, my name is Praveen, sir. I'm a DM resident from Madras Medical College. I have a question regarding repeat doses of surfactants, sir, both in MAS and in extreme premature, which is having RDS. When you will consider regarding the repeat dose of surfactant?
Criteria which we actually use for giving the surfactant, that is the criteria which we adopt for giving a repeat dose. If FiO2 is going to be a criteria, then that will be the criteria. So generally, we assume the baby is on CPAP, requirement of more than 6 centimeters. FiO2 requirement is more than 30%, we administer. That is what we do. Repeat also, the same criteria is being met here. The only issue is with the repeat doses, always look for alternate reasons why the baby's oxygenation has not improved. and why the lung, because there could be a PDA that has opened up. Other reasons could be there. So always have a cause, I mean, identify the cause. And if you show that the subsequent, non-improvement, the first dose is also because of RDS, evolving RDS, then you could contemplate giving us repeat course. And so for meconium aspiration syndromes, routinely, we don't administer multiple repeat courses because the dosage that is actually required in the first place is going to be higher. When madam uses lavage, we use it the bolus dose of 150 milligram per kg. We cannot keep on giving it. We see the response in the first place, and then if our parameters are not down, then we might contemplating depending upon the scenario which we are facing in meconium aspiration. Yes,
Yeah, yeah, sorry. I just wanted to make a comment about meconium aspiration. They are usually near-term babies who don't have a problem with their own endogenous surfactant production. It's just that something's happened that it's getting catabolized and not being efficient. So once you leave them, let them some time to recover, the endogenous surfactant production restarts. And it takes a few hours, maybe 12, 24, 36 hours, but they don't need repeat surfactant doses. Yeah.
Excuse me, ma'am. I have a question. For the repeat dose of surfactant, which you told just now, like after how many hours do you go for, you think that if the FiO2 requirement is more, or the lung ultrasound for the scoring, like you prefer doing after how many hours?
So when you give exogenous surfactant, the poractant, its half-life would be 6 to 12 hours, and that's the time that the endogenous surfactant in a preterm baby would start getting produced. So we would not give it before 12 hours.
So if we are looking for the lung ultrasound scoring like before giving first dose, so we need to repeat the lung ultrasound after 12 hours.
It could be lung ultrasound or FiO2.
Yeah,
lung ultrasound for a redosing might not work out that well because we've already administered surfactant. So the changes that we expect in the using the first ultrasound may not hold good for the second redosing also. So FiO2 requirement is what I think we
lung ultrasound. If you do use lung ultrasound, it wouldn't be just on the score itself. It should be a worse score compared to your first pre-surfactant score.
Your clinical examination cannot be replaced. It is the increased work of breathing in FiO2. It remains high. That's an indication. That is the main indication. Rest all are supplementary.
So
Nothing
scoring
more.
like you use more than 10 or like for the first dose also?
The first dose, it is more than 8.
More than 8.
Yeah. And it's not because you found 7 that you will not give it. If it's 7, you will go again in half an hour, 1 hour to see which way it is going.
So if after 12 hours, the score is 10. If it is same 8, if it was 8 initially and it is again 8. So we do not repeat like.
Well, it depends on what your FiO2 is doing.
If the FiO2 is okay, it is.
If FiO2 is okay, you leave the baby alone.
Okay, but if it has gone from 8 to 10, but FiO2 is okay.
I mean, if it's gone from 8 to 10 and the FiO2 is okay, why would you do a lung ultrasound in the first place?
Yeah. Yeah, if the baby is clinically stable.
Yeah.
So we need not.
I mean, lung ultrasound is to help you go further in your clinical examination. It all starts from looking at the baby. So it's how we think about it is you observe, palpate, auscultate, and then put your probe. It's not just put your probe.
Thank you.
Extremely sorry, we are running out of time.
Sorry.
Thank you.
Thank you so much.
Thank you once again to the moderator and the panelists for their interesting session. Next, we have a 20-minute talk on evidence-based choice of broad coverage pneumococcal conjugate vaccine in practice by Dr. C. Jayakumar, Head of Pediatric Department, Amrita Institute of Medical Science, Kochi. We have Dr. Jayachandran, Chief Consultant, New Bless, Maulana Hospital, Perindalmana, as a moderator for the session. We humbly welcome you, sir, to the dais and also to introduce the speaker for the session.
Hello. Very good afternoon to you all. Thanks for having this opportunity. We are moving on from hardcore NICU topics to an OP-based but very important topic of evidence-based decision in choosing the right pneumococcal conjugate vaccine in practice. And to present this, we got an expert in this field, Dr. C. Jayakumar, who is a professor of pediatrics at AIMS Cochin. Very good leader, very good academician, past president of IAP and of Kerala, and personally a very close friend of mine. Over to you, sir.
Most respected organizers of this meeting, Dr. Manoj, Dr. Vishnu, and my dearest friend and chairperson of this talk, Dr. Jayachandran. And at the outset, I would like to thank the organizers for giving me the opportunity to present this topic to this August conference. You may wonder what is the relevance of these topics in a conference like this. So you know that strep pneumo is an important infection in children more than 3 months of age. Sometimes you can have infections due to strep pneumo in newborn babies also. And to prevent that, what are the armamentarium, what are the drugs available, what are the methods available to prevent this? You can give this vaccine even to the pregnant women. In that way, you can prevent this strep pneumo infections in newborn. The questions are, now there are so many vaccines available, PCV10 and PCV13, and which one you have to choose for this to prevent this dreaded disease of strep pneumo infection. So the topics that I'm going to discuss are So many PCVs are available, PCV10 and PCV13, and PCV13, you know, is having maximum coverage. So which one we have to select, and what's the reason for selecting this PCV, which is having maximum coverage? So that's the topic of discussion today. Okay. Questions are, all need protection against strep pneumo. What are the available pneumococcal conjugate vaccination? Is a PCV that offers broad coverage is desirable. Whether all PCV should include serotypes 3, 4, 6A, 19A, and 4. What is the evidence-based decisions important in choosing the PCV? Do IgG and OPA after vaccination matters? Whether product switching is allowed? In need of booster doses, can PCV impact data? Select can decide whether choosing the right PCV. Even heroes need protection against strep pneumo infection. The WHO says that highlighted the vital role of healthcare workers, noting that their availability, accessibility, and acceptability and quality that define the standard of healthcare system in a time of crisis. In pandemic, the stability of the healthcare system would be threatened if frontliners are affected or they become ill. So healthcare workers are more susceptible to infections due to influenza and also due to strep pneumo. So ARI causes absenteeism among healthcare workers. Health problems negatively impacts the productivity, efficiency, and patient safety and quality of patient care. So healthcare workers are at risk of developing infections due to influenza and also due to strep pneumo infections. So a vaccination with the PCV13 among healthcare workers, you can reduce the infection rate by 2 times. Asymptomatic IDH reduced by 2 times. Respiratory pneumococcal infections reduced by 2 times. And overall reductions of infections reduced by 2 times by using a vaccine. So this is a incidence of co-infections and super infections hospitalized patients with COVID-19 of 989 consecutive subjects. 7.2 had other microbiologically confirmed infections. Of this, we get 7.2% that patient hospitalized due to COVID-19 had other microbiologically confirmed infections, and 57.1% of community-acquired pneumonia were due to strep pneumo infections. So that is the magnitude of this problem. So strep pneumo infections are very common. and patients with the community-acquired co-infections, hospital-acquired infections, superinfections had worse outcome. So if they have infection with strep pneumo, they can have worse outcomes. So PCV13 at any cost won't prevent COVID-19, but more than 65 years of age, if they are PCV vaccinated, 32% lower incidence of any COVID-19 hospitalization and 32% fatality reduction if they are vaccinated against strep pneumo. So that's the importance of this PCV13 vaccination. So what is the recommendations of this vaccine by the IAP? So we can have these vaccinations from infancy, childhood, adolescence, and more than 15 years. The only vaccine that is recommended throughout age is strep pneumo vaccination 13 than other vaccines, because recommendations are not there for use of that other vaccines in older people. So mortality rates from pneumococcal disease, if you are not using this vaccination, invasive pneumococcal disease is 20%. And among this, highest rate is seen in infants. In developing countries, that may be as high, 50% chance for developing meningitis. Now, the commonest cause of meningitis in the post-Pentavoc era is strep pneumo infection. Survivors of meningitis, if they survive, they can have long-term sequelae in the form of hearing impairment, mental subnormality, hemiparesis, quadriparesis, and seizures also. So this is a spectrum of pneumococcal disease. We can say the commonest manifestation is otitis media, then comes pneumonia, and then IPD. The IPDs are sepsis, meningitis, and bacteremia. You know that in a child who is having fever without any focus, and the child is not vaccinated against strep pneumo, the commonest cause of focal bacteremia is strep pneumo infection. I repeat, a child who is not vaccinated against strep pneumo, and if there is fever without focus, the commonest cause of focal bacteremia is strep pneumo infection. So available conjugate vaccinations are the same, similar, or equal. So PCV13 has 3 additional serotypes, that is 3, 6A, and 19A. And the older PCV lacks 3, 6A, and 19A. These 3, 6, and 19 are very important strains that has been covered. New PCV don't contain 3, 4, and 18C. So antigen concentrations of each individual serotypes used in PCV13 is higher compared to other PCVs. So antigen concentration for majority of serotypes of PCV13 is more than older PCV10. So conjugation technology is also very important in the genesis of antibody production. So there is broad coverage for this PCV13. So this is a study conducted by ICMR that shows that meningitis is very common in India due to strep pneumo infections. And also 82% case of pneumonia also due to this strep pneumo infections. And so meningitis 82.9% due to strep pneumo, 14.4% due to hip even in the post-Pentavoc era. And Neisseria meningitis is very, very low incidence, only 2.7%. Highest prevalence is seen in children in the age group of 1 to 11 months. Conclusion, less than 5 years. And highlighted the predominance of strep pneumo as a cause of meningitis in young children. So this is a Indian picture of pneumonia and pneumonia deaths. So strep pneumo infections, 23% of the world's total occurs in India. So 0.37% episodes per child per year. So case fatality rate, you can see 3.6 million case of severe pneumonia and 560,000 pneumococcal pneumonia. And death is also 350,000. And India, it is 105,000 case of pneumonia death due to strep pneumo infection. So this is the Indian picture of strep pneumo infections in otitis media. Is protection desirable? Most common cause of otitis media is strep pneumo. No doubt about that. This strep pneumo infection can lead to otitis media can lead to hearing impairment and impede the language development of children and also increase the healthcare cost. Acute otitis media is often associated with the strep pneumo and nasopharyngeal colonization. So vaccine effective against strep pneumo should have broad spectrum coverage. So these are the comparison of the various vaccines. You can see that this PCV13 contains 4, 6B, 9B, 14, 18C, 19F, 23F, 1, 5, 7F, and in addition 3, 6A, and 19A. The older PCV don't contain 3, 6, and 19A, and then 3, 4, and 18C are not present in the newest PCV10. So now let us see the importance of these strains. Strain number 3. The causes necrotic pneumonia and empyema. Even now, we have cases of empyema, and the commonest cause is strep pneumo and staphylococci. And serotype 4 is an outbreak serotype. Serotype 18C, this is an outbreak serotype. And 6A, so 6A may lead to resistance to antibiotics and also IPD and pneumonia and acute otitis media. 19A can cause IPD, pneumonia, AIM, and multi-drug resistance. So serotype 1, pneumonia and outbreak serotypes. Serotype 5 can cause invasive pneumococcal disease, acute otitis media, pneumonia, and outbreak serotypes. And 6B can cause again IPD, pneumonia, and AIM. And serotype 7F can cause IPD, pneumonia, and outbreak serotypes. 9B and 14 again cause IPD, pneumonia, and AIM. And serotype 19F, IPD, pneumonia, AIM, and 23F cause IPD, pneumonia, and AIM. So this is the coverage of various serotypes. You can see this 13 has maximum coverage compared to the other one, as per studies by Nisarga, Mahendra, and Vandana. So 13 covers most of the strains compared to other new serotypes. The question number 2, broad spectrum of the disease burden. Is PCV that offers broad coverage is desirable? No doubt about that. Strep pneumonia is the leading cause of meningitis. Strep pneumonia is responsible for pneumonia and death. Protection against strep pneumonia, otitis media is also very important. So these are the vaccine type of pneumococcal serotypes available that causes disease burden. You can see that 156B, 7F, 9B, 14, 19F, and 23B, and then 3, 4, 6A, 18C, and 19A. So coverage difference in PCV 13 versus newer PCV is 7.6 to 10.7%. So PCV 13 have more coverage compared to newer PCV. Compared to older PCV, the coverage difference is more, 12 to 23.3% difference. So that difference is there in the compared to the new PCVs. Serotype 4. So it causes invasive pneumococcal disease. It's an outbreak serotype. And what are other features? Brief colonization and survive better in the environment. So you have to include this strain also in the vaccination. Otherwise, this disease may spread. So outbreak serotypes are responsible for pneumococcal disease in close settings in the post-antibiotic era. Need for early recognition and implementation of public health measures in order to interrupt the transmission. So you should have include this strain in the vaccine. And another important strain is 18C. It can cause meningitis and bacteremic pneumonia. So responsible for epidemic cycles. Higher case fatality rate, prolonged hospitalization due to 18C. So newer PCV don't contain 18C. So this is the IgG level after pre and post vaccination boosters in PCV 13 and PCV 10. You can see initially it's only this much amount of antibodies there, but post booster, see the difference. This is for 6A and this is for 19A. So the sad fact is that newer PCVs, they don't promote, they don't say any booster dose, only 3 primary doses are there. They are not suggesting any booster doses. As a result, antibody production may not be that good. So then specific serotype B cell memory in pre and booster for 6A and 19, sorry. So this is for the PCV 10, see the effect and see the response after booster doses. So boosters are very important. This for 6A and 19A. So PCV 13 provides direct protection against serotypes 3 IPD in young children. None of the new PCVs don't contain strain 3. Is it important for PCV to include 3, 4, 18C, 6A, and 19A? As said earlier, PCV 13 provides direct protection in children. PCV 7/13 in older PCV has controlled the disease burden due to these serotypes. So as they are present in the older PCV, we could control the infection rate. Their removal can result in outbreaks due to these strains. So that's the most important point. So at 6 and 19A, protection against serotypes 9, 6 and 19A is definitely superior to any cross protection offered by unrelated serotypes, even of the same group of in a PCV as recommended by IAP schedule. So it is essential for a PCV to include strains 3, 4, 6A, 19A, and 18C. And also another important aspect is the production of IgG and OPA. Serotype-specific IgG reflects the intensity of the immune system stimulations, surrogate for memory B cell. So memory B cells means the protection against nasopharyngeal carriers. So important predictors for overall impact of PCV on all pneumococcal disease-related diseases. And OPA type is surrogate of functional humoral protection. So that leads direct protection. So we should have a higher IgG production and also higher OPA carriage rate. So this slide shows the importance of this higher IgG in strains like 3, 6A, 6B. See the difference. 79, 91, 89, 96, 19A, 892 and 97, 23F, 91 and 97. Okay, and then this OPA in 4 weeks after third primary dose of either PCV10. See 7F, 87.86 and 307.63. The huge difference is there. 9V, 197, 752. 19A, 151 and 765. So undoubtedly, this 13 is advantageous to the children. Do both aspects of immunogenicity, IgG and OPA, matter? Both IgG and OPA are important parameters of judging immune response. So IgG, newer PCV immune response to serotypes 3, 6A, 6B and 19A, and 23 means the WHO recommended standard. So they have less percentage of immune productions. OPA GMT serotype 7F 9B 19M is the GMC ratio of 2-fold in children. So based upon the immunogenicity results available, newer PCV10 may be considered as comparable to PCV13 for serotypes 1, 5, 14 and 23 based on IgG and OPA titers. So all the is incomparable with the PCV13. And regarding product switching, what WHO says recommends that product switching only if it's not possible to complete the primary series or booster on the original product. PCV interchangeability dossier by Johns Hopkins University makes it clear that available interchangeability data, especially for newer PCV10, is limited. So booster dose and what is the relevance? A booster reactivates the immune memory cells, as we know, and result in rapid increase in IgG production and tighter by rapid proliferation of the memory cells. Booster is recommended across children. Like we know that we are giving boosters for 3+1 schedules for HIP. We are giving boosters for DPT. We are giving boosters for other vaccines also. So PCV also we need a booster, but newer PCVs don't recommend, or 10-valent vaccination don't recommend any boosters. So newer PCV does not have booster doses recommended even in their label. So this is the impact of PCV. You can see the reductions of IPD in US and 100% reductions in vaccine serotypes. Pneumonia, 39% reductions. AIM, 48% reduction. Herd effect also 92%. So that's the impact of PCV in this world. Substantial impact on invasive pneumococcal disease reinfection and after productions in national programs in various countries, as you can see. PCV13 has shown substantial reductions in nasopharyngeal colonizations after induction in the national programs. So this is a decrease in the antibiotic resistance in IPD after use of PCV13. So we could prevent the infection, and resistance also has come down dramatically after the induction of PCV in the national immunization program. This is to show the herd effect. The people who are not vaccinated are also benefited by taking this PCV in children. So the herd effect is also there for this PCV vaccination. So driving evidence based on classification, PCV impact data helps to choose the right PCV. So PCV13 has substantial impact on IPD, all cause of pneumonia, otitis media, NP colonization, antibiotic resistance, and herd effect in people more than 65 years of age. So robust impact data does lead us to choose the right PCV. So these are the 130 NIPs program cities excluded, 127 countries worldwide. Safety profile, absolutely safe. 13 control trials, 15,000 doses, and 6 weeks through 16 months of age. So 13 has tolerated in clinical trials in infants and children. The adverse events profile generally similar to that of PCV7 after the vaccine dose. There are practically, there are
Excuse me, sir.
Yes.
Only one more minute to wind up the
Okay.
session.
Summary. Relying on evidence based on decisions in choosing a broad coverage of PCV should be able to demonstrate impact level that extends beyond the pneumococcal disease prevention, not only demonstrate impact of invasive IPD, but also show the effect in reducing the NP carriage. Of available PCV 13 is included in the 130 national immunization program exclusively in 127 countries. So PCV 13 is the first and only PCV to help protect children 6 months to 5 years, 6 to 17 years, and adults over 50 years of age. Thank you so much for the patient hearing. I completed the program before your scheduled time. Thank you so much.
Thank you. It is very clear that the PCV13 is very essential and an effective vaccine. He conveyed the message very clearly. Because of time constraints, we are not having liberty to have questions, but the speaker has conveyed the message very clearly. Thank you very much, Jayagumar sir. Over to Dr. Manoj for continuing the session. Thank you.
We thank Dr. Jayachandran and Dr. Jayakumar sharing with us your views on the topic. Next, we have a 45-minute session on ROP, a biomarker for brain development, by Professor Anne Hellstrom, Professor in Pediatric Ophthalmology, Sweden, who will be joining us online. We humbly invite Dr. Rahul Yadav, a consultant neonatologist at Rainbow Children Hospital, Chennai, to chair this session and request you to introduce the speaker.
Good evening. It's my great pleasure to welcome you, Madam. Professor N. Hellstrom. She is Professor in Pediatric Ophthalmology, Sahlgrenska Academy, University of Gothenburg, Sweden. She is board member of Swedish National Register for Retinopathy of Prematurity, SWEDROP, 2006, and is ongoing. So I welcome you for the session, Madam. So the topic is quite interesting here. Here the topic is actually about surrogate marker, the development of brain and retina. Are they parallel? Because all of us, we know that. Welcome you, Madam.
Thank you so much. Can you hear me? Can you hear me?
Yes, yes, Madam.
Okay, and can you see my images?
Yes, Madam.
Is this better? Do you see the full page now?
Yes, yes, Madam. Please go ahead.
Okay, thank you so much. So thank you for inviting me to give a talk regarding retinopathy of prematurity as a brain marker, as a biomarker for brain development. As surely most of you know, the retina is part of the brain. And as such, it is a strong biomarker for later development of preterm infants regarding visual development, but also cognitive development. As a pediatric ophthalmologist, there are in most countries national guidelines on how to handle these infants regarding screening for retinopathy of prematurity. And in Sweden, we have a national patient registry for all patients screened for ROP since 2007. So what we see in about 75% of the babies is that the retinal vessels grow normally. And we screen in Sweden all infants born below 30 weeks of gestation. We have changed the over limit for screening babies during the last decade, but now we are down to below 30 weeks because we have not seen any baby developing severe ROP that are older than 29 plus 6 weeks. However, in about 30% of the babies, we see this. We see some kind of abnormal neurovascular development. And in some cases, we have to treat the infants because of neovascularizations to avoid retinal detachment and blindness. This is a baby with aggressive ROP with very central treatment with laser spots. Every spot here, yellow spot, is a laser treatment. And still, ROP is one of the most main causes for blindness in children. In Sweden, we looked at all the babies that had been treated for ROP and that became blind, because we wanted to titrate out the reasons for blindness. And we found that in 2/3 of the children that were blind, it was because of not following the guidelines. The babies had not been treated in time within the 72 hours that we have on us to treat the babies, or the children were wrongly diagnosed, or the treatment was not optimal. So this is how the natural history looks like in Sweden for ROP, and we have been able to have this map of ROP thanks to our now more than 11,000 babies screened for ROP in Sweden. And as you can see, we screen the babies we screen. Approximately 70% never develop any ROP, and approximately 7% are treated. We have seen an increase in treated babies in Sweden and in other countries with a similar neonatal care. We do not see any changes in the incidence of ROP, as the older babies now do better and do not develop so much ROP, but we have seen a survival of the most immature babies that are approximately 50% of babies now survive born less than 24 weeks. And 45% of those babies are treated for ROP. Thanks to our register, we have also been able to pinpoint the time with the highest risk of needing treatment for ROP. And we were quite surprised that it was more the postnatal age of the baby. As seen here, the highest risk for being treated is around 12 weeks after birth. And we can see that the risk starts to increase around week 8 after birth. And of course, the younger the babies, there is a slight shift towards higher postnatal ages. But this is a good reminder. Now, for a long time, ROP was considered to be a vascular disease, but lately we know that it is a neurovascular disease, as we have found that it is the astrocyte precursors that actually produce the VEGF that are responsible for the neovascularizations. And in this very nice experimental publication about 3 years ago, the authors had managed to knock out the astrocytes' possibility to produce VEGF in the brain of the mice. And what they found was, if the astrocyte could not produce VEGF, there was a hypoplasia of the cerebral cortex. And the authors even stated that the astrocytes in the brain work in the same manners as the astrocytes in the retina. So there are similar pathophysiology between brain development and retinal development, and that is not a surprise, as retina, as I said, is part of the brain. We did see that there was a strong correlation between the stage of ROP, which is seen here on the x-axis, where we have children with no ROP, and on the y-axis we have the head circumference. And as you can see, the more severe ROP, the poorer is the head circumference. This is at week 36 postmenstrual age. And we could also see what was interesting following head circumference longitudinally, where we have the stage 3 and treated in the bottom here in blue. When we actually see that the growth of the brain is turned over regarding head circumference standard deviation score, that is also the timing when we start to see the vessel growing on the retina. So for sure, they are following each other. It has also been shown that the ROP developmental stage is correlated to brain volume. In this case, it's unmyelinized white matter volume, where the children with no ROP have a higher score. And this is the cerebellar volume, also where children with no ROP has a higher score than children with any ROP. So this is another study, a similar study, but comparing severe ROP, children being treated for ROP in a different cohort in Holland. And here you can also see that the brainstem volume is lower in children with severe ROP, as is the cerebellum volume. When it comes to function, it has also been shown that ROP stage is correlated to worse motor and performance developmental index. And in the large ELGAN study, they found that infants with severe ROP were twice as likely to develop a low Bailey score below 70. And this was at 2.5 years. We were very interested in studying a brain biomarker for these preterm infants. And we looked at the biomarker, brain injury biomarker, neurofilament light. And the line you see here is a reference value for adults. And it has been shown that adults, for instance, exposed to high risk of brain injury sports like hockey or boxing, or even going into space, adults going into space were found to have levels above 20. And quite surprisingly, our preterm babies had for 4 weeks quite dramatically increased levels of this brain injury biomarker. So then we were interested to see what this was correlated to. Was it correlated to any neonatal diagnosis like IVH, neck, poor nutrition? And the only variable that we could find was associated to these levels was actually ROP. And as you can see here, the levels in children with any ROP are significantly higher than the levels in children with no ROP. And this was true even after adjusting for gestational age, as we could also see that the younger babies had higher levels. Now, there is quite a thorough research in Sweden ongoing looking at autism in preterm babies and doing MRI in these babies. And in 2 of these studies, I was quite intrigued to look at the neonatal variables in children with autism that were matched in gestational age and weight to children with no autism. And looking at all their neonatal characteristics, actually, one of the things that came strongest out was actually the ROP, any ROP as well as treated ROP. So there is seemed to be a correlation with especially neuropsychiatric diagnosis and ROP. So this made us in Gothenburg look at our data. We had actually 27% of the babies with autism. And then we looked at the risk having severe ROP, and actually 67% of the children with severe ROP also had autism, and any ROP, it was 89%. And then we looked at IVH, and as you can see, it's a much lower correlation between a neuropsychiatric diagnosis and IVH in this cohort. We recently looked at all babies born below 24 weeks in Sweden in a project called Tiny. About 22% of those babies were visually impaired. And in fact, all of those babies, which was 72, had other diagnosis related to the brain. 64% of these babies with visual impairment were treated for ROP, but about a third had other cerebral reasons for their severe visual impairment. And here you can see the other diagnosis related to the brain in this cohort of extremely preterm babies born below 24 weeks of gestation. Actually, 75% of the babies had diagnosis related to the brain in this cohort. So what is it? What is the big risk of these babies having severe ROP with later poorer cognitive outcome? Well, is it the disease itself, that what we see in the retina when we see these bad neovascularizations, that also is a marker of poor brain development? Or is it what we do when we give these babies laser and when they have their general anesthesia? So a very nice study looking at general anesthesia in children with not so severe ROP, actually pre-threshold ROP, did not see that the children who had surgery or anesthesia actually performed worse regarding psychomotor development, at least. So in this study, there is no evidence that it is the procedure that is causing the poorer outcome, but rather the disease itself that reflects then a poor brain development. When it comes to risk factors that would likely affect both the retinal development as well as the brain development is the oxygen exposure. And we managed to look at almost or a little bit more than 1,900 babies and 27,000 data points, and found that in the babies that developed severe disease, it was actually the high variability in oxygen exposure, not that they were exposed to, not that the babies had very high oxygenation, they rather had low oxygenation, but they had a high variability. And this has also been shown by others, that it is rather the high variation in oxygen delivery that is associated with poorer neurovascularization, at least when it is somewhat controlled. It has also been shown in experimental studies in mice that exposing the animals for hypoxygenia actually decreases the myelin basic protein and upregulate the glial fibrillaric acid protein, which is a marker of brain injury. So it seems that fluctuations is not good for brain or as well as retinal development. Another factor that we know affects both the retina and the brain is actually anemia. In many publications, it is stated that it is transfusions that is a risk factor for ROP, but in fact, it is the reasons for transfusions, the anemia, it seems as, especially during the first weeks after birth. And there are studies on delayed core clamping in regarding the risk for abnormal development. And it seems as by delayed core clamping, it seems as there is a less risk for poorer development later in life. We also looked at this and regarding one important factor for oxygen delivery actually, and that is the fetal hemoglobin levels. And as you know, intrauterally, the babies are mostly exposed to fetal hemoglobin. And after birth in a term baby, it takes approximately 2 months to reduce the levels to around 20%. But in our preterm babies, the levels are quite rapidly reduced. This is only the first week after life. And you can see the quicker the reduction in fetal hemoglobin and the higher the decrease, the higher the risk for any ROP. This is also true for BPD. And looking at fetal hemoglobin and the brain, it has been shown that cerebral oxygenation transport is lower if the fetal hemoglobin levels go below 30%. And as you can see in this image, after a week, we are really below 30% in a majority of the preterm babies. So it seems as exchanging fetal hemoglobin with adult hemoglobin, as we do when the babies are exposed to iatrogenic phlebotomy due to clinical sampling. And this is a cohort from Sweden where we found that during the first 2 weeks of life, 57% of the blood volume was lost due to clinical sampling. And of course, the more blood we take from the babies, the more blood we give. And what we give is not fetal blood, but it is adult blood and adult erythrocytes with a completely different affinity to oxygen. And of course, it is also other factors that we exchange when we do the take the sampling of the babies. So restrictive blood sampling is highly recommended. It's also interesting to note that it is really a relation between what type, if it is a male or a female donor, regarding, in this case, the red blood cells. So it seems as a female donor is to prefer regarding neck, death, BPD, and a composite outcome. Actually, the only neonatal diagnosis that was not affected by the sex of the donor was ROP. It's also interesting to note that when plasma is given, it is always plasma from men because of the risk of giving female plasma of the host versus graft reaction. So I think in most countries, at least in Sweden and in Europe, we only give plasma from men, so also to the preterm babies. Now looking at proteins that are related to ROP in a large cohort of extremely preterm babies born below 28 weeks, we found that of 550 proteins, 20 were related to gestational age and or ROP. And they were within the functional areas hematopoiesis, angiogenesis, CNS development, and immune function. So this really shows that brain and retina goes hand in hand regarding development and that they are tightly associated. But also it shows the importance of the blood components for this development. So how can we do to reduce this iatrogenic phlebotomy? Well, of course, delayed cord clamping has become a big thing all over the world because of its positive effects. And of course, reduction in blood sampling. There is a large national multi-center study ongoing in Sweden, which is called Less is More, where we use micromethods to look at blood gases and infection variables like CRP, and by that reducing the blood volume phlebotomy by 50%. But we have also lately looked into if it would be possible to use cord blood transfusions in a study called NeoRed, where we now have a product with fetal erythrocytes that can be infused instead of adult erythrocytes. And we'll later see how that outcome will go. So another factor important for development is the growth factor, insulin-like growth factor 1, IGF-1. And after birth, the levels of IGF-1 is quite dramatically reduced. The red dots here are blood samples from preterm infants and their levels compared to the intrauterine levels at the corresponding gestational age. And we found that in babies with poor neurovascular development, they had significantly lower levels of this growth factor compared to children with normal development. And then it was hypothesized that maybe if these levels could be restored, we could also normalize development in the retina and the brain and hopefully the lungs. And that was the background for a multi-center study that is now ongoing. And in the first phase 2 study, it showed positive effects, not so much on the retina, but especially on the lungs and also in reducing IVH. So this study is now ongoing again, and the first publication was out now 3 years ago. This is a sub-study where we looked at the levels of IGF-1 and related it to brain volumes in approximately, I think this was a bit over 60 babies that were born extremely preterm. And this was actually accepted last week in pediatric research. And you can see that there are some brain volumes that for sure were correlated to IGF-1 or during the first postnatal month, also when correcting for gestational age. And that is again the cerebellar, the cortical gray matter, white matter, and total brain volume, as well as the deep gray matter volume. So maybe IGF-1 could be interesting hormone to substitute these babies with, but I think the ongoing trial will tell us more about this. Another factor that is important for the development of preterm babies are the fatty acids. And during the third trimester, omega-6 arachidonic acid is transported actively from the mother to the fetus, as well as DHA, the omega-3, especially during the last part of the third trimester. But after preterm birth, we know that the levels of these factors drastically are reduced. And we have also seen that in babies with ROP, they reduce more as compared to in babies with no signs of ROP. And this is the omega-6 arachidonic acid. And this is DHA. So we were interested in actually looking at brain volumes in relation to these fatty acids, and found that higher DHA levels were associated with a higher total brain volume, and higher arachidonic acid levels were associated with decreased ventricular size volumes. So this all encouraged us to actually perform a trial where we wanted to substitute the babies with arachidonic acid and DHA 2:1 enterally, as there is no parenteral solution with both these components. And we gave a small amount from birth to 40 weeks gestation. At birth, we gave, say, 0.1 mil, and around 40 weeks, we gave approximately 1 milliliter. Endpoint was ROP. And this is the outcome regarding the fatty acid levels. It could and arachidonic acid. See that we had a profound effect on severe ROP. And the solid line here are the children with substitution. results if they end up with the same positive outcome regarding ROP. So there are studies that have shown positive outcomes for the brain administering DHA, and this is a study looking at different IVH stages, and here you have the percentage of the DHA, and as you can see, the less grade of the higher the grade of IVH, the lower the DHA. And there are also some studies that have showed better microstructural development as well as functional development after early DHA to preterm infants. Interestingly, we have shown that in children with a high parental lipid intake, we actually we actually found that the higher the parental lipid intake was, the lower was the both DHA levels and arachidonic acid levels. And as you can see here, quite surprisingly, we found that the higher the intake of parental lipids, the lower was the head circumference score. And this was also associated to lower levels of the fatty acid, both omega-6 and omega-3 that I mentioned.
Excuse me, ma'am.
Yes?
We are running out of time. Can you please wind it up within 5 minutes?
Yeah, this is the last slide. So ROP development is associated with abnormal brain development. We know that it is associated, we know that it shares histopathological mechanisms. We know that they share similar risk factors, and I believe they are likely to benefit from similar preventative actions. So thank you very much.
Thank you very much, madam. It was quite enlightening talk. You covered so many aspects about the prevention of ROP. And if in future, if we're able to prevent ROP, we can prevent neurological handicaps of these tiny preterm babies also. Thanks a lot. Any questions from audience? I'd like to ask only one question, madam. Right now, there is anti-VEGF coming up, and there is always overlap between laser therapy and anti-VEGF treatment in treatment of ROP. So did you find any difference in neurological development in those babies who are treated by anti-VEGF and those who are treated by laser?
Actually, this is a very tricky question, and unfortunately, there are no good prospective studies looking at this. And in Sweden, we have very few babies treated with only anti-VEGF or laser. We use this treatment with anti-VEGF only for the most severe cases, the zone 1 disease. Then normally they also need a laser treatment, so it's difficult to split it from each other. But it might be, and I'm not sure of this, I think the future will reveal that, but it might be that the two different treatments are associated with different neurological outcomes. It might be that one is more associated with a neuropsychiatric diagnosis, and one is more associated with a neurocognitive outcome. And if I was to choose which one would go one direction, I would say maybe that the inflammation we cause with laser would postpone more for neuropsychiatric diagnosis, and maybe anti-VEGF could affect cognitive development in a different manner, but this is only a speculation. As for now, there are some reports pointing at that anti-VEGF has some poorer outcomes, but it's difficult since also these babies are the most severely affected. But there are also several studies now that cannot show any negative effects of anti-VEGF. So I don't think we have the true answer today.
Thank you, madam.
Can I ask just one question? Yeah.
Oh, sorry. Please.
Do you think the time has come to give DHA supplements to all preterm babies?
I don't think only DHA. I don't think that is good. I think for sure, if you give DHA, I think you should give arachidonic acid also, because we saw that a certain degree of arachidonic acid is actually needed for DHA to have a maximum effect. And if we only give DHA, it could be also negative, as was seen in the big study with Collins, with the risk for BPD. And I would really like to see the outcome of the study from Norway, because, you know, always doing one study can give one finding, but if we have two studies going in the same direction, I would feel much more confident to recommend it. But we could not see any negative effects on this substitution. So it's difficult to give you a answer yes or no. But if I had a baby born, or my children would have a baby born this week, I would definitely recommend it.
Thank you, madam. Thanks a lot. Thank you for your patient listening. Over to organizers. Thank you.
Thank you.
Need to interrupt for an announcement. National Neonatology Forum Kerala EB meeting will be held in Professor Santosh Barua Hall at 3 p.m. and general body meeting of NNF Kerala will be held in the same hall at 3:30 p.m. Please carry on.
Thank you, Professor Ann and Dr. Rahul, for that informative session. Next, we have a 1-hour talk on synchronized non-invasive ventilation of newborn by Professor Corrado Moretti. We have Professor Pradeep Dabetta, Professor of Pediatrics at VMMC and Safdarjung Hospital, Delhi. He is also President-elect 2023 NNF Delhi. We welcome you, sir, and kindly request you to introduce the speaker.
Good afternoon, everyone. And Professor Corrado Moretti, he doesn't need any introduction regarding if you see his work in synchronized non-invasive ventilation, he's the pioneer actually. And basically from his idea, we have now from non-invasive, from CPAP to NIPPB, and now synchronized NIPPB. There's many papers to his credit. And those are basically the fundamental research of synchronized non-invasive positive pressure ventilation. So without much ado, let us hear from Professor himself.
Good morning. Good morning to all of you. So do you listen to me?
Yeah, you are audible.
And this is the slides. Can you see the full page? Can you see the full page?
No.
No.
We're not able to see your slides.
Ah, yes.
Yes, now we can see.
Just 1 second. Now you can see full page.
Yeah.
Okay, and so thank you very much for your very kind presentation, and also to thank all the organizer of this wonderful meeting for inviting me. And above all, I want to thank Dr. Kumar and Dr. Professor Manoj for inviting me to speak on synchronized non-invasive ventilation. I start with a little piece of history. This is, I think, the first probably paper on intermittent positive pressure ventilation by nasal prongs. This paper, this was my first paper, and that was published more than 40 years ago. And as you can see in the left, also the time we are looking for synchronization, but because you can see that this is the pressure of the ventilator and this is the thoracic impedance, but we used to do it manually, so trying to set the same parameters of the baby on the ventilator, so the expiratory time and the rate. And at the time we're using these homemade nasal bronchs that are not so dissimilar from the bronchs that we use today. Clearly, the treatment was above all for apnea of prematurity because, as you can understand, at that time was impossible to treat severe RDS due to the fact that we were in pre-surfactant area. So it took a long time, in the truth, to see a widespread adoption of this technique. But luckily, in the last year, this technique, non-invasive ventilation, is increasing and increasing, as was demonstrated by this retrospective study, whose goal was to evaluate the change in primary respiratory support in United States infants. As you can see, in this period, the period considered as of 10 years from 2008 to 2018, there was a remarkable and significant increase of the use of non-invasive ventilation, and at the same time, there was a decreased use of mechanical ventilation. This is the high flow nasal cannula, more or less is the same, a little bit a reduction of its use. So, and the authors also reported that thanks to non-invasive ventilation, about 30,000 fewer newborns were ventilated than expected when compared with the 2008 data. Clearly, these changes represent a very significant improvements in neonatal respiratory care. I remind you that there is a direct relationship between the duration of mechanical ventilation and the neurodevelopment of preterm infants. This is a beautiful paper, recent paper, in which were enrolled more than 300 babies, studying the relationship between the NDI and mechanical ventilation. And the conclusion was that there is a strong association, but this is a very impressive phrase, that every additional day of mechanical ventilation is strongly associated with an increased risk of NDI. And moreover, also, a failed extubation has a great risk of complication, of an increased mortality and morbidity. This is another beautiful paper in which were enrolled more than 900 babies, and the authors report that the infant who failed extubation had a significant increase of severe complication, and not only deaths, but also BPD, intracranial hemorrhage, and so on, length of stay, and so on. So clearly, also to fail an extubation, it has a very high price. For this reason, limiting invasive mechanical ventilation is an important goal in the treatment of preterm infants. But so now the question is, what are the most effective non-invasive ventilation techniques? The answer is given by this beautiful network meta-analysis developed by a colleague from India. The name Vaira, but it's very difficult for me to say the complete name. So this is a very beautiful analysis whose objective was to compare the efficacy of different NIV modes as primary respiratory support. The modes included were flow-nasal cannula, nasal CPAP, BiPAP, and NIPPV, but not the synchronized mode. As you can see, many randomized trial 35 were considered with more than 4,000 infants enrolled. The main outcome was the requirement of mechanical ventilation within the first 7 days. So results, NIPPV is the most effective modality to prevent mechanical ventilation respiratory failure, and also the mode with the lowest incidence of BPD and death. Also very interesting is the second network meta-analysis by the same author. In this time, the objective was to compare the efficacy of different NIV modes as post-extubation support. In this case, this is very interesting because more or less all the non-invasive ventilation techniques were considered: high flow nasal cannula, continuous flow, variable flow nasal CPAP, BiPAP, synchronized and not synchronized ventilation, and also nasal high frequency oscillatory ventilation. Again, a large number of randomized trials, a large number of infants considered. And the main outcome in this case was the required ventilation within a week. The results are that synchronized nasal ventilation is the most effective mode for preventing extubation failure, and this technique is also associated with a decreased incidence of BPD. So we can really say that NIPPV, and above all, if synchronized, are among the most effective NIV techniques, and by all these trials do not appear to be associated with an increased risk of side effects. But when using this technique, we must consider a very important factor, that the upper airways. We have to remember that there is not a direct connection between the ventilator and the lower airways, that is the tracheal tube. And moreover, you have to remind that the upper airways perform functions that for which they must open and close, are all vital functions as breathing, swallowing, speaking, crying, and protection from inhalation. So for this reason, clearly, the upper airways have no structural rigidity, but are made up of muscles connected to rigid supports. The rigid supports are at the top, the base of the skull, at the front, the jaw, at the bottom, the laryngeal cartilages. So clearly, we know that another very important problem is that how the patency of upper airway is controlled during expiration. Because when the diaphragm contracts, we know that there is an increase of the intraluminal negative pressure with a tendency of the upper airway to collapse. But this collapse is prevented by three simultaneous events. First of all, the opening of the glottis to reduce the resistance. As you can see, this is a picture of top inspiration, and there is a widening of vocal cords. And by contrast, during the expiration, there is the closure, that is grunting, as you know. Moreover, the negative pressure stimulates intraluminal pressure receptor, and this determines the reflex activation of the upper airway abductor muscle in order to stiffen and widen the pharynx. And I remind you that the main upper airway abductor muscles are the genioglossus and geniohyoid. These muscles are linked between the hyoid bone and the jaw, and their contraction determines a forward displacement of hyoid bone. You have to consider that the hyoid bone more or less in this position, and the forward displacement determines a widening of the pharynx. So we have to take in mind all these physiological details in non-invasive ventilation. And now let's go on analyzing the interaction of not synchronized ventilation with spontaneous breathing. This is a picture taken by a baby assisted with not synchronized ventilation with a backup rate of 20 breaths per minute. And you can see that most of the mechanical breaths are not synchronized with the infant. Here, the ventilator started at the peak of spontaneous breath, here the mid expiration, here in the late expiration, and so on. I remind you that the rate of asynchrony is very high. This was demonstrated in several papers. This is one of the last one. This is a very well done paper in which the respiratory activity was measured, that was recorded by the electromyogram. And in this study were enrolled very low, 21 very low breathed infants with a very low gestational age. And these authors reported that the rate of asynchronous was about 70%, so extremely high. You have to think that when you set the ventilator on 40 or 60 breaths minutes, as the author of this paper did, This means about 60,000, 80,000 cycles every day, and 70% of them are asynchronous. I suppose that this is very upsetting for the baby. Moreover, there are, as you can see, ventilation is not improved by asynchronous mechanical breath. This is a very old paper by our group. This is a recording of the first attempt trials of flow synchronized ventilation. Here we have the pressure of the ventilator. Here the esophageal pressure that, as you know, is the same as of the intrapleural pressure, and it shows us the effort of the baby. And this is the tidal volume. You can see that this asynchronous breath perhaps is auto-triggering, perhaps a backup rate. There is not at the same time the effort of the baby. And you can see that from the ventilatory point of view, this breath is practically ineffective. This problem was demonstrated many years later, also by Peter Davis. He studied the effect of non-synchronized nasal ventilation, and he reported that the tidal volume only increases in a significant way when synchronization occurs. And also Peter Davis reported that synchronization occurs only about in 25% of cycles, confirming the previous paper that the rate of asynchrony is extremely high. So the hypothetical beneficial effects due to the non-invasive, not synchronized nasal ventilation are above all due to an improvement in manner pressure, and this means an improvement in FRC. You know that improving an FRC determines a lot of positive effect on respiratory physiology, lower compliance, lower resistance, improve the compliance, decrease the resistance, improve the perfusion of the lung, and so on. Another effect could be that the intermittent inflation of the hypopharynx could stimulate the respiratory drive. And moreover, we can think that superadded ventilatory inflation enhances tidal ventilation. But I underline, as we have seen in the previous paper, only the synchronous breath are really improved. Moreover, the asynchronous mechanical breath have also some negative effect. First of all, I think this is a phenomenon that we see very frequently, an alteration of the spontaneous respiratory rhythm. You can see here that the ventilator starts at the beginning of the respiratory phase. We have a blow-up here of this image. The ventilator starts exactly in this point. You can see that the baby reacts with a very prolonged and deep expiration. Why? Why? Because probably the lung was overinflated. And this, what we see here is only an Ehrenbroyer inflation reflex. And not only there is a deep expiration that is not a good phenomenon, but there is also a delay following the expiration. The same thing was demonstrated in other papers. I show you this paper by Professor Bancalari. Again, exactly the same phenomenon. This is the esophageal pressure. The ventilator starts during the expiration. You can see here a prolonged exhalation, and here a forced expiration, a positive pressure inside the esophagus. There are some others negative effects of asynchronous breath. There are several papers demonstrating that asynchrony may also activate laryngeal closure. And it could be the results, because the flow goes in the wrong way. There could be an increase in abdominal distension. All these factors increase clearly the work of breathing, and above all, I think, the discomfort of the patient. I want to underline this last point that is very rarely considered. We know perfectly, there are many papers demonstrating this, that in infants, children, and adults, asynchrony during non-invasive ventilation is an important cause of stress and discomfort. And it is a frequent reason of NIV failure. And we know perfectly that in preterm infants, pain and stress have well-documented adverse neurological impacts as an alteration of the development of brain and cerebellum. So a question that I ask myself very often, but I have not the answer, is asynchronous nasal ventilation a possible cause of stress in premature infants? As I said before, thousands and thousands asynchronous breath every day, I think that could be really a cause of stress, and we should study this problem. But as I said before, I have no answer to this question. But now let's go on to analyze the interaction of synchronized nasal ventilation with spontaneous breathing. Synchronous mechanical breaths have, we will say, have many positive effects on respiratory physiology. This is the recordings of a baby in access control with a flow synchronized ventilation. You can see that the rate of, here we have a long respiratory time, here short, so the rate is the rate of the baby. And you can see that three lines, pressure, flow, and thoracic impedance now are perfectly aligned. The ventilator starts every time the baby starts breathing. So, but why does synchronization has positive effect? The reasons are very simple. Because when the ventilator is triggered, when the pressure rises, at that time the glottis is open. Moreover, the pressure of the ventilator pushes the soft palate against the base of the lung, sealing the oral cavity. This means less leak. Moreover, the upper airway, as we have seen before, are stiffening and widening. Moreover, there is a real collaboration between the baby and the ventilator because as you can see here, there is the negative pressure due to the contraction of the diaphragm, the positive pressure of the ventilator. This means an increase of the transpulmonary pressure. This means less work of breathing. Clearly, the time lag between the start of spontaneous breath and the mechanical breath must be very short. By convention, we say less than 100 milliseconds. Another very important point is that also the thoraco-abdominal asynchrony is reduced. Now, I'm going to show you this problem that is very important in non-invasive ventilation. This is a very old paper, but still relevant. All this data were demonstrated, has been demonstrated in the following years. But this is the previous one, the first paper on this topic, on the thoraco-abdominal motion. Kinziman, the author, placed two strain gauges, one around the chest wall and one around the abdomen. In a perfect situation, the two structures should move in complete synchrony. When the abdomen expands, the rib cage also should expand. But we know that this doesn't happen in very low birth weight infants, but also in infants, that we have a paradoxical breath, especially when the compliance is low. And when the diaphragm contracts, there is an inward collapse of rib cage. So in order to maintain the same tidal volume, the diaphragm has to increase the shift to improve the work of breathing to compensate the loss of volume. But how can asynchrony be measured? Can be measured in a very single way, by the phase angle, that is the difference in degrees between two waves that move at the same frequency. For example, this is the abdomen, and this is the rib cage. As you can see here, by convention, I have to say one wave is 180 degrees. So in this case, the phase angle is 80 degrees. Clearly, when we have a complete synchrony, the phase angle is 0. When we have a complete asynchrony, the phase angle is 180. And Kinziman studied the phase angle in newborn treated in different conditions. I have to say that the right phase angle, the physiological phase angle in a healthy preterm infant is about 40 degrees, because the diaphragmatic contraction slightly precedes glottal abduction. So 40 degrees is the best, is the goal. As you can see, if Kinziman studied the phase angle in baby treated with CPAP and the tracheal tube, so this is a remarkable increase of the resistance in the worst condition, something that we have never to do. The phase angle is very high, not far from complete asynchrony. Better with nasal CPAP, there is with short nasal prongs, 80 in any case is the double of the normal phase angle, but the phase angle comes back to normal value with synchronized nasal ventilation. So the conclusion is that the synchronized nasal ventilation stabilizes the chest and reduces the thoraco-abdominal synchrony. So the physiological advantages of synchronized nasal ventilation are the lowering of resistance, the increase in transpulmonary pressure, decrease of thoraco-abdominal asynchronous, and as we will see in the following slide, this means an improvement in ventilation, improved a decrease of work of breathing, and as we will see also perhaps a stimulation of the respiratory drive. All these things I convinced that it means an increase of comfort for the baby. So coming back to the clinical results, analyzing the improvement on ventilation with synchronized ventilation, I show you again a very old paper, but as I said before, still also this paper is still relevant because this data were all demonstrated in the following years. This is a crossover randomized trial analyzing the physiological effect of synchronized ventilation compared to nasal CPAP after extubation. And we studied 11 very low birth weight infants. So this is the pressure in the circuit. This is esophageal pressure, as I said before, the effort of the baby, and here the tidal volume. Shifting from nasal CPAP to synchronized nasal ventilation, there is a significant lowering of the respiratory rate. The effort is significantly reduced, 1/3 less. And despite the reduction of the respiratory rate, despite the reduction of the effort, there is a significant increase of tidal volume, and also the PCO2 was statistically lower. The same results were obtained many, many years later by the group of Helmut Ramler. This is, he compared directly synchronized nasal ventilation with not synchronized ventilation. I think this is the only paper doing this, this research, comparing directly the two techniques. And the beautiful thing of this paper that the two techniques were applied with the same inner pressure, because 40 breaths were set of not synchronized ventilation, and only 40 breaths were assisted during synchronized ventilation. The baby were with very low gestational age, most of them still in oxygen, it means still in acute phase of the disease. And as you can see, the results were exactly the results we had that I showed you in the previous paper. Significant reduction of the effort, or in other words, of the esophageal pressure, reduction of the respiratory rate, the improvement in ventilation. So improvement in PCO2 removal, and an increase, significant increase in oxygenation. And I want to show you also this paper of some years ago. This is a crossover randomized trial to compare the efficacy of flow synchronized ventilation with an NSCPP and CPAP for the treatment in apnea of prematurity in infant in good condition, but affected by severe episodes. And so the results were that only with flow synchronized, with synchronization, was possible to have a significant reduction of the incidence of this phenomenon, apnea desaturation in bradycardia. And, but there were no differences between NATPV and nasal CPAP. With synchronized nasal ventilation, it was possible to reduce in a significant way all these phenomena. And I want to show this last clinical paper by Manuel Luna, just to show you the efficacy of this technique. He was using in this research, in this trial, flow synchronized ventilation. And he studied a number of baby as elective group. So baby after extubation elective group, and 92 of these patients with a very low gestational age, in 92% of this baby, the extubation succeeded, was a success. And this is also very important. A large number of baby was failing CPAP failure, again with a low gestational age. They applied for synchronized ventilation as a rescue therapy, and 2/3 of these patients avoided intubation. I think that these are very encouraging data. So what choice about parameters, interface, and trigger for synchronized ventilation? The parameters, I think, is a very simple answer because more or less are the same parameter that you use during mechanical ventilation, just the peak inspiratory pressure is a little bit higher, 2-4 centimeters. But as you can see, the value of PEEP, inspiratory time, and flow more or less are the same that we use during invasive ventilation. Clearly, don't forget caffeine. About the interface, this is a very, very important point. It's a critical point because the interface affects pressure transmission to the lung. There are different devices, different shape. This means different resistances. And I underline that currently a widely adopted interface for nasal ventilation is the double inspiratory loop cannula. This is the both tubes. This cannula, both tubes conduct inspiratory flow. This has the same shape as for high flow nasal cannula. But I know that this is loved by everyone, is loved by the infants because due to the less nasal injuries, loved by the nurses, easy to set up. It favors mother-child bonding, so it's loved by the parents, but this device, it has very often and very high resistance, which could compromise the pressure delivery to the airway. This is something that we have to think about. About the trigger, so the oldest one, I think, pressure sensor, pressure trigger, but you know that especially in very low birth weight infants, the inspiratory effort is very weak. So with this device, it's very difficult to try to find the good sensitivity. And so this means that very easily you can have auto triggering or no triggering. Gatsby capsule also is a very good device, but sincerely, it's not very reliable over time because the position, the right to find the right position, the movements, also the abdominal distension are all factors that can alter the function of this device. Moreover, there are some data in this paper that tell us that during fasted breathing, the response of this device is less consistent. This is exactly the opposite that we want. So very good tool, NAVA. The electrical activity of the diaphragm is detected by this catheter. In any case, this is partially invasive because we need this catheter in place for all the time of the treatment. This is also very expensive. So there are some paper, very recent paper, that underline that for a perfect functioning of this device, it's needed a very good neural feedback. And very often the infant, premature infant, a sick infant, the neural feedback is not so good. Our group has developed a flow sensor, that this is something that we use currently in invasive ventilation, but with non-invasive ventilation, there is a big problem of the leaks. But now I'm going to show you our setting. This is a baby treated with slow synchronized nasal ventilation. Here, the flow sensor. The response time is very good, about 65 milliseconds, or this data are published. And we adopted a double loop inspiratory nasal, double inspiratory loop cannula, so the same as high-flow nasal cannula, but we developed a cannula of very low resistance, with the diameter of this tube is very high. So we could measure that, we could check that there was a really good pressure transmission of the lungs, to the lungs. And I remind you that in this case, the nasal prongs must fit well because the peak inspiratory pressure and the expiratory pressure is controlled by the ventilator. But I want to spend just a few seconds analyzing this image. Again, you have the pressure ventilation, the flow, thoracic impedance. But look at the flow. And this is a very good thing to have the signal of the flow. You can see that the flow is a very strange shape of the flow because there is the inspiratory phase, but not the expiratory phase. What does it mean? It means that the expiratory flow leaves the airways from the mouth. So it means that these two lungs tube, there is no dot space and no rebreathing because practically never the expiratory flow comes back in the circuit. But this is also obvious because here there is a pressure and the mouth, the pressure is 0. So the suggestion, if you use this technique, don't never close the mouth of the baby, thinking that so the pressure is transmitted well, in a better way to the lungs. Moreover, I underline the fact that the flow sensor detects the expiratory flow, but never the expiratory flow. If you use a normal flow sensor, you will see that after a few breaths, the alarm will beep. You can see here that the flow signal is extremely stable despite the leaks. So we were able to obtain this by a special software that practically reports to the 0 line, the flow line after every inspiration. So we resolved, I think, in a very good way, the problem of the leaks, variable leaks. So the take-home messages of my lecture that asynchrony during non-invasive ventilation may have some negative effects on ventilation, the alteration of the rhythm. This is very frequent, and probably also the patient comfort, and also on the quality of sleep. But we have no data about this. I again underline that this is something that should be studied. By contrast, the synchronization integrates with the complex physiology of the upper ways, reducing work of breathing and improving ventilation and comfort. Synchronized nasal ventilation is a technique very well studied, and there are many papers demonstrating that it's better than an EpiPV and nasal CPAP, also than BiPAP, in reducing the need for intubation as primary support in RDS, in improving the success rate of extubation, and in reducing the incidence of apnea desaturation in bradycardias, as I showed you before. So I conclude, underline that flow synchronized nasal ventilation performed with a low resistant double loop inspiratory canal can be used successfully. And so the good thing is that we were able to combine the physiological advantages of synchronization with the same comfort and easy use of this interface of the double inspiratory loop canal. Thank you very much.
Thank you, Professor Moretti. You made us to understand what is the anatomy involved, what is the physiology behind the synchronized NIPPV, also the clinical implications that we usually we require in preterm, that they should not get mechanical ventilation and the rate of BPD should become, there should not be any more work of breathing which led them to mechanical ventilation and intubation. So synchronized NIPPV is one of the best mode. We started from CPAP, non-invasive ventilation, now synchronized non-invasive positive pressure ventilation is the norm to prevent mechanical ventilation. So thank you very much. Any question from audience?
Okay. Yes, I want to underline that no one today will use not synchronized ventilation in the invasive mechanical ventilation. I think that we are going exactly toward the same goal. That I think that in the future, every child, every newborn will be ventilated with synchronized nasal ventilation, because the path is exactly the same as what happened many, many years ago. But who would treat with not synchronized ventilation intubated today? No one. Everybody would say that there's a crazy thing. I know that with non-invasive ventilation, there is a less direct barotrauma, but more or less the problem are exactly the same. We have to consider this.
Okay. So any question from the audience?
Sir, regarding my question is like concerning regarding CO2 levels, sir. If it is synchronized NIV, there is a chance of any hypocarbia and any neurodevelopmental issues. And one more question is, kindly share your experience regarding the volume compensation, how much leak compensation is happening, and how your ventilators are compensating, how much percentage of leak compensation is happening.
No, so the first, the hypocarbia, I heard well. The first question.
about CO2 wash out. His concern is that if we keep synchronize NIPPB, then there will be more CO2 wash out.
So no, there is any problem about CO2 removal because so it's the baby who determines his own respiratory rate, and so we never had problems. So we had an improvement in removal of CO2, but always at physiologic levels. And about the leak compensation, you know, when you said in our device is not needed because yes, there are the leaks, but when you set the flow of 8 to 10 liters, so the flow is much higher than needed. So there are variable leaks, but usually the pressure that we set, that is in the range of 15-25, is reached. I don't know if the leak compensation is so useful because it means that to increase abruptly the flow, and so this also have bad effects. So this is in our device is not a problem. Currently, we like better to have a constant flow, and it can happen that sometimes one or few hacks have a little bit lower pressure, but this is not so important at the end.
Thank you, Professor. Anyone, any question?
Hello, it's a very good talk. My question is regarding the interface. On a dragger, we can use a CPAP interface to give CPAP through the ventilator. For what sort of interface? Is it the same interface you use for SIPPV? For a synchronized non-invasive ventilation. What sort of interface are available, or can we use the same CPAP interface?
So the interface that we use is usually nasal prong. I have not experience with a nasal mask. This is something that we are going to try, but most of all our trials were done with normal short nasal prongs. In the last period, we developed the double respiratory loop cannula, and we, thanks to the fact that we can see the flow, we saw that there was never rebreathing. So the two lungs tubes were not a problem for breathing at that space, because the expiratory flow was, as I said before, leaves always the areas from the mouth, so there is no rebreathing. So now we are using more and more these cannulas, because, as you know, the parents and nurses, everyone is much happy with this more comfortable and easy to set prongs. This is something rather new. And I underline that we developed a special flow cannula, special cannula for this, with very large resistance, so 2 large tubes, but in any case comfortable.
Good afternoon, sir.
One more question.
Yes, sir.
One more question is coming.
Thank you very much for the excellent talk. I just want to know whether this is one step ahead of CPAP. So is there any head-on, because the indications after CPAP failure for mechanical ventilation is same. So the mechanical ventilation compared to synchronized non-invasive intermittent positive pressure ventilation, is it a head-on any trials which you have done, sir?
Sorry, could you, because I have an echo, and so I didn't understand well, sincerely. If you try to speak a little bit slower, or if the chairman can tell me your question.
Sir, indication for mechanical ventilation after a CPAP failure is the same. So
Yes.
we just, yes, sir. So we just go ahead with synchronized non-invasive intermittent positive pressure ventilation. And is there a trials which compare synchronized non-invasive intermittent positive pressure ventilation with outcomes of intermittent mandatory ventilation, which is, we all know it is it's an invasive one, but there are little tiny premies where they have little bit of flow only, or the volume which may not be the impedance, thoracic impedance or the flow, they may not produce adequate enough to get the trigger of through synchronous non-invasive positive pressure ventilation.
Yes, I'm sorry, but I didn't understand.
Basically,
there is an echo that amplify everything. I don't know why.
Basically, our question is, after CPAP failure, is there any comparison between synchronized NIPPV and invasive mechanical ventilation about the outcome?
So no. Yeah. So I showed you that before the paper of Luna that it was possible to avoid to 60% of his patient the invasive mechanical ventilation is shifting from nasal CPAP. The baby was failing, and he used the synchronized ventilation as rescue therapy. And in 2/3 of these babies, mechanical ventilation could be avoided. And there are data from the meta-analysis of IRA, and also there are two previous meta-analysis to Cochrane's. All of them reported that there is really the hope that that the BPD, the rate of BPD decreases with this technique. But I think this is normal because this ventilation respects the physiology of the baby, and these things doesn't happen with not synchronized. What I said before, who would use not synchronized invasive ventilation today? No one. But so the problem is exactly the same.
Sir, is there a trial where you had compared flow sensor versus thoracic impedance, which we are using head-on trials for synchronized non-invasive positive pressure ventilation?
Sorry.
Flow sensor versus thoracic impedance.
We use the flow sensor, but what you asked me, sorry, I'm really sorry.
Okay.
Can you, the chairman, can you, I listen better to the chairman, not from your, the chairman, if he could repeat the question.
Sir, thoracic impedance, you are using a synchronized non-invasive positive pressure ventilation. You had showed two of your studies where you had used flow sensor, yes, and thoracic impedance, the other one. So, is there any trials which shows any difference between flow sensor versus thoracic impedance? As a trigger.
Yes, understood. No, we never did the comparison. We know that the thoracic impedance, you know that the Grasby capsules is many years that is on the market, but it's well known that it's not very reliable. It's good for research, but because you can stay, but you have to stay close to this device because if you use for a long time, that could be a problem, and it's not very reliable. So this is the reason why. Otherwise, it's so simple device that everyone, all the ventilators could have this device currently. But why all we try to find another solution with flow sensor, and there is the NAVA. So there are attempts to increase the efficacy of the devices because the Grasby capsule is good, but not so good.
Sir, and volume guarantee with synchronized non-invasive positive pressure ventilation, volume guarantee added on with your synchronized one, like HFOV we are doing with nasal HFOV with volume guarantee. So something like that. Is there a trials?
The problem in the non-invasive ventilation is that we never know the volume. Is because the expiratory volume, there are leaks, from especially during the expiratory phase, leaks from the mouth. As you know, that the tidal volume is measured during the expiratory phase. So it's currently it's impossible to know the tidal volume. Now, I don't know, in the future, now there are new tools to see the expansion of the lungs by electrical tomography or something like that. Perhaps one day will be possible to know the volume also during non-invasive ventilation. But currently we don't have this chance. But we have seen that in any case, due to the leaks, the direct barotrauma is less. In any case, there is the possible for an overflow to leaks to leave the airways from the mouth. And so we never reported an higher incidence of air leaks with this technique. This was underlined in many papers. Also, if we don't know exactly the expiratory tidal volume, this is, I think it's a very difficult challenge for the future, and that I suppose that will be resolved by electrical tomography or something like that. But in any case, if you use the parameters in the range from 10, 15 to 25 centimeters of water, we never had problems with air leaks.
Thank you so much, sir.
So sorry for my difficulties.
Sorry for the last language.
It's the microphone, I think, your microphone. Okay.
Okay, thank you, Professor Moretti. It was a very nice experience hearing from you about synchronized NIPPP, which is your passion itself. Okay, thank you so much.
Thank you very much.
Thank you, Professor Moretti and Professor Pradeep Dibatta. Next, we move on to a talk on nitric oxide for term and late preterm infants by Professor Carlos A. Fajardo from Canada. And we have Dr. Leslie Lewis as the moderator for the session. He's the professor and head of pediatrics, unit head neonatology, Kasturba Medical College, Manipal. He has over 20 years of experience in teaching in neonatology for UG and PG students. With much joy, we welcome Dr. Leslie Lewis to the dais and humbly request you to introduce the speaker to the audience.
Good afternoon, everyone. Hypoxic respiratory failure is very common in the neonatal intensive care unit. And we use conventional ventilation or high frequency ventilation. And when we fail, we look into nitric oxide, inhaled nitric oxide. The molecule of the year 1992, and then further research in this area, researcher has got the Nobel Prize. And for the last 2 decades, inhaled nitric oxide is available in the most of the intensive care unit for managing the hypoxic respiratory failure. We have to highlight on the evidence of using inhaled nitric oxide in a term, late preterm babies, and maybe extended to our preterm babies. We have an expert in this field, Professor Carlos Fajardo. He's a clinical associate professor, Calgary, Alberta, and he's a specialist in pediatrics, neonatal, and perinatology. He has a wide experience of using the nitric oxide, as well as a lot of papers has been mentioned about the inhaled nitric oxide. So without much delay, I request Professor Carlos to start his presentation.
Well, thank you very much for your kind invitation to the 13th Annual National Conference of Indian Academy of Pediatrics Neonatology Chapters. I would like to share my screen. And I wonder if you can see the slides.
Yeah, slides are visible.
Okay,
and audio is also clear.
All right. Well, it is indeed an honor to be part of this meeting. And I would like then to talk about inhaled nitric oxide, as I said, for term and late preterm infants from a historical perspective. The story of nitric oxide resembles, in my opinion, the Cinderella story You might be familiar with that story because it came from a toxic gas precursor of acid rain, the structure of the ozone layer, carcinogenic, to what was considered to be a marvelous medication. So let us look at the first part of this one. So from toxic gas to carcinogenic. So for more than 5,000 years, we know that inorganic nitrate and nitrate has been used for the preservation of food. But it was not until the 19th century that we discovered that food preservation is due to the conversion of nitrate to nitrite by bacteria. And nitrate in meat greatly delays, among other things, the development of botulinum toxin. In the 1970s, there became a major public health concern regarding nitrate when there was an indication of endogenous formation of N-nitrosamines from nitrate and nitrate and its relevance to human cancer. The first report in the 1950s on the hepatocarcinogenic effects of this N-nitrosodimethylamine or NDMA ignited an enormous interest in these compounds and their association with the cancer. And since the early 1980s, there has been numerous reports in these associations and human cancers. Recently, Pizzetti, in the year 2022, did a meta-analysis looking at nitrate and nitrite in water and the risk of cancer. They found 9,835 reports, of which 111 studies were reporting in health outcomes. But 60 only were the ones reported specifically in cancer outcomes, the majority of them case control and cohort studies. So when looking at meta-analysis in these studies, there were not any that shows any relationship, but 4 studies that has positive association with gastric cancer, in which the odds ratios of R were 1.91 and per 10 milligrams per liter increment in nitrate ion. Before 1978, we didn't know that there was endogenous synthesis of nitrate and nitrate. And it was not until that year that Tannenbaum, in an article in Sciences, reported his study in 6 adults in nitrate study balance. Those patients had protein-free diet for 10 days. And as you can see in the table of that paper, table 1, the urinary nitrate in subjects consuming protein-free diet was very erratic from day 1 to day 10. You can see that the values are very different and very variable between the individuals and among the individuals. And that is not really what you would expect. There is not clearly a tendency of equilibrium. And the expectation, of course, is what you would expect to have a value that is lower than what is consumed. And in table 2, you can see that the intake is lesser than the excretion through the urine. And since urine nitrate is apparently unrelated to the protein intake, one wouldn't expect that the level of the nitrate was related to the muscle catabolism. And therefore, the most likely source of this one is going to be the intestine. And so because of that, in the same paper, he presented 8 healthy adults, the 25 to 40 years of age, in which they collect fecal samples after a Western-style diets. And 6 25 to 30 years of age, healthy individuals as well, who happens to have a total colostomy for ulcerative colitis 2 years earlier. And it took ileostomy effluent samples from them. So in table 3, we can see the nitrate and nitrate levels in the feces and intestinal contents. There is a great variation found in the individuals, as you can see here. All samples contain nitrate, but non-ileostomy samples contain nitrate, and only 5 of the fecal samples contain nitrate. So that is a very interesting factor, because the absence of nitrate in the ileostomy samples, in the presence of such a high concentration of nitrate, as you can see here, indicates that is synthesized from a more element or reduced nitrogen compounds. So we know now that nitric oxide is a small, simple, and highly toxic gas that is odorless, by the way. And in the presence of oxygen, it will give you nitric dioxide, which is a very toxic compound. And nitric dioxide, in the presence of water, give you an acid nitric, which is a very corrosive acid. The speed of reaction between nitric oxide and oxygen is usually slow, with an average time of 1,000 hours, but increased many-folds in the presence of oxygen, ozone, I'm sorry. That will decrease that one to 18 seconds. Now, we have nitric oxide, let's say at 10 parts per minute in air. 50% of that will be converted to nitric oxide in 7 hours. So the importance of that really is that nitric oxide is a very toxic gas, that if you have it in the environment between 200 to 700 parts per million, it could be fatal. It could make you demise. But if you have short exposure between 60 to 150 parts per million, it will give you irritative cough only, but a long exposure will give you ARDS, cyanosis, pulmonary edema, metahemoglobinemia, and seizures, among other things. Now, despite of that one, it has a tremendous biological roles, in not only in the immune system, not only as a neurotransmitter, but obviously a vasodilator. And as the chairman was mentioning, it is one of the most important messengers molecules, to the point that the prestigious journal Sciences make it the molecule of the year in the year 1992. Let's go back then to how that become a reality and knowledge that now we have. And it was really in the year 1953 when Fortschott and Badracom found that acetylcholine that in animals in vivo will produce vasodilation, as well as in organ preparations, and did in the rings of aortic muscle produce, on the contrary, a vasoconstriction. So, and that was the norm, and what was found by the majority of the researchers, with some exceptions. And one of those exceptions occurred in 1980, in which by one of the technicians of Dr. Fortschott, a laboratory not following the instructions that were given to him, found that the acetylcholine and carbachol produce immediately vasorelaxation in those strips and rings of aortic aorta. So that was very intriguing, and that response to muscarinic agonists lead basically to look at how now is producing the same effect that is produced in vivo. And that is what really led to the very famous paper, Fortschott and Sadwansky, in which they look at the rings, aortic rings or strips, in which they rubber the intima surface of the vessel, okay, and they found that there was no relaxation, as you can see here, in acetylcholine, and only after the washout there was a relaxation. And if you use it collagenase as well, you will have the same effect. But if you don't rubber the strips or don't treat with collagenase, you will find immediately the relaxation that was the serendipitous finding that was previously found. The other thing that is important is that there is a relationship between the percentage of relaxation of the strips or rings and the production of cyclic GMP that was found for Foucault by Monrat specifically, and by Ignaro and many others investigators there. So now we know that the endothelial-derived relaxant factor, which was the name that Foucault gave to this effect that he found in the paper in 1980, is nitric oxide. And that was mainly found by Ignaro initially, but followed very shortly by papers by Palmer, Moncada, and Foucault and Kahn. So the release of nitric oxide now we know is responsible for the biological activity of the EDRF. And that is what you were mentioning before as well, which is that in October of 1998, the Nobel Prize in Physiology and Medicine was given precisely because of the research given in this molecule as being a key molecule for the cardiovascular system. And it was given to Dr. Murat, Dr. Foucault, and for Dr. Ignaro. Dr. Murat basically established the nitric oxide cyclic GMP pathway. And that it was very important part of the puzzle that was on there. And Dr. Foucault, as mentioned before, was the one that discovered the endothelial-derived relaxing factors. And Ignaro, which was the first one to recognize that EDRF was indeed nitric oxide. And that then established from there on that the mammalian cells do produce nitric oxide. Now let's look at what happened after. Then the discovery of the synthase of nitric oxide, that there are two of them, constitutive and inducible one. There are three isoforms, and what they do basically, they all bind calmodulin, and they all have parts in their structure. That really leads to arginine in the presence of oxygen to the production of citrulline, another amino acid, and nitric oxide, using several cofactors like NADPH or FAT or FMN. So there are the two types of synthetases, constitutive found in the neurons, or NOS or NOS1, and the endothelial cells in NOS or NOS3. And they're activated by camodulin and calcium. And they, in the neurons, is producing the central nervous system and in neurogenic neurons. And they really control and has a lot of effects in what is the plasticity of the synapses, as well as central control of the blood pressure, among other things. The endothelial cells, NOS, is mainly found in the endothelial cells, and it really controls blood pressure systemically and locally. And as well, it has a lot of effects of anti-atherosclerotic effects. An inducible one, which is produced mainly in the macrophages and Kupffer cells in the liver, many other cells, it really is active when it's produced, and produce a much greater amount of nitric oxide that is going to be induced by elements or substances like lipopolysaccharides or cytokines, and that it produces effects basically leading to the destruction of these cells and carcinogenic cells and parasite cells. So it is very important for the immune system, and as well is important in the generation or part of the pathophysiology of the inflammatory processes and the septic shock. Now, this is basically, if we how it's being produced, really is just a cartoon showing how the L-arginine through the nitric oxide synthase lead to nitric oxide will diffuse rapidly to the small muscle cells, and acts in the cyclic GC, and that will increase the cyclic GMP, and then producing relaxation. There is, of course, a regulatory mechanism through the phosphodiesterase. And all the nitric oxide that goes into the blood is going to be captured rapidly because it has a great affinity to the hemoglobin, and then will be converted into nitrate and nitrate that will be eliminated through the body. Now, this is, if we give it exogenously through the airway, then it's a very important selective pulmonary vasodilator. Basically, that one and prostacyclin are the other two. And it's been used in the clinical field since 1991. First for Kepke and Sava in 8 adults, and then next year by Roberts in basically pediatric patients with congenital heart defects, and at 80 parts per million. And in 1992, John Kinsella used it in 1 newborn baby, and next year in 9 ECMO candidates. And in 1993, Steve Affman from the same group basically used it in a premature infant of 28 weeks. So in 1993, we start some animal studies in Winnipeg, in Manitoba, and using inhaled nitric oxide, which lead us to use the nitric oxide in our patient as a descriptive study. This is the setup that we have. And I'm going to show you roughly what that is in a more cartoon type of picture. You have the nitric oxide tank, and what we used was 1,000 parts per million balanced nitrogen. And we have a very low flow meter, and give the gases into the gas inlet of the ventilator. By joining that one, we decrease the concentration, and then with a little pump here with electrochemical sensors, we measure the nitric oxide value that we reach. And as well, we use the gold standard measurement device, which is the chemoluminescent machine. And then the gases went into the humidifier through the inspiratory limb into the patients. After that, we have an expiratory limb, and because there was a lot of concern about toxicity, that was sent to a vacuum out of the building to maintain the safety of the environment. So this is the descriptive study that we have in 1993 and published in 1996, in which we need to have patients with hemodynamic evidence of pulmonary hypertension that were ventilated, requiring at least 80% of oxygen for 8 to 12 hours. And after maternal or paternal consent, the babies were given inhaled nitric oxide at 20 parts per million. We consider full response when the increase of PaO2 was greater or equal to 20 torrs 30 minutes after the 20 parts per million nitric oxide. Partial response, 10 to 19 torrs increase, and no response when you have less than that or not increase on PaO2. When we have partial response or no response, at that time, we decided to increase nitric oxide to 80 parts per million. And there is one appropriate response, then nitric oxide was to be given only for 72 hours. And these are basically the results. We have 14 babies, 10 infants in NICU and 4 in PICU. And we have full response in 5 patients, partial response in 1 patient, and no response in 8 patients. Here we have the characteristics of the groups in the NICU, and there were 10 patients, of which the responders were 3 babies with congenital diaphragmatic hernia, 1 patient with hypoxia, and 1 with PPHN. The non-responsive or partial responders were 2 premature babies with RDS, 2 babies with meconium aspiration, and 1 baby with PPHN. Here we have the PICU patients in which they were all cardiac patients, and we have no response on them. I like to show you a case presentation just to give you an idea on how that works for us. This is a baby with 3.1 kilogram with an antenatal diagnosis for congenital diaphragmatic hernia. At that time, we have elective induction of term, and we, after being born the baby, intubated the baby. At that time, we paralyzed the baby and hyperventilate the baby, placing, of course, an OG tube, and keep the baby in 100% oxygen. After 12 hours, we found that this baby had a pre-post oxygen saturation that was a gradient more than 10%. So we confirmed PPHN in this infant with a right to left shunt at ductal level, and we initiated inhaled nitric oxide at 20 parts per million. The baby went to the OR in nitric oxide, was stable during and after surgery. And in this graphic, you can see on the left axis, the concentration of oxygen and the PaO2. Then the right axis, which is a logarithmic axis, we have the nitric oxide, which are the three things that I want to show you, basically. So you can see that prior to the nitric oxide, okay, here, this baby had a gradient between the pre and postductal PaO2. That was great. The baby was in 100% oxygen. And once we initiated nitric oxide at 20 parts per million, the gradient between the pre and postductal PaO2 decreases and narrowed it down till it disappeared. And the FiO2 at the same time went down, as you can see here, from 100% to some 34%. We'll continue treatment of this baby, and at 3 days we needed to stop that one. So we went down to 3.6 parts per million of nitric oxide, and then we discontinued it. But that was with the price of increasing FiO2 and the decrement in the PaO2. Therefore, we reestablished nitric oxide, generating a decrement in the oxygen concentration. And this is finally another attempt to discontinue unsuccessful. Then we went down to 1.5 parts per million. And finally, we discontinue the nitric oxide with some increase in oxygen, but was successful there. So the baby was discontinued after 14 days, as mentioned here, extubated at 20 days of age, and oxygen was given for another 7 days. The baby went home without any problems. So after that one, then we did in Canada a study called the CINOS study, which is Canadian Inhaled Nitric Oxide study by several universities throughout the country. And the American counterparts was generating as well a study. So we joined forces and created the NINOS study, which is the nitric oxide, North American nitric oxide study. So, and the aim was basically to evaluate the ability of nitric oxide to prevent death or initiation of ECMO in those babies, term or near term, that has hypoxic respiratory failure and responsive to intensive conventional therapy. We administer nitric oxide. That was the hypothesis in those infants that has hypoxic respiratory failure with OIs greater or equal to 25. And we aim to reduce the death before 120 days or discharge home, and or the need for ECMO from 50 to 30%. And our secondary hypotheses were that the administration of nitric oxide would change the parameters in benefit of the baby, increasing the PaO2, decreasing the OI and AABO, etc. And there were not going to be any deleterious effect, like no changes in the ventilator, no pneumos, BPD, and neurodevelopmental outcome at 18 to 20 months will be no difference. So this is the inclusion criteria. The baby needs to be intubated, ventilated, has severe hypoxia. We didn't require echoes to prove PPHN because of the nature of the study. And we have 2 OIs at greater or equal to 25 within 30 minutes. We have parental consents. And this is kind of the flow that we have. So an eligible patient we were giving 20 parts per million of nitric oxide or a low flow oxygen, depending on what the randomization put the baby into. Then we repeat the arterial blood gases 30 minutes after, and if the PaO2 was greater than 20 parts, then we'll continue at 20 parts per million or low flow oxygen. If the baby did not respond that way, either partial or no response, then the study gas was discontinued. We have a second arterial blood gases, and then we increased to 80 parts per million or high flow oxygen and took another gases. So if the baby had gases that it shows us more than 20 torrs, in other words, a good response, then, and the initial response to 20 parts per million or low flow was either no response or partial response, we continue with 80 parts per million. If on the other hand, you have a partial response in the second high flow or 80 parts per million, then if there was no response in the initial 20 parts, then we'll give 80 parts. But if it was a partial response, the same as 80, well, we use 20 parts per million low flow. And if there was no response in the lower, in the higher flow or 80 parts, then no response in the first one, then we'll discontinue the study gas. But if it was a partial response in the 20 parts per million or low flow, then we'll continue at that. This is basically the patient's characteristics showing that they were similar in those parameters that you can see here: birth weight, gestational age, outborns, male, etc. The admission to the study was in the majority of babies, around 50% in less than 12 hours, and similar in control and treatment group, as well as the upper scores were very similar. The primary diagnostic was no difference between the control and treatment group, with most of them being meconium aspiration syndrome, and the others divided between PPHN, RDS, and pneumonia sepsis. The babies received volume, vasopressors, and sedations in a high percentage, and some of the babies received tolazoline, systemic vasodilator found at that time. And majority of babies received muscle paralysis, alkalosis, and surfactant. That was the way we used to treat these babies, and around half or a bit more than that were ventilated with high-frequency ventilation. There was conditions prior to treatment that were very similar in them in terms of pneumos or hemorrhages. And the ultrasound abnormalities was similar in all of them. And the intracranial hemorrhage was found a bit more in the control group, but there was no statistical significance. And this is the condition of treatment. As you can see, the age of a star was similar in both groups. The arterial blood gases and the treatment of these babies were very similar. And you can see here that the OIs are 45 average in both groups, which tells you that those babies were very ill, and obviously some of them really already in ECMO possibilities. The results are here. I'm going to start with the secondary results, in which you can see that the change in PO2, change